All right. We'll kick this off as folks are still kind of dialing in, but I've got 10:01 just to kind of keep us on schedule here. So good morning, everyone. My name is Matt Pickering, like I said, from Battelle. Thank you all for joining the meeting today. This is the Spring 2024 Cost and Efficiency Endorsement meeting. Also joining me on the call, who you'll see also facilitating with myself, but also presenting various times today, are my colleagues Meredith Eastman, who is our primer or pre-rulemaking measure review and measure set review task lead. So handling that work, other aspects of what we do here as a consensus-based entity. Myself being the endorsement maintenance task lead. We have Anna Mickey, who is our deputy endorsement maintenance task lead. And we have Isaac Seichi, who's our social scientist today. So you'll see their faces pop up here and there throughout the day, along with myself. If you have joined as an attendee and you are a recommendation group member, you will see on the platform that you will not be able to mute or unmute yourself. So if you are on the attendee side and a recommendation group member and you have not had the ability to unmute yourself, please raise your hand. We will promote you over to the panelist side so that you can go ahead and freely speak and be part of the discussions today. This also goes for any developers that are on the call that will be speaking on behalf of the developer or representatives of them. If you are joining as an attendee, you will not be able to have the features of muting and unmuting yourself. So please raise your hand and we'll definitely promote you over so you can do that. If you're on the panelist side, you're fine. You should be able to mute and unmute yourself. You should see that at the bottom of your screen. So you're good to go. And we'll continue to check in on that as we proceed today. Okay, so let's go to our next slide. So again, welcome to this call. And I do want to thank all of our committee members for their time today, for contributing to the discussions ahead of us on the measures up for review, of which we do have 6. And also thank you to our developers as well, who will be on the call to both listen to the discussions, but also to answer any questions that you may have. And we'll go through that, how that process will work here in a little bit. And of course, thank you to the Battelle team for all of their work this year. This is the last meeting we've had, meeting number 5, starting last Friday. So the team has been doing a tremendous job on those other meetings, which have gone very well. So, but to also join me today are 2 co-chairs. We have Danny Van Leeuwen, who is our patient co-chair for this cycle. And we also have Amy Chin, who is our non-patient co-chair. So I will give them an opportunity to provide welcoming remarks to set us out today. So Amy, I'll go to you and then we'll check in on Danny.
Sure. First, I want to thank everyone for showing up today. But beyond that, I just want to express our appreciation for all the hard work that we do to vet and review these quality measures. I know it's a lot of work, but it's important work in order to drive forward quality. And we're just excited to be here. Thank you.
Thanks, Amy. And Danny, I see your video is on. Awesome. Go right ahead if you'd like to give some opening remarks.
Sure. You know, I thought I knew the complexity of measuring costs before I joined this group in like 2000. And now I can say for certain that I had no idea. I've always had this quiet voice on my shoulder that kept asking me, so what? You know, how does the measure under consideration help patients, their caregivers, and clinician partners compare and choose providers of care? And how does it help all stakeholders use measured data longitudinally to inform change? And I really encourage everybody on the call to remember back when you first realized that health was fragile and consider that time during these discussions. I look forward to our sessions today. It's great. Thank you.
And thank you, Danny. And thanks for that messaging as well. Always good to keep that in mind. Great comments also from Amy as we get ready for our discussions today. Thank you both. And so Danny, like I mentioned, our patient co-chair this cycle. We had Mary Schramke last cycle. Unfortunately, she is not able to be active this cycle. So appreciate Danny for stepping in to be our patient co-chair for this cycle. Thank you so much for that. Before I proceed, Chris, you have your hand raised. I'm not sure if you have a question at this moment, or is that maybe a leftover?
Just want to make two comments in public. I found your staff reviews excellent. Okay, it's the best I've seen, and I don't know if it's confirmation bias on my side. At any rate, I thought it was excellent, and commensurate with that, the slide deck is excellent. It flows very nicely. It hits all the key points. So really nice job. Okay. And I have some questions later regarding not met, but addressable, but we'll get to that when you talk about it. That's it.
Yeah, of course. And thank you for the comments, Chris. The staff did really do a lot of work preparing for this, obviously. I appreciate those. And I will just state, the staff assessments are just preliminary. It's really going to be up to the committee to discuss and review. Again, noting that the developer's on the call to answer questions for clarification, et cetera, and we'll talk through that process. And Michiel, I know your hand was raised and you dropped it down, but Chris, you still have a leftover. Okay, great. Well, definitely we'll have some space for some questions as we proceed today, but thank you, Chris, for calling that out as well. And Michiel will definitely have an opportunity for some questions before we get into the meeting or the evaluation of the measures. Thank you. Okay. All right, let's continue moving forward, going to the next slide. So for our agenda today, after we did the welcome here, we'll review our meeting objectives and ground rules. We'll then go over our roll call, disclosures of interest. This is where we'll establish our quorum thresholds, and obviously reviewing any potential disclosures that result in a conflict that would recuse any member from voting. So prior to this meeting, and weeks ago, we were sent a link to an online measure disclosure of interest form, just asking if you've had any relationship with the measure developer, if you've had any involvement with the development of the measure in any way. We try to identify those for spirit of transparency. If you had any conflicts, we'd ask you to disclose those. And again, under our process, if those conflicts result in any recusal, that's just recusal from voting. So you can still discuss the measure, but you would not be able to vote. But our colleague Isaac Safety will go through that when we get to that agenda item. After that, Anna Mickey will take over and she will provide an overview of the evaluation procedures and the measures for endorsement consideration. So this is where we'll talk about the flow of how we will proceed through the day, especially recognizing various different stakeholder groups that we have. We have some subject matter experts that will be in attendance today to help support some of the discussions. So really calling attention to them and thank you for their time. And also we will have our patient partners and time for them to express any questions they have, and also thinking about the value of these measures to the patient community. Are they meaningful? Are they important? So we have a few of our patient members, and of course, Danny Van Leeuwen being our patient co-chair. After we go through that, we'll then do a test vote. So about 9 a.m. Eastern this morning, you were sent an email to in your inbox from noreply@voteer.com. That is VOTEER.com. You're more than welcome to look through your emails now to see if you have it. You were sent a personalized link. So when say personalized, do not share that with anyone else. Please do not drop those links into the chat. These are just sent to you. You're more than welcome to click on it, open it up. This test vote portion of the agenda is not anything about endorsement. It's not going to ask about endorsement. It really will just ensure that you have that system up and running. We'll do some troubleshooting during that time. And if you cannot find that link, you can definitely drop us a message in the chat, or you can come off mute and say you can't find it. We will direct message you that link so that you can make sure that your vote is up and running. After we go through the test vote, we'll dive right into the evaluation of the measures. And I mentioned, again, we have 6 that we'll be going through today. 4 of those 6 are very similar, as you all probably have reviewed those 4. They are very similar measures, so we may kind of go through those a bit quicker, but just keeping in mind that for consistency and thinking about how we evaluate these measures. Lastly, once we go through all of the measures, we will have some opportunity for any additional recommendation discussions if the committee wishes to have those. Now, this is not an opportunity to revisit the measure decisions and open the measures back up for endorsement. Here, it's just to elaborate more on potential recommendations. These are not conditions we would then add to the measure. These are really just thinking about any additional suggestions or clarifications that you find would be helpful for the developer. And again, we have if time permits. So it is, full day meeting. If we need to use the time all day to review the measures, we'll skip that agenda item and go to next steps and then adjourn. In addition, if the committee does not have anything to propose or suggest or clarify further, we can definitely skip that as well and go to next steps and then adjourn. Go to the next slide, please. Our meeting objectives for today. So we will review the measures that were submitted to this committee for the spring 2024 cycle. We will consider, as part of that process, the comments received from our advisory group members, public comment, the developer responses, and also our staff assessments, and even some of the inputs that we have received from our recommendation group members that reviewed the measures and submitted their reviews prior to this meeting. So thank you all for doing that. We then will conduct voting on those measures and render an endorsement decision via that vote. Go to the next slide, please. So just a few housekeeping reminders. So if you are a panelist, you have the ability to mute and unmute yourself. So we kindly ask that if you're not speaking, to keep yourself on mute. We also ask you to raise your hand, and we can definitely, as facilitators, recognize you and call you to participate and ask questions or contribute to the discussions. Please use your video feature too. This is a very engaging type of way we can keep the committee engaged with these virtual meetings like this. So we ask you to use your video when speaking. It also allows the developer to kind of get a sense of who was it that was really speaking, as well as sort of searching through the list of names. We can actually see the faces of those individuals. So please use the video, especially when speaking. And also feel free to use the chat. Now we will encourage you to share any comments or questions verbally, but obviously if there's a lot of discussion, we have to keep moving. You're more than welcome to drop something in the chat, especially if it's something you agree with, if it's something that you don't have any concerns about. That helps us as facilitators know if there's some consensus from those that maybe aren't voicing up as much, or there's a lot of discussion, we have to keep things moving. We ask that please drop things in the chat, like I agree, or I have no concerns. That is helpful for us as facilitators to know when we can start to move on. And then also, if you're experiencing any technical difficulties, you can email pqmsupport@patel.org, and our team will be monitoring that and assisting you through any of those challenges. Okay, next slide, please. So just a visual of the Zoom platform. Now that I know Zoom has had an update since these slides were generated, but the functionalities and where they're located are very similar. So again, for a panelist, on the bottom left of the screen, you'll find your ability to mute and unmute yourself, as well as the video feature towards the center. You then can pull up the participant list and see who's on the call, as well as the chat feature. And then you can also find your raised hand as well. And the next slide is just the mobile version. Very similar type of setup from left to right, the mute and unmute with the video feature, plus the participants, and then opening up more options for chat, etc. And as I mentioned at the opening of the call, if you are a recommendation group member and you joined as an attendee, you are not seeing those abilities to mute and unmute yourself. So please raise your hand and we will promote you to become a panelist. And this is also for developers that may have joined on the attendee side. Let's go to the next slide. So just some ground rules. Obviously, we convene various different perspectives, various different opinions, those who have various different expertise, lived experiences, etc., to these meetings to really be very collective on the input that we have. So we kindly ask that you respect those opinions, respect all voices here, and encourage you to share those experiences. You are sitting on this committee and representing you as yourself as an expert in any area. But there's also where you work, and even though you're not representing that organization, we do ask you to share the experience based on that. It is helpful to consider in some of these discussions. We also ask that you keep your comments concise and focused. That's why encouraging to use the chat if needed when you agree with something or you have no concerns with something. If somebody is saying something that you also have a question about or similar topic, you don't have to repeat that. You can kind of just again agree with that. And again, facilitators. We appreciate that so that we kind of know where the committee is coming from or where they're landing. We want to base your evaluations, yes, on your experience, but also on the measure evaluation rubric, and our staff will be here to draw attention to that as needed. And remain engaged and actively participate. And that means being prepared prior to the meeting by reviewing the materials and then also being ready to engage in the discussions. Okay. And ultimately, we do learn from others. We've had a lot of really good learnings these past few days with the other meetings, so looking forward to doing the same today. Let's go to the next slide. So just recognizing our project team here, great members listed here that have contributed to various different aspects of this work. So there's also members that are not listed on this slide that are on the back end that do a lot of assistance with us. So just drawing attention to a lot of great work of this Battelle staff and team for these endorsement meetings. Let's go to the next slide. Okay, I'll turn it over to Isaac, who conduct our roll call and go through quorum, and we can see who is on the call for attendance. So Isaac.
Thanks, Matt. Can we go to the next slide? There are two quorum thresholds that are important to note. First, we have meeting quorum, which is 60% of the recommendation group members present during roll call at the beginning of the meeting. That number is 13 for us to discuss the measures. We also have voting quorum, which is 80% of the active non-recused members of the recommendation group, which is 17 for today's meeting. Let's move to the next slide. Prior to the meeting, we asked you to complete a measure-specific disclosure of interest form, which contained questions pertaining to any involvement you may have had with the measures under review for the spring 2024 cycle. We collect this information in the spirit of openness and transparency. Please note that since recommendation group members will be voting, if a disclosure results in conflict, you will still be able to discuss the measure, but you will not be able to vote. I will now go around the virtual table, and when I call on you, please state your name, any affiliation you've had, and any disclosures you identified on your form. If you did not disclose anything, you can state, I have nothing to disclose. Starting with Amy Chin.
Amy Chen with the Hospital for Special Surgery. I have no disclosures.
Thank you, Amy. Mary Shremke. Alice Bell.
Alice Bell with the American Physical Therapy Association. I have no disclosures.
Thank you, Alice. Benjamin Schleich. Christopher Desi.
Chris Desi, Healthcare Quality Advocacy and Strategy Consultants, no disclosures.
Thank you, Christopher. Danny Van Leeuwen.
Yeah, hi, Danny Van Leeuwen. I have no disclosures.
Thank you, Danny. Daniel Halaby.
Dan Halevi, Health First in New York. I have no disclosures.
Thank you, Dan. David Schultz.
Hi, I'm Dave Schultz, American Academy of Family Physicians, and I have no disclosures.
Thank you, David. Dmitry Pozniak.
Dmitry Pozniak, Mathematica, no disclosures.
Thank you, Dmitry. Hal McCod. Kimberly Jeffrey.
Kimberly Jeffrey, I have nothing to disclose.
Thank you, Kimberly. Mahil Sanatharaja.
Mahil Sanatharaja with Truven Meredith Analytics, no disclosures.
Thank you, Mahil. Marissa Elliott. Megan Gwynn. Pamela Roberts.
Pamela Roberts, Cedars-Sinai Medical Center, American Occupational Therapy Association, no disclosures.
Thank you, Pamela. Paul Kalur.
Paul Kalur with the Center for the Study of Services and Consumers Checkbook, and I don't have anything to disclose.
Thank you, Paul. Pranavi Suramoju. Rosa Placencia.
Rosa Placencia, Advancing States. I don't have any disclosures. Thanks.
Thank you, Rosa. Sandeep Das. Sapita Andronako. Sunny Jamnani.
Sunny Jamnani, cardiologist, no disclosures.
Thank you, Sunny. Tara Heidbrink.
Yep, Tara Hybrink with Sync Health, no disclosures.
Thank you, Tara. If any of our recommendation group members joined and missed the initial roll call, please unmute yourself, state your name, and indicate if you have anything to disclose. And if you also happen to be on the attendee side, please raise your hand so we can promote you to panelists so you can unmute yourself. Next slide. While we confirm attendance, I'd like to recognize Dr. David May and Dr. Tariq Hughes, who will be our subject matter experts for these surgery measures. We also have Dr. Maurice Hamilton and Margarita Lapson, who will be our subject matter experts for the home and community-based services measure. Starting with Dr. May, if you're on the call, please introduce yourself and indicate if you have anything to disclose.
Thank you, Isaac. David May, I'm a general surgeon by training, work with Jefferson Health, no disclosures, thanks.
Thank you, Dr. May. And I believe we have Margarita on the line. Can you introduce yourself and indicate if you have anything to disclose?
Margarita Lapson, I have no disclosures.
Thank you, Margarita. And checking in on Dr. Hughes and Dr. Hamilton. All right. It appears we have 14 active recommendation group members on the call, so we can proceed with the meeting and the discussion of the measures. I will now turn it over to my colleague, Anna Mickey, to go over the evaluation procedures.
Wonderful. Thanks, Isaac. Good morning, everyone. Okay, so there are 6 major steps of the endorsement and maintenance process, and there were a few enhancements implemented during this spring 2024 cycle that I'll highlight as I discuss the workflow. So each cycle begins with intent to submit, where measure developers provide some basic information about their measures, so the specification, the level of analysis, and about a month later, measure developers will then provide their full measure submission, which includes information about evidence, testing, and measure use. From there, the Battelle team will conduct completeness checks, which reviews the application to make sure that attachments were submitted correctly and all of the applicable information is present. We then move on to the public comment period. And during this cycle, that is where we introduced 2 new enhancements. So first, in addition to offering a written public comment period, we offered a virtual public comment listening session where members of the public could call in and provide their verbal feedback for any of the spring 2024 measures, offering more flexibility and opportunities for engagement. And after the last cycle, advisory group meeting members expressed the importance of having meaningful opportunities to participate in the process, as they had been previously excluded from speaking during the endorsement meetings. And so to address this, we implemented separate advisory group meetings to collect input directly from advisory group members prior to these endorsement meetings, ensuring broader participation and contribution to the consensus building process. Measure developers were also invited to the advisory group meeting to answer questions from the advisory group. The Battelle staff has summarized input from the advisory group, staff assessments, public comment, and responses from measure developers, and you'll see those included in your discussion guide that will be used for today's meeting. Next slide. So we are currently at the E&M committee review step of the process, which is highlighted in yellow here on the screen. And during today's endorsement meetings, the recommendations group will discuss the combined feedback, again, as summarized in the discussion guide, and render an endorsement decision via a vote. Importantly, during today's meeting, only the recommendations group will vote on the measures. Advisory group members are welcome to listen into the conversation, but the discussion and the voting will be only within the recommendations group. After today's meeting, the Battelle team will produce a summary, which includes final endorsement decisions that will be posted to the PQM website. We'll then move on to an appeals period, followed by posting the final technical report for spring 2024. Next slide. Okay, so in terms of how today's meeting will proceed, first, the Battelle facilitator will introduce each measure, reviewing basic characteristics about the measure, such as the description, target population, and level of analysis. Next, developers will have the opportunity to provide an overview of and additional commentary about their measure for the committee's consideration. We kindly ask developers to limit their commentary to no more than 5 minutes. The Battelle facilitator will then cover the key discussion points shown on the key discussion points slide. These discussion points, again, were developed based on the synthesized feedback from public comment, staff assessments, and the advisory group, as well as developer responses, all which can be found in your discussion guide. Just a quick note that we have included slides for staff assessment, public comment, and committee independent review within the slide deck, but those are references. We'll not be reviewing those slides as we'd like to leave time for committee discussion. The Battelle facilitator will then ask any of our invited subject matter experts to share their perspectives about the topics listed for each measure. So as Isaac mentioned, we do have a couple of subject matter experts on the line here today. We have David May, who will be the subject matter expert for CBE 3357, 3366, and 3470. We have Tariq Yus, who is the subject matter expert for CBE 2539. And then we have Morris Hamilton and Margarita Labson as the subject matter experts for CBE 4490. Once the subject matter expert is done, we'll then turn to our patient partners to hear their thoughts and perspectives on the measure. And then we'll open up the discussion to the larger group. And during the conversation, we do encourage committee members to consider the discussion topics on the slide, but please note you are not limited to these. Feel free to explore beyond these topics. Additionally, I'd like to highlight 2 procedural details for the discussions today. First, as measure questions come up, we really want to keep the conversation within the committee to the extent possible, instead of frequently calling upon the developer. If there is a topic that requires clarity, the developer is on the line, and the Battelle facilitator may call upon them to speak. Additionally, toward the end of the discussion, developers will have the opportunity to address topics that have come up before we proceed to a vote. Second, we are not asking the committee to identify conditions during today's discussion. We would like the committee to focus on the topics of discussion rather than determining what may or may not be a condition. Instead, Battelle staff will be listening to the discussions and capturing potential conditions that may be placed on a measure for the endorsed with conditions category in the background. At the end of the discussion, the Battelle facilitator will share any potential conditions with the co-chairs and clearly state the conditions with the committee before voting. The recommendations group will then move on to vote. It's important to note that if there are no conditions for a measure, that you should not vote for this decision outcome. The endorsed with conditions outcome is reserved only for when conditions have been identified. Okay, I'm going to stop here. If there are questions, feel free to raise your hand. Chris, do you have a question? Christopher?
Yes, does not met but addressable constitute a condition?
Yeah, Matt, do you want to take this?
Yeah, sure. Yeah, thanks, Chris. Not necessarily. It may not always be a condition that we would place on the measure. Sometimes not met but addressable means that maybe there's some more clarification that the developer can provide on something that was identified within the submission. Doesn't necessarily mean that it should be a condition. That's why we wanted the committee to really just talk about the measure, talk about the topics that you may have concerns about or questions about, or the topics that were listed on the slides as we will present those. And then we will be listening to that and then determining whether or not we want to propose that as a condition for the developer and committee.
So then not met but addressable does not mean that if it's not addressed, it's not met.
So that's correct. It could just be some clarification. Some other committee members may also feel that what the developer has submitted or what the submission states is just fine. For example, there were some of the measures today in which there were some not met but addressable based on some of the testing, just for clarification. So that there was other testing the developer did, but we just drew attention to one of the elements of testing just for clarification. It's just meaning that it could be just for clarification purposes. But again, there could be some not met but addressables that require potential conditions. But again, we want the committee to not focus so much on that. We just want them to focus on the discussions.
Wonderful. Thanks, Chris. Thanks, Matt. Anyone else have questions? Please feel free to raise your hands. Okay. All right, let's move on to the next slide. Okay, so patient partner feedback. So this slide includes a few questions that our patient partners may want to consider when providing their input. So for example, does the patient partner have experience about the measure topic that they would like to share? Do they think the measure is meaningful to patients and responsive to individual needs, preferences, and values? And based on their experience, are there aspects about the measure that may be difficult for a patient to understand and would be burdensome for the patient? So these questions are provided as examples to guide your responses, but again, please feel free to explore beyond these suggestions. Next slide. Okay, so this slide shows the 5 domains in our measure evaluation rubric that I'll touch on briefly. So importance is looking at the extent to which the measure is important for making significant gains in healthcare quality or cost, where there's variation in or overall less than optimal performance, and the measure is meaningful to patients. Feasibility is looking at the extent to which the measure specifications, the numerator, denominator, and any exclusions require data that are readily available or could be captured without undue burden. And this is also taking into consideration any proprietary elements of the measure as well as any data availability or capture issues. Scientific acceptability is the extent to which the measure, as specified, produces consistent or reliable results and credible or valid results about the quality of care when implemented. Equity is currently an optional domain, and that is looking at the extent to which the measure can identify differences in care for certain patient populations, which can be used to advance health equity and reduce disparities in care. And finally, use and usability is the extent to which potential audiences, consumers, or providers, or policymakers are using or could use the measure results for both accountability and performance improvement. And so importantly, while these domains are the building blocks of measure evaluation, during today's meeting, we will be discussing and voting on the measure's suitability for endorsement as a whole. Next slide. So just to briefly touch on some of the conditions. So as I mentioned, during today's meeting, Patel staff will be listening in to identify potential conditions that may be placed on a measure for the endorsed with conditions category in the background. To be endorsed with conditions, there should be reasonable certainty that the measure yields a net benefit to entities and persons as is. However, new information would reduce uncertainty and net benefit, and this new information may be unavailable until the measure is used or takes time and resources to gather. So for example, if there hasn't been improvement in the measure over time, the committee may want the developer to explore why with accountable entities. So are there implementation challenges? Is more implementation guidance needed? What are some barriers and facilitators to overcoming these challenges? All conditions will be considered in terms of what is feasible for the measure developers to conduct by measure maintenance. And so importantly, if it is a major change to the measure or it cannot be achieved in the 3 to 5 year time period, then it is not an appropriate condition. Next slide. There are several non-negotiables where the measure cannot be endorsed even with conditions. So for example, if the business case for the measure or evidence supporting the business case is unclear, that is a non-negotiable. The measure cannot be endorsed even with conditions. If there are significant feasibility issues that impact measure implementation or cause significant burden, or if the measure is not scientifically acceptable, so it's not valid or reliable, or if there are inappropriate testing methodologies to demonstrating scientific acceptability within the application. Next slide. So this figure depicts how endorsement decisions are reached based on a 75% consensus threshold. So 75% or more of committee members are required to vote to endorse the measure, to not endorse the measure, or remove measure endorsement. If there is a spread across the endorsed and endorsed with conditions categories shown here in the second row, then the measure will default to endorse with conditions. And if no consensus is received at all, shown in the fourth row, then the measure is not endorsed. Let's move on to the next slide, and we'll talk about the measures that were submitted for the spring 2024. Okay. So there were 6 measures that were submitted to this committee, the Cost and Efficiency Committee, for endorsement consideration during the spring 2024. 5 of these measures are maintenance measures, and 1 measure is a new measure. And these measures are looking at hospital visits after ambulatory surgical center procedures, hospitalization for ambulatory care sensitive conditions, and readmission rates for the MIPS eligible clinician groups. Next slide. So this slide is showing all of our measures that were submitted, in addition to the developer Stewart, the CBE number, and measure title. So our first 5 measures today are the developer Stewart is Yale Core with CMS. And those are CBEs 2539, 3357, 3366, 3470, and 3495. And then our last measure for today is CBE 4490, with the developer steward being the Lewin Group and CMS. Okay, so before we move on to a test vote, I just wanted to again quickly pause. If there are questions about anything that I've covered, please feel free to raise your hand before we move on to our test vote. Okay, I'm not seeing any hands raised or anything in the chat. So Isaac, I will pass it off to you to go through our test vote.
Thank you. As mentioned earlier, we sent an email this morning containing the voting link to members of the recommendation group. So look for an email from noreply@voitier.com, and the subject of the email contains the phrase voting link. Let us know if you can find it, and we will send it to you directly via email. The link you receive is specifically for you, so we ask you to refrain from sharing that in the chat. If at any point you encounter challenges with the voting platform, try refreshing your page or using a different browser. If that does not resolve the issue, you can send your vote directly to me in the chat. Before we move to the vote, I see that Hal McCod, you're on the call. Are you able to introduce yourself and indicate if you have anything to disclose?
Sure, thanks, Isaac. Yes, Hal McCard. I'm a healthcare attorney practicing in Nashville, Tennessee, and I do not have any conflicts to disclose.
Thank you, Hal. That's as we pull up the test question for today. So our test question for today is, what is your favorite vacation destination? And the options are mountains, beach, or the city. And we have 15 active recommendation group members on the call, so we're expecting 15 votes. Let us know if you can't find the link or you're having issues sending in your vote. We have 10 votes in so far.
Dave Schultz, I have the voting link and I'm on it, but it won't pull up the question.
Could you refresh your page? That might resolve that. And if that doesn't work, try a different browser. Google Chrome or Edge Chromium will do the trick. David, I see your vote came in.
Yeah, we're up and running. Thank you.
Yeah. We are expecting one additional vote. Kim, are you able to log in and send in your vote? Kimberly, are you having any issues with the voting platform? All right, we have 14 votes in. We can move forward and we will troubleshoot or reach out to anyone who's having issues with the voting platform. With voting closed, we have 5 votes for mountains, 7 votes for the beach, and 2 votes for the city. That's 1 more than yesterday for the city. I also want to draw attention to the voting outcomes. We have endorse, which applies to new and maintenance measures. We have endorsement conditions, which only applies if there are applicable conditions, and we will summarize those if there are any. We have the not endorsed decision, which applies to new measures only. And lastly, we have removal of endorsement, which only applies to maintenance measures. I'll now turn it over to Matt to introduce our first measure.
Thank you so much, Isaac. And for those curious, that was the same question we asked on all prior 4 meetings we've had, and city was not a popular choice for vacation. So a lot of folks choosing mountains or beach. I also wanted to draw attention to another committee member that's joined, So Peta, are you on? Are you able to state your name and if you have anything to disclose related to the measure discussions today?
No, my name is Sopita Andronico. Have nothing to disclose.
Thank you so much, Sopita. Appreciate you joining. And any other committee members that have joined that were not here during roll call and have not been recognized, that's Benjamin, Marissa, Megan, Pranavi, or Sandeep. Are you on the call? And if you are on the attendee side and you can't speak, please raise your hand and we can promote you. Okay. We do think that maybe these members might join a little bit later. So unfortunately, this means that we are at 16. We needed 17 to actually vote on the measures today. Not to say that the committee members here are not able to vote. Since you have the voting link, you may submit your votes through that link when we get to that point of the discussion of the measure. But since we don't have that full 17, we're not able to actually do the vote. Prior to the meeting, it was anticipated we would have 21 actually attend today. So we're following up with these individuals to see what may be going on and see if they really can join this call. So maybe at some point we can pick up for voting. So apologies to our committee members that are here today, but also to our developers. And for those that are continuing on with this, our work, this is also, as you know, very, very important to attend these meetings so that we can vote. There's a lot of time that goes into development of materials from the developer side, and to not have quorum, to understand where the decisions are, we have to wait and follow up and things of that nature. So it's really imperative to let us know in advance if you're not able to attend a meeting, or just make sure that you can attend. Appreciate that. Okay, so last call for any of those committee members that may have joined late. We're not here. Okay. All right, well, let's get into our first measure up for discussion. So again, the four measures we have first are going to be the Yale core measures that are going to be very similar. They're looking at these outpatient types of procedures, whether it be surgery or others. And we do have, like I said, David May is on the call to be our subject matter expert to weigh in, and especially for any of the types of complications related to these procedures that have been identified from the developer, et cetera. So if there's questions from the committee, we can definitely triage accordingly with Dr. May, and then Tariq Hughes will be on later for the colonoscopy measure, and of course, Margarita and Morris, as we mentioned. I do want to check in to see if we have a representative from Yale Core on the call to speak to the measure.
I'm Doris right here.
Hey, Doris, thank you so much. And Doris, do we have everyone from your team on the panelist side, do you know, that needs to speak?
I believe so. I just asked them that very question. We'll let you know if anyone else.
Okay, great. If there is anyone else on the attendee side from Yale Core, you can raise your hand. Our team will be able to promote you. Okay. All right, great. So thanks, Doris. So all right, so we have this measure, our first measure up here is CVE number 3357. This is the facility level 7-day hospital visits after general surgery procedures performed at ambulatory surgical centers. As you can see the measure description, this facility level risk standardized ratio of acute unplanned hospital visits within 7 days of a general surgery procedure performed at an ambulatory surgical center or ASC among Medicare fee-for-service patients aged 65 years and older. An unplanned hospital visit is defined as an emergency department visit, observation stay, or unplanned inpatient admission. The developer is Yale Core, and the steward is the Centers for Medicare and Medicaid Services, or CMS. This is a maintenance measure which was last reviewed in the fall of 2017. Its current and planned use is public reporting, as well as the quality improvement with benchmarking, specifically external benchmarking across multiple organizations. The measure type is an outcome, and the target population, as you see there, which was in the description, and the care setting here is the ambulatory surgical center, and the level of analysis being the facility itself. All right. So Doris, I'll turn it over to you to do a 3 to 5 minute overview, and then we'll jump to those discussion points, summarize those, and then turn it over to see if David May has any thoughts, and then our patient partners. But go ahead, Doris.
Great, thanks so much. Hi, my name is Doris Peter, and I'm here representing Yale Core, the developer for the next 5 measures. So I'm afraid you're going to be hearing a lot from me today. So I thank you for your patience and also for your hard work in reviewing all this information and all the back and forth with the committees and public comment and such. So thank you very much. Also, thanks to the Battelle team. You probably all have noticed the iterations of these cycles where there's been constant improvement and requests for public comment and changes in the process. It's really meaningful for us as developers, and I'm sure on the recommendations group and advisory group side, you're seeing the same improvement. So really kudos to Battelle for taking that on. So for the first 4 measures that we talk about, these are very similar measures, as Matt already pointed out. The first one we'll talk about is the ASC, what we call it for short, general surgery measure, because the name exists is too long to say every time. So I'll call this measure ASC general surgery. And Matt already gave a little bit of a background on this measure, and I'll go into a little bit more detail. But first, I just wanted to address the very first point that was made by a committee member about the value of measurement. And I always think about that as well and thought about my background. So my background is really a consumer activist background. I used to work at Consumer Reports, and we used to use data like this to hold facilities accountable for their performance. And organizations like Leapfrog use this data today from these ASC measure results for a similar purpose. In particular for ASCs, there are few performance measures with public data to be used for this type of work. So it's very important, these measures in terms of their accessibility to the public. And more importantly, I think, in these measures in particular, is that the information is going back to the ASC in terms of, in the form of reports that get to the individual patient level information about which patients came to their facility, which ones experienced a hospital visit, what type of hospital visit it was, and why the hospital visit was experienced. For example, was it for nausea and vomiting? Was it for pain or whatever? And then that ASC can look at their own data and they can start to dig down on what the problem is and how they can improve it. So that's really important cycle. And the side of public transparency, the data is also available to the public. So I just wanted to make sure that everybody was aware of the importance of these measures and the lack of information out there for ASCs. So getting back to this particular measure and the other measures that are very similar, they capture, as Matt said, post-procedural hospital visits within 7 days of a general surgery procedure. And the hospital visit is an inpatient admission, an emergency department visit, or an observation stay. And the whole point of that is to capture sort of like an all-cause readmission measure in a way, but it's also capturing that ED and observation stay. And this all-cause approach is in a way a proxy for complications. And we use that in our validity testing to show that the measure is capturing complications, but it's actually trying to capture, the big picture of hospital returns hospital visits or acute care returns to a facility following these procedures. And we don't include, some of the committees had questions about why do we not include ambulatory care visits? Well, we don't want to include visits to a clinic because that's what we're trying to incentivize. We're trying to have clinic visits happen instead of a hospital visit. Because something like, for example, post-procedural pain or nausea and vomiting, not only can that perhaps be prevented before the patient leaves the facility, but also there should be a way for the patient to follow up with the ASC or the physician surgeon at the ASC afterwards. So that's the whole purpose and why we don't include those procedures. A little bit more about the measure itself. These measures are all risk adjusted. So we use information from claims data to risk adjust for patients' comorbidity. And for this measure, also categories of procedures and also procedure complexity and age. So we try to adjust for differences between patients within facilities to make a fairer comparison. I also wanted to note that these measures are very similar to a measure that this committee reviewed previously, the HOPD surgery measure. And that measure had a very similar structure, and all the same issues that came up with that measure came up with this measure also in these other 4. So you're probably pretty familiar with these issues around the 7-day outcome window, which is sort of supporting this all-cause outcome approach, and also issues around the issue I already brought up about hospital-based acute care versus ambulatory care. So it's really the same approach, and the measures have very similar results in terms of their metrics that you reviewed for the HOPD surgery measure, which you did endorse. So I'm going to go now just focus a little bit on the validity of the measure So for all these measures, again, they're all the same. We've provided similar information for all of them. So these measures meet the TEL requirements on validity, as well as reliability and also use and usability, but I'll focus on validity right now. So for validity, we've provided you with 4 sources of support for validity. First, there's face validity that we use for our technical expert panel. We assessed the face validity for these measures, and they had reasonable face validity, over 80%. And then second, we provide external empiric validity testing that's showing expected association with facility procedural volume across all these measures. And we note that while procedural volume can be considered a complex construct, in our logic model, I have to admit, we did not explicitly say procedural volume, but we would say it falls under the provider technical ability because higher volume is associated with better outcomes. And it's really likely provider volume that we're looking at in terms of these ASC measures. Third, the measure's validity is supported by the risk model performance because the risk model shows good calibration and discrimination. And if the risk model wasn't showing good performance, we would know there was something up with our risk model. So that validity, the validity of the risk model supports the validity of the measure. And then finally, this issue about principal diagnoses associated with the hospital visit. When we look at those, complications are the top ranked reasons for the return to the hospital. Not all of them are directly associated likely with the hospital return, although it's very difficult to tell. So sometimes you could have something like a fall that was actually caused by something like medication reconciliation that wasn't done, and that ends up in a hospital visit. Although at first you might say, well, why is a fall, something that should be in this outcome? So you can see that there's sort of a wide range of potential outcomes. Finally, in terms of use and usability, I mentioned already, this is an assessment of quality that's publicly reported and also informs quality improvement because facilities receive this claims detail reports that help them identify which patients returned for a hospital visit. And this is the only reported measure that captures this kind of outcome. And we're spending more and more money on these types of procedures because procedures or volume is shifting more to the outpatient setting. So this measure can capture that. As procedures move to the outpatient setting, the procedures end up in the measure and the outcomes are evaluated. So I really appreciate all of your time in reviewing these materials. I really look forward to our discussion. I'm here to answer all of your questions. Thank you.
Thank you so much, Doris. Great overview, touching on a lot of the points that we'll be going through today. So let's touch on those. So we'll go to our discussion point slide here. And as Anna mentioned, there are previous slides in the deck that were provided for reference and review, but we really want to dive right into the discussions. You can see the topics listed here, which really come from advisory group input. It comes from staff assessments, public comment, et cetera. So we've identified these, but again, you're not limited to what's here on the slide, but we really wanted to draw attention to what's listed here. The first here is the all-cause outcome, which Doris was alluding to in her opening remarks as well. And this is coming from the advisory group discussions, that concern around that all-cause outcome of the measure, expressing that there may be some of these complications that are unrelated to the surgery procedure, and which Doris was discussing. The approach that they took, as Doris highlighted, was looking at that 7 days and the top 25 that may be associated with the procedure, those complications due to that. And again, she had mentioned this was the same approach that was taken last cycle for a measure that was up for review 2687. And so the committee really applauded Doris and the team for that approach, really taking a look at what are those complications that are related to the outcome. So if you have questions about that, of course, David May is on the call here. If you have questions about some of these complications that may be associated with these types of surgeries, so he can definitely provide some input on that. So the next is about the bias to the outcome, in which also advisory group input. There was just some questions around that the outcome itself is not capturing people who may be going to an urgent care facility or even going back to the ambulatory surgical center and not really going to the hospital. So it's really just not capturing those events. And as Doris also touched on, really the accountable entity here is the ambulatory surgical center, and the goal is to measure and improve that care and to minimize the use of acute care hospitals. So those facilities and their staff should encourage these post-surgical care and non-acute, non-hospital care settings, which could include the ACS itself or the other ambulatory settings like clinic visits, urgent care visits, et cetera. So the low outcome rates, this also came through for this measure as well as all the other measures as well. Advisor group feedback and some recommendation group members as well also kind of picked up on this one. So the committee really questioned the variation across these rates is low. And so the developer had provided a response to these concerns or this topic, really indicating that there was a series of things that they did to mitigate some of these low outcome rates, one being establishing a minimum case volume, doing some statistical approaches to actually pull some of these measure scores from small facilities to the mean. Now, this type of statistical approach has been used previously. There is precedent for this, and actually some of the measures that went through this previous cycle did this as well. And so this is something that other committees also found to be acceptable, and also there is a precedent for it. So there is something that is it is an approach that we've seen before. And also this measure, as Doris mentioned, used in pay for reporting, not or used in public reporting, not for pay for performance. For the reliability was also something that came up, and this was from our advisor group as well as the recommendation group in public comment, just mentioning that reliability is low. Specifically, there's 3 deciles. So in our reliability submission, or what we ask of developers to submit when looking at accountable entity reliability, is to see a distribution of those estimates across the accountable entities, so in deciles. We look to see, especially if it's a signal to noise approach, if those estimates are greater than 0.6 according to our rubric. And in this case, 70% of those entities are greater than 0.6, which is fairly sufficient. It's something that other committees previously this week as well also felt that was fairly sufficient as well. And again, coming back to what Doris was saying related to how this is used for public reporting, not pay for performance. And so Doris also had, and the committee developer had a response there. Let's go on to validity. So there was some topic about validity through our staff assessment and the recommendation group. Specifically, they did 3 areas of validity testing, like Doris had mentioned. And one of those is where we were asking for some clarification, which is around the volume of outcome and volume to outcome association that was presented. We just identified that it wasn't clear what that really meant, if that was really a quality signal. So the volume of procedures had a negative correlation with the outcome. So the higher the volume of these procedures, the less likely that that patient or that individual would be going to the hospital. So just wasn't clear in the submission why that was done for validity. And Doris and maybe even David can also speak to, is that really an indicator of quality that you have a higher volume of procedures that will reduce the number of those hospital visits. So we can, if there's any discussion there, we can go there. Lastly, with use and usability, the thing that we identified in the staff assessment and recommendation group as well also called attention to this was just that there wasn't any improvement over time seen with this measure. It is being used. So wanting to see if there's, yes, use, great. If there's feedback and a feedback approach going on with these measures, in this case, yes, there is, to collect feedback from the public, accountable entities, and then being responsive to that feedback, which the developer had identified. But we also want to see if it's actually moving the needle over time. And so that wasn't reported, and the developer had mentioned that because of these procedures change so frequently as more and more of these move into the outpatient setting, that it's really hard and challenging to make that comparison year over year. So we can see if there's any discussion we want to have there. I'm going to go to David, Dr. May. Just want to open it up from your perspective or thoughts. Anything that you feel the committee should know, either about the complications with these procedures or something else that struck you when you were reviewing this. Go right ahead. And if you don't have anything yet, that's perfectly fine. But I'll open it up to you to see if you have any initial comments.
Thanks, Matt. Yeah, I would say I'm, overall in favor of this metric. This patient population for ambulatory surgical centers should be a highly selected group where they should have, low risk and low risk of morbidity and mortality. So, it's important to keep this number, as low or lower than we already saw in some of the data. I think from a transparency standpoint, I think Doris, said it really well, that there's a lot of these surgery centers are sort of functioning without a lot of transparency. So having some view of quality to these ASCs is really important. But then even on top of that, for the surgery center themselves and the surgeons, there's not a lot of transparency. You lose track of these patients. You don't know if they're showing up in other ERs. So overall, I think this is a really helpful metric for the public as well as the surgery center and individual surgeons.
Thank you so much, David, for mentioning that. And I appreciate you drawing attention to Doris' comment about, you know, the value of this and being able to have this transparency for these facilities. If in the submission from the developer as well, you know, how you may be wondering how these facilities can respond and react. You know, there are claims-based reports that really drill down to understand what the complication was for the patient related to the procedure. So, you know, there's ability there for them to actually act on those information, which speaks to some of this transparency that's going on. So adding that as well. Thank you, Dr. May. Again, Dr. May is here if the committee has some specific questions about this clinical area, and appreciate his time on the call. Let me turn it over to our patient partners as well today who are on the call. Danny and also Kimberly, any thoughts from you about, you know, this area of focus? You know, is it important, do you think, for patients? Is there something that, you know, is a question for you that we want to keep top of mind? And Danny, I think you started us out with that during your opening remarks today. But anything else you'd like to add? And maybe I'll see Kimberly, you'd like to start first and before Danny, but if you don't have anything to state, that's perfectly fine. We can definitely see if Danny has comments. Nothing from Kimberly at the moment. I don't know if Danny, if you have any comments or thoughts?
Yep. So I know that we don't include Medicare Advantage, but I think I just need to state that that's just ridiculous to me, that more than half of the Medicare patients aren't part of this pool, and that it just needs to be stated. So whenever that actually happens, I'll be fascinated how all these statistics change. I also want to say that 14% of Medicare patients are under the age of 65. And I think it's arbitrary that we don't include those people. They have these procedures as well. I also feel like I think it is that we need to rethink about ambulatory visits being not hospital when more and more hospitals are owning practices and billing for facility charges. And if they're billing for facility charges, then they should be included as a facility follow-up. You can't have it both ways. And I realize this is political and not likely within any of our powers, but I think it should be thought about. And finally, you know, how this is changing over time, in that, you know, the out-of-pocket expenses have increased dramatically. That were the shift from solo to group practices, the increase in minimally invasive procedures, imaging advancements, telemedicine. How do these changes in the delivery of, you know, all of these ambulatory procedures, how does that allow for people to improve and to compare when over time it just seems like the way we're delivering the services are so different than it was 5 years ago and certainly 10 years ago.
Yeah, great comments, Danny. Thank you so much. And very, very important comments for us to also, you know, consider from the patient perspective of thinking about capturing our summary. I agree with you. I think there's some things on today's call that I don't think we can resolve today, but recognizing the comments around Medicare Advantage, rethinking about these ambulatory visits and hospitals billing for facility charges. I definitely appreciate those comments from you, Danny. I don't know if there's any comments the developer might have on the 65 age here, and recognizing that there are those patients who are less than 65 that may have these procedures. So we may go to the developer on this one, and appreciate the comments around out-of-pocket charges, Danny. But Kimberly, I'll see if you have any thoughts, as maybe you were probably thinking about some things. But while you're doing that, Danny, any thoughts on maybe this area of focus? Is it important or meaningful to the patient community, in your opinion?
Yes. I mean, I think I think these are all very important in the sense that they're common. These are, you get a bunch of old farts together, they talk about this stuff. So it's important to us. And, we think about, I know I can give some personal experience when we talk about some specific, the measures that are more specific and not so general. Yeah, so I think these are important.
Thank you, Danny. And Kimberly, I'll come back to you, not to keep putting you on the spot, just to see if you have anything to chime in on. Okay, all right. So I'll turn to the committee. Any thoughts on any things that Danny had mentioned, or even think about what Dr. May had stated? Any thoughts there, especially around this under 65 age limit? If you have anything, please go ahead and share those. But also, do you have any questions around some of these topics? Anything that you also want to propose? I'll see some hands raising. So Chris, I'll start with you, and then we'll go to Sunny and Amy.
All right, thank you. My first questions are to Dr. May, if you can. I'm assuming you're a participant in this program, so you get the feedback through the years?
Yes.
Great. Do you find that the risk adjustment model adequately captures the all-cause issue? I'd say all-cause problem. I mean, I'll leave that out there. See, do you understand my point?
I'm comfortable with the all-cause because of the shortness of time. I think if you were going to extend it out to 30 days, then, being a little more specific is probably helpful. Any visit in that very early 7-day time period is significant, even if it doesn't seem like it's related to the procedure. So I know that there were some complaints in there, such as chest pain, or dizziness. I think, the expectation is that patient's not going to have, those kinds of symptoms in the immediate 7 days after a procedure. So yes.
All right. So then you're happy to the degree that when this feedback comes to you, some you'll say, well, it's not related to what I do, but it's important to know. Is that your point?
Correct.
Perfect. Doris, just a broader question. Why risk adjustment versus exclusion?
And before we go to Doris, Chris, I do want to make sure we're trying to collect some of the inputs here and see if others maybe want to weigh in on some of these thoughts too. But great questions, and Dr. May, thank you for answering those. So Chris, you're asking about the risk adjustment specifically. Can you repeat that?
Yes, I'm an old model developer, and it's sometimes it's very difficult to adequately adjust. I mean, you can put your models in but I guess my question is, if excluding those issues that have to be adjusted, doesn't that make for a more accurate result?
Okay, thank you very much for that, Chris. Let me see if we have Sunny. You were next. Any thoughts on what Chris had mentioned, or Dr. May? I also see Daniel Hallaby has also put in that he appreciates his response from Dr. May. That really satisfies his concerns. So thank you, Daniel, for dropping that in. But Sunny, go right ahead. Anything that Chris had mentioned, or Danny, or others, or something new? Oh, and Sunny's hands down. Sorry, Sunny, if you were trying to speak, we couldn't hear you, but
sorry.
Maybe
Can you hear me?
Yes, go ahead, Sunny.
Yeah. My question's I mean, I don't want to be repetitive, so I think Chris's question is a valid question. I'd like to hear them. My questions were in addition to his on several other topics. So I don't know if you want me to lay all my questions at this moment or just, but in essence, I do agree with the all costs measure. I think that is the valid way to do things, as the surgeon mentioned, being a cardiologist and a clinical practitioner. But the second point on Chris is a question that I also had, and I'd like to hear back from Doris or the developer. And then I have several questions of my own that I can hold on at this moment.
Okay, thank you, Sonny. Amy, you're next. Any thoughts?
Yeah, I mean, I just want to bring up kind of my biggest concern when I was reviewing the measure, which is the measure developer mentioned like the ever-changing list of procedures at the ASC that prevent them from evaluating improvement over time. I guess my concern is that that's going to always be an issue. And so how do facilities improve over time? And is there some kind of like mitigation that could be applied in order to allow for that? So maybe it's you stagger when you introduce new procedures that are added to the ASC list, or create, coherent groupings that allow for comparison across. I mean, I think the other piece would be that different ASCs do different procedures. So even across facilities, it's difficult to benchmark or compare.
Great. Thank you, Amy, for that. Just drawing attention to those improvement results and maybe not being able to see those. So how can we, what do they do to improve, or how can we actually see that as well? How do we know that we're improving? Thank you, Amy. Paul, your hand raised, and then I'll go to Daniel and then Dimitri. So Paul.
Yeah, I think I think this measure is really important, and I think it's very well described and very well laid out. And to me, the biggest challenge is, when I was looking through there was some tables with the results from looking at the 2021 data, and just how many of the groups were, significantly different than the national average. So the general surgery, I think it was about 1,300 groups were reportable, and 9 of the 1,300 were either below or above the national average, which I think is really disappointing from a consumer's usability, and how someone can use this stuff to inform decisions. And I have a few, I think the big challenge is, I think, sample size and getting enough people in there. And so I think that is an argument for me. Someone brought up kind of the getting away from adjustment and having more exclusion. So I don't think we want to exclude people, because I think that poses a problem. I think, adding Medicare Advantage would be fantastic. I understand the technical difficulties with that. But hopefully that'll be something that can be done relatively soon. Adding people under 65, well, it would increase the sample size. I think that introduces a whole bunch of new people that have different health statuses that allow them to qualify for Medicare under 65. So I think that really does complicate things, and that can be hard to suitably adjust for. But one way to increase sample size that I think would be interesting to look at would be to go back in time. So instead of doing 1 year, do 2 years, right? Do 3 years, just to have a bigger pool of people. I understand the procedures are changing, but as long as you're adjusting for those changes, for the procedures, adjusting for the procedures, I don't think that's a problem, because as someone else already brought up, you already have to adjust for procedures because different ASCs are doing different procedures. And someone that, might not be doing the same, even though they're all, in this case, general surgery, they might not be doing the same general surgery. So we feel comfortable that we can adjust for those procedures. So over time, I would think that wouldn't introduce any new issues.
Great comments there, Paul. Thank you very much, and appreciate the comments on how this was really well described and important. Also some good suggestions. I'll go back to Doris on some of these here. So let me keep going with Daniel and then Dimitri. And Dimitri, I know you are also a measure developer and a methodologist, and there are definitely others on this call too. But I also welcome any thoughts. I mean, Paul alluded to this too, around the risk adjustment versus the exclusions. Any thoughts that you might have on that? But Daniel, feel free. Go right ahead.
All right, thanks. So first of all, I completely agree of the importance of this measure, and actually this set of measures, because we're considering many of these measures which are very similar. So very important I appreciate the responses to the all-cause outcome. I agree with that. Just to respond to a couple of the earlier points. As far as including under 65, yes, it's going to be a different population. So, but you have to see whether you have enough members to be able to adjust for those differences. I would like to see the Medicare Advantage data. Although I think that also has to be a different population. I'm sure that it'll be great to see whether there's a difference in the results between what you would see for a Medicare, for a managed Medicare population, and what you'd see for a fee-for-service Medicare. I do spend a lot of time thinking about the reliability, and again, I appreciate the responses of the developers. This is one of those areas where you really need consensus in the scientific community. So if there is consensus in the scientific community that the value of 0.6 represents, a valid cutoff, then I think that makes sense. That this is where you really rely on the expertise of the scientists and statisticians to come up with what's reasonable and what can be useful to monitor over time to ensure that the results are reliable, such that we can respond to them. And that's all I wanted to say. Thank you.
Thank you so much, Daniel. Great input there as well. And thinking about that reliability also, in our rubric, we mentioned 0.6. This also comes from a lot of the engagement from the previous scientific methods panel, NQF, which did some work at reliability thresholds. And we're trying to stem away from calling it a threshold, recognizing that this is something that does vary, and it just depends on a lot of things, the sample size and other things like all of you are very familiar with. It really is there to be a starting point and to really see that there is a good number of accountable entities that have hit that or not. And if not, are there some mitigation strategies that can help improve those smaller volume facilities, and some of which we've been hearing from Paul and others here about sample size increasing. The developer also drawing attention to some of the statistical work that they've done to try to bring those facilities to the mean. So there are some approaches, but again, we really want to see that there's a good number of those facilities that are meeting that 0.6. And again, we're not trying to terminate a threshold, recognizing your point there, Daniel, about just getting that consensus from the broader scientific community. Go ahead, Dimitri, and then maybe we can try to see if Doris can take some of these questions, but go ahead.
Sure. So Daniel and Paul brought up a lot of my questions, and I'd love to hear the answers related to the sample size, reliability, and validity. I do have two questions about statistical methodology of the measure. So first question relates to validity and risk adjustment. So for empirical validity, the developers opted to test the association between volume and the outcome, and they found that the association was statistically significant and negative. To the best of my understanding, volume was not used as a risk factor in the risk adjustment model. I might be wrong on that. So I am wondering if the developers or the committee have any concerns about potential bias if we're comparing facilities with different volume. So that's my first question. My second question relates to reliability, and I believe I brought this question up before. So when we're using hierarchical risk adjustment models, which smooth the rates for these small facilities, hospitals, providers to the mean, I continue to think that signal to noise is not an ideal approach to capture the reliability, because it masks the true performance of these facilities that have small volumes. So most generally, I think the reliability for these facilities will be inflated just by virtue of them being pulled to the mean. So I am wondering if the developers considered different approaches to test the reliability, and Matt, I think this also raises a question that maybe the standards might need to be finessed in the future to sort of account for different nuances where certain types of reliability testing might not be appropriate or less appropriate.
Great, thank you, Dimitri. I'm going to go back to the committee. Any thoughts on what Dimitri was saying, especially around the validity and the risk adjustment models, calling out the volume being not used as a risk factor, Any concerns with that based on what he had said, or any thoughts, maybe not having much concern? Any committee members wanted to chime in on Dimitri's point there? Yeah. Okay.
Right, go ahead.
Go ahead, Paul.
Sorry.
Yeah, go ahead, Paul.
I think that, to the extent that if higher volume facilities do perform better, which is kind of the, underlying assumption, I think that you wouldn't want to adjust that away. I mean, that's important for people to know that, you want to, you wouldn't want to back that out of the score, if I'm understanding that correctly.
So Paul, you're saying you wouldn't want to include that in the risk adjustment model. You would actually want to see those differences.
Right.
Right. Okay. Michiel, you have your hand raised. I don't know if you wanted to chime in.
Yeah, no, I was just agreeing with Paul. If higher volume facilities actually perform better, we should be trying to drive consumers there and shouldn't adjust out the volume impacts.
Okay. Dimitri, I don't know if you had a response or a follow-up to that.
Yeah, I mean, from the comparison perspective, I think this might create a disparity, sort of disadvantage those small volume facilities. I do see that as a consumer. I'd want to see that nuance. As a provider, though, I think there's a different perspective.
Okay. Chris, you have your hand raised. Would you like to comment?
Yeah, would the high volume providers draw the more educated, more sophisticated patient? I mean, I'm wondering if there's some kind of bias there. If it's a magnet for I won't say all the good, a lot of the good patients, but it leaves the smaller facilities. I wonder if the ones with the lower volume, as Dimitri was saying, are those who are disadvantaged. It's more reflection on the patient and the risk that they bring. I don't know. I mean, there's a lot wrapped up in that, but high volume facilities will be a magnet for a lot of patients. Good, patient.
Yeah, thanks, Chris. And Dr. May, considering that this high volume negative correlation relationship with the outcome of these hospital visits, is there something there with the higher volume? I know Chris was alluding to, are there different patient populations to consider with those high volume facilities versus low volume facilities? And also just this volume indicator as well as being something of quality indicator. Do you have any thoughts on that, to Chris's comment, or even just that volume is a quality indicator?
Yeah, I mean, I'll maybe defer to Doris on this, but yeah, I think the literature shows that, volume equates to quality just because of that repetition effect and probably some expertise that's developed. And maybe, as you were getting at, Chris, some things around patient selection there too, that they're able to select out, some high risk or marginal candidates for the procedure because of the volume that they have.
Thank you, Dr. May. I'll go to Amy, and then I'm trying to circle back, and Doris, I'll try to list out what we've heard as far as topics, so we can start there, if that's okay. And so, Amy.
Yeah, I just had one comment about the volume quality relationship. I think it's well established across a wide breadth of surgeries, right? But I think in this context, I mean, volume is really a proxy for something else. And we've kind of all pointed at different things it could be a proxy for. I think what might be more effective is identifying more distinct elements of that it's kind of that are more directly connected to quality, right? So if it is experience, what are other metrics of experience that aren't just volume? If it is some kind of favorable payer mix, right? Or patient mix rather, because these are all Medicare patients, then how do we get at that? I mean, I think volume is a quality indicator, and we do see that. I just think that there's more baked into it than just volume. Volume means better quality.
Yeah. Thanks, Amy. Great comments there, and maybe even just exploring that even further could be a suggestion there for Doris. Doris, maybe we can start with reliability and the sample size piece. Maybe we can start there, and then we can maybe get into the volume piece here. And I know there's some others, But maybe we can start with the reliability and sample size piece and some of the suggestions maybe that we've heard already. Paul had mentioned increasing the period to 2 years to increase the sample size. I don't know if you've considered that. Also, some questions around from Dimitri related to are there different approaches that you consider besides signal to noise, recognizing some of his concerns. So let's start with reliability and sample size. Go ahead, Doris.
Sure. Thanks. And thanks for all the questions. I've been jotting everything down in my notebook, but I really appreciate the discussion. So as far as increasing the sample size, it kind of ties into the recommendation for adding Medicare Advantage. So we would love to add Medicare Advantage to these measures. And actually on the inpatient side, there are a bunch of measures, readmission measures, which are sort of akin to these measures. But on the hospital inpatient side, that is happening as we speak. So Medicare Advantage patients are being added to those cohorts, which is an enormous undertaking. So we don't know for sure what the plans are for CMS's plans are for adding Medicare Advantage, but it would be a logical expansion of these measures as well. There may be issues around what data is available for Medicare Advantage. It was mainly a data availability issue on the part of being able to add this information. So I think that would also help our sample size, which would help reliability. That's why I brought it up now. So that's the first thing. The second is adding another year. So this is already a 2-year measure. We could look at adding a 3rd year. We always have this push and pull between currency and number of years. So as the measure expands the number of years, we get feedback that it's not timely enough and that the time span is too wide, and that you're looking at procedures that happened 3 years ago and maybe something changed since then. So that's another sort of push and pull that we have to think about. As far as methodology, it shows that I've been here a long time and the pendulum swings back and forth to different types of measurement for reliability. So we actually used to focus a lot on what some people call test-retest, but it's really split half reliability calculations. And we used to really only provide that. And then back in the days of NQF, they actually switched and started to ask us to do signal-to-noise reliability. So we shifted all of our analyses to signal-to-noise reliability, which is what we provide now across all of our measures, except there are a few that the methodology doesn't fit the type of measure. So that's really why we've moved over to that method. And there are other approaches as well that we can look at. So I think that could be a larger discussion, maybe with Battelle, as far as the types of methodologies that should be applied for what types of measures, and then also what the thresholds should be. So also knowing that the thresholds have shifted, it used to be the threshold of the median reliability of 0.6 or 0.7 was the cutoff. Now it's the minimum of 0.6. So that's a big shift for all of these measures. In order to meet that minimum reliability, the threshold is a much tougher task for these measures than the median. So I hope I addressed those questions. The sample size issue also plays into reliability. So we have a minimum sample size of 25 procedures for this measure. It differs slightly across the different measures. And those were initially developed based on reliability thresholds. So that's potentially something that could be adjusted as well. So I think there are many moving parts to this reliability issue, but I think we're all moving in the right direction of thinking about this and discussing this and talking about how it could play out in the different measures. And one other trade-off with reliability, of course, is as we raise the minimum procedural volume for public reporting, we cut off what is available to consumers in terms of transparency. So what we do right now is we calculate the measure for all providers, so all ASCs, and then we only publicly report those that meet the minimum volume threshold, 25. So as we raise that, we're just cutting off what was publicly reported. However, we do provide feedback to ASCs for all ASCs. It doesn't matter what your threshold is, you still get that facility level and claims detail level report. So they still get that information, but still you'd be, reducing what's publicly reported. I hope I answered all of the reliability questions.
I believe you did. I do see the hand is raised. I'll also just mention the S&P also suggested, calculating reliability with and without shrinkage to better evaluate reliability and the validity trade-off. And so there's those considerations from the S&P that were also discussed with reliability. As Doris mentioned, is an ever-changing type of approach that we're looking at within measurement. And we are looking at sort of this minimum here, but it's looking across this distribution of those entities. And again, this measure having 70% of those entities meeting that 0.6. Mahil, do you have a question about the reliability comments that Doris?
You
had
know, I
mentioned?
think it's sort of related. So, you know, it would be good to see the stability of measure rates across years from a usability viewpoint. So even if the sort of mix of procedures may change from year to year, I think, you know, from a consumer viewpoint of what an ASC is going to be high performing one year and low performing the next year, it kind of affects the usability of the measure. So it'd be good to see that as a follow-up. And just a comment on the shrinkage. So I think it's the right statistical thing to do, pulling the scores to the means. But again, it becomes a bit of a usability problem. So for another program, I actually did that for a hospital readmission measure. And you take out, oh, your observed rate is 0%. And then after we shrunk it, it's 8%. How much lower than 0% you want me to go? And so it'll be interesting to see how ASCs kind of respond to that, if they have. But that's just more of a comment.
Thank you, Mahil. And I'll pose this to, and before we go to some of the other topics, Doris, don't worry, we'll come back to that. I'll pose this to the committee. You know, are there reliability discussions here that are causing you significant concern that would change or impact your endorsement decision? And we're thinking about the reliability piece here. Well, we had some of these other areas definitely, but you know, is that something that still is a big concern for you? Again, you know, the team here is communicating back and forth on what we're hearing and thinking about some of these suggestions or recommendations for the developer. But is it something that's really questioning your concerns? Feel free to speak up about that. Sonny, you have your hand raised. Is it about the reliability? If not, would you mind if we moved on? But if it's reliability, go right ahead.
No, it's about the reliability. I mean, this measure has been in for years, and as Doris mentioned, the standards of testing requirements have changed. I mean, I remember when this measure came and I was part of the committee, core presented with retest test measures, and then it was signal to noise ratios. I think with every cycle, when this measure comes up, we have good discussion about reliability, the limitations of every testing model and the advantages. And I think the developer does a good job addressing them. And I think whatever model you choose, there will be some limitations and implications and assumptions, and there will be certain parts of the measurement that will be affected. But overall, I think looking at the progression of this measure over almost a decade since I've viewed this measure, I have no major qualms. I think I'm pretty satisfied with the reliability measure.
Thank you so much, Sonny. Very appreciate those comments. And Sonny comes from participating as well as Danny and others, Amy, on the Cost and Efficiency Committee when that was under NQF, and Sonny used to actually chair that. So he has seen some of these measures before, as well as Amy and Danny. So thank you for drawing attention to that. Any others? And we're thinking about reliability here. Is it something that's really concerning, that's questioning your endorsement? So please, we want to be able to identify that. Okay, and Sonny, you still have your hand raised. Not sure if that was a leftover. Okay, great. You know, Danny, I think we heard a lot about the sample size considerations that you were drawing attention to. So thank you. Related to the 65 and older, or the Medicare Advantage specifically, we'll kind of get into maybe the 65 older here. So appreciate you raising that, because other committee members really also agreed and wanted to hear from the developer on that. Okay, let me open it up to the validity here, and we're going to maybe talk about the volume quality relationship, and this kind of plays into some of the risk adjustment comments that Dimitri, Paul, and Mahil were talking about here. So Doris, any thoughts on you know, first of all, you know, the risk adjustment piece? I think if we're wanting to see this type of comparison of volume, maybe not including that as a risk factor within the model, and maybe what your thoughts and approach were with this, but also Amy's question about the volume quality relationship here, and sort of what your thoughts are on kind of digging into that a little bit more to really understand what is it really going on here that makes it a quality signal. And maybe we can, yeah, we'll start there. Go ahead, Doris.
Okay, I'm going to start with the second part first, which is first of all, why we started to look at volume in the first place. So often when we provide validity evidence for these submissions, we try to find quality measures that are in the same causal pathway and try to do an analysis looking at the relationship between two quality measures that are, that are related to each other, and try to predict like that there would be an association, a negative one or a positive one, depending on what it is. So for example, if there were some other measure that we could use that were similar or that was looking at something in the same causal pathway, we would look at that instead of volume, or maybe in addition to volume. But in this case, as I mentioned, there's nothing else out there for ASCs. And so there's very little for us to look at in terms of trying to look at this validity issue of the measure. Some people would say, well, the measure, I've heard this before, this measure has face validity because look, you're capturing hospital visits, which we know occur from utilization, and you showed that the main reasons for the return to the hospital are complications. So that in itself is validity, which is why we provided it as well. So we tried to go one other step to say, well, there's no other measures out there. Maybe we can look at volume as, in this case, a proxy for quality in this sort of analysis. And the relationship was as we expected. As the volume gets higher, then the rates are lower or better performance. There was also a recent article published on this very topic of volume outcome relationship of ASC procedures. So we also felt that it was also in the literature and reasonable to look at. I agree, it's volume is a sort of a complex quality construct, because you can think about, first of all, many aspects of volume. You can say, well, there's ASC volume, which is what we looked at. Then there's the individual provider or surgeon level volume, which is rolled up in there. And then you could ask other things like, what about lifetime volume, right? There's the physician or the surgeon has been operating over a certain time, and it's probably, not a linear thing. It might be a bell curve or whatever. So as a surgeon gets past a certain age, maybe the volume effects are diminished or it's a plateau. So it's very complex. But in this case, what we were trying to do is provide one additional element of validity in addition to the 4 others we provided to give you confidence that this measure is actually measuring something in a quality construct. So I hope I answered that. I don't think we would risk adjust for volume, again, for the reasons that were brought up by the committee members, because we actually want that to be out there, and that we want the, we don't really adjust for other facility level issues around, facility level variables. We adjust for procedure level variables, like the procedure type or complexity, and then also patient comorbidities. But volume isn't something we've considered, and we wouldn't, I believe, want to adjust for that. So I hope I answered your questions on those 2 topics.
Yes, and Doris, Chris, I'm sorry, Chris, Debbie, I forgot your question here, which I went to Dr. May about. But is this the volume piece? Is this something that you think would actually draw the patients to choosing a high volume versus a low volume? I know Chris kind of asked that question, considering this volume in the risk adjustment model or not. But I don't know if you had any thoughts on that, Doris. Yeah,
it's possible that it would, but first of all, it's hard for patients to even find this information. It's not published on Hospital Compare right now. You have to actually download the ASC data from CMS's website. And then remember, the volume you're seeing is only Medicare volume. So an ASC operates on or cares for a much wider group of patients than just Medicare patients. So even ASCs would argue, well, for a patient selecting a facility, you don't actually have the full picture of the volume at that facility. But where I'd go for then is Leapfrog, because Leapfrog actually surveys ASCs and they ask questions about volume, and they're getting if from the ASC self-reported the actual volume overall, not just Medicare patients. So I do think it's a valuable thing, and I do think consumers do use it, and they use it at the patient, at the surgeon level also, if they can get it. So whether it draws more educated patients or not, I'm not really sure. I think, we try to inform patients across the spectrum that this is a type of way to look for high quality facilities. But what I'd really love is for us to give patients better information than volume. It's so, I don't know, disheartening to me that at this day and age in 2024, that's still what we're talking about, a proxy, using volume as a proxy. Why can't we have better quality measures that look at all patients at ASCs and have and give consumers a way to really choose rather than just making them use volume as a proxy? So it's kind of a sad comment, sorry.
Thank you, Doris. Thank you. And you may have touched on this, Doris. I think you touched on the 65 and under population. Paul alluded to this. So did Danny and Paul had mentioned that this may provide patients with a little bit more complications that may be challenging with the measure. I can't recall if you touched on the 65 or under 65 population, excuse me.
No, sorry. Thank you for bringing that up. That is exactly why we don't include patients that are on Medicare that are not over 65, because they have a higher burden of disability. And so risk adjustment is more difficult. And for almost all of our measures, especially the claims-based measures, it's patients 65 and older and on Medicare.
Great, thank you. So I'm going to circle back to the committee. Here we're thinking about that risk adjustment model. Here we're thinking about the validity and and this volume outcome relationship that was done. Doris had mentioned this, but I also want to draw attention. There were other validity assessments the developer did do. This was just one of them. And Doris mentioning, this may be all we have at the moment. And so, until something out there is better, looking at this volume as the quality indicator, since there was some literature published on this, was what the rationale they provided here. But let me open it up, and now we're thinking about validity and risk adjustment based on those comments. Danny, you have a question, go right ahead.
I don't want to let this under 65 go because I think we're very glib in stating what we think the differences are. And what we're doing is we're saying that we're looking at half the Medicare or less than half of the Medicare population. So let's just say it's 50% are the people who are not Medicare Advantage. And then we're saying 14% of them we're going to take off because they're under 65. So we're ending up with that there's a significant proportion of people who are over 65 who have complex conditions and disabilities. So I don't know. I just think we just say that, and but we accept the variation in the over 65, but we say that, oh, we're not going to look at this because there may be more people who are disabled in that. I don't know. I just think it's I don't know how much we test that, and whether we can't okay, just accept it and include it. And then what does that say? Anyway, I don't think we should. I think it's wrong to exclude. Enough.
Thank you. Yeah, thank you, Danny. I appreciate that. Others on the committee, thoughts on the 65 plus? I mean, I heard from Paul and we heard from Doris, or under 65. I heard from Paul and Doris about some of the challenges with including that patient population. I mean, Danny raising a good point here as well, but thoughts on the under 65 with this measure, or even in other contexts? So Danny, is this something that is really challenging your decision on an endorsement here, or is it something that we can include as something for CMS to consider in some of their measures, since this is a CMS stewarded measure? Is it really challenging your endorsement decision? We can circle back, and if you need more time on that one.
I don't know. I don't know.
Okay. All right. Well, Amy, let's if you wanted to chime in, go ahead.
Yeah, just chiming in on this issue. I mean, I think that in my mind, the under 65 population is so systematically different from the fee-for-service 65 population. And not to say that similarly complex or disabled patients are not within the fee-for-service population. It's just that these patients specifically have these conditions, and that's why they're on Medicare when they're under 65. I think this also a little bit goes back to an earlier comment about risk adjustment versus exclusion, right? So is there enough or sufficient risk adjustment to add these patients to the model and not affect the actual statistical qualities of the model? And I really question that, honestly. One population we might think about as end-stage renal disease, right? Those are Medicare patients, but they obviously have a very distinct bias or rather aspect to why they are in Medicare, right? And under 65. And so I just want to think about all of those things together I'm wondering if like maybe the halfway is we include the patients, but not, and so that at least ASCs will get the information that these patients are being readmitted, right? Are having ED visits, are having observation stays, but not necessarily included like in the model. I'm not sure if that's an option.
Yeah, thanks, Amy. I see other hands raised here, Sunny and also then David. I also will ask, Dimitri, again, coming back to you, I know as a measure developer, any thoughts you have on this topic of including the less than 65 from your experience with measure development with CMS stewarded measures as well. But David Schultz, go right ahead, and then Sunny.
Yes, I'm Dave Schultz. I agree. We should exclude the under 65. It's just a special type of group. I think those who are on Medicare under 65, for example, because of autism or some of the psychiatric illnesses, maybe we could include some of those, but it gets very difficult to cherry pick out because, again, these people are going to have unique circumstances and kind of are a group of their own. And I'll go one step further. As a primary care doctor practicing, we try to follow these people almost 100% of the time already because they are going to have problems. It's not a matter of if they're going to have problems. Many of them will. And so we're already following them very closely in the office whenever they have basic outpatient surgical procedures and even diagnostic procedures as well.
Thank you, David, for that. So just adding on some additional commentary about maybe considering this under 65, but Sunny and then Paul.
I can see where Danny's coming from. I mean, let's take this another thought. I mean, in an ideal circumstance, not even you would want to know every single patient coming in, what is their unplanned visit status. But this is where the challenge comes in when you're trying to develop a measure. You try to come up with an ideal scenario, but then you try to figure out what can be measured accurately, reliability, validity. Do you have the data to support that? And when you start getting into the nuances of developing a measure with populations which are vastly different, with different set of comorbidities, at some point you'll have to take some assumptions, you'll have to make some exclusions and inclusions, because at the end of the day, you want a measure to measure something accurately and not be just garbage in and garbage out. And that is why initially, I think the current rubric that the developers adopted does have limitations. I mean, it does exclude a significant cohort of people, but I think I would rather trade that and figure out another way to include the patients which are in that Medicare Advantage population in a measure that is reliable and valid, rather than sacrifice the scientific acceptability of this measure. So that is one comment to Danny. A comment or a question I have for the developer is, I mean, this measure has been in for many years. Have you ever thought about figuring out of novel ways of doing this to include these patient populations which are excluded? Have you had discussions with CMS to maybe push the bar? I know you mentioned something about unplanned hospital visits on the readmission measure, but similar measures on the ASC side.
Thank you, Sunny. And definitely we can see what Doris has to say here. I will open it up to others who have developed measures in considering the under 65 population and what your thoughts might be. And Paul, you're next. Go right ahead.
Yeah, one of the thoughts on the under 65s, I mean, I think it's important to try to measure that group to the extent, possible, but to the extent that they will add to the sample size, I don't know what the answer to this is, but I'm interested to know how many of those folks end up going to the ASCs anyway, since the ASCs tend to, have lower risk patients. Are they just as likely to go to the ASCs for these procedures as the over 65 group?
Yeah, so thinking about that patient population and are they actually going to have these procedures and versus the over 65? And of course, Danny Van Leeuwen also called attention to obviously the complications and various different conditions with the 65 plus population being somewhat different than maybe the under 65, keeping that in line. Others on the call here, I know we're talking about this under 65 here, but I want to open it back up for some of the risk adjustments and the volume as well, just to make sure, again, if we want to kind of close this conversation, and I wanted to go back to this use and usability. and maybe we can kind of wrap some of this up and go to a vote. So others on Doris's remarks around the validity here with the volume outcome relationship, the risk adjustment, exclusions, others on the call. And David and Sunny, you still have your hands raised. Not sure if those are leftovers, but anything from the volume risk adjustment conversation, validity discussion that's really questioning your endorsement of this measure. Okay, hearing none, taking it that folks on the call are satisfied with these responses is not really something that is challenging your decision here. So thank you, Doris, for answering all those questions. I will come back on the use and usability piece, but Doris, do you want to maybe touch on the under 65 population? Sonny's question about have you maybe explored this in any way? Any additional thoughts you wanted to add?
I'll just reiterate the same issues that actually were brought up in that when you're developing a measure, you're trying to include as many patients as possible. But then when you see very different outcome rates, you start to have to narrow your measures. So you have a more homogeneous measure so that risk adjustment will work. So it's that trade-off between what the question before was, why aren't we excluding more patients instead of risk adjusting? Well, we're trying not to actually, but for certain patient populations that have widely different outcome rates, we would have to do that. But more importantly, we do believe, and we can look at these numbers. I don't have them on the tips of my fingers. We'd have to go back to the original data. It's probable that patients who are less than 65 who are on Medicare are probably not being selected for at ASCs. They're probably getting procedures done as either inpatients or at hospital outpatient departments. So I do think that that's probably the issue. We actually think that we gain much more focusing on the Medicare Advantage population and adding those to the measure than the under 65. But we do appreciate that point, and we want to be as inclusive as possible. So we do understand the concern.
Yeah, thanks, Doris. Anything with your TEP on this? Just curious, anything that came up with your TEP related to this age population?
No, I don't think so. I mean, this was, I think it's been a pretty standard approach across almost every claims-based measure I've ever worked on. It may have come up many, many years ago, but maybe now it's time to bring it up again and think about what the alternatives might be.
Yeah, thank you, Doris. All right, Chris, you have your hand raised. Want to see if you had any follow-up on this. I do want to touch on the use and usability piece. I know we're going a little over on our time here, but these are all these types of topics that repeat some of the other three measures. So keeping all of this discussion in mind, especially with those other three measures, we can revisit if there's anything new that's come up for those other three. But Chris, let's go to you and see if you have any additional comments.
I'll be brief, and like you said, everything we've talked about really applies to the other measures. Doris mentioned something that reminded me of something Dr. May said, suggesting that the ASCs pretty much draw the low-risk population, if I paraphrase correctly. Do you see that from your data analysis, Doris?
Well, I'd have to look back at, I guess, the prevalence of risk variables. Somebody on my technical team might be able to, but on other measures that I've worked on, yes, I have seen that, where the national outcome rate for the ASC population will be lower than the HOPD population, and also analyses by MedPAC, if you've ever looked at their reports. Revealing that I'm a geek, read those MedPAC reports. They actually have done analyses like this, looking at outpatient procedures and comparing HOPD and ASC populations and showing comorbidities are much higher in HOPD than ASC population. And in a way, it's actually, if you look in our logic model, they're actually supposed to appropriately select patients. So I'm using that word appropriate. Right, they're supposed to be selecting them based on their clinical situation. If the provider thinks that the patient doesn't have the capacity to care for themselves at home, or they have a lot of disability, they may decide that it's better to do an inpatient procedure, right? So appropriate selection for the lower risk patients who can be discharged on the same day and largely be able to care for themselves. So I hope I answered that question.
Yes, you did. Thank you.
Yeah, and thanks, Chris. And as Doris was mentioning the MedPAC reports, Dr. May was agreeing, he's like, yes, and then he said geeking out, and he kind of laughed on that one. So I take it Dr. May probably looks at those from time to time, potentially. So Alice, you have your hand raised. I don't know if you had a question on that topic or something new.
So just it's something that I had put in the chat, and just a question about if there were some consideration potentially to include under 65, but to add dual eligibility as a risk adjustment. I know dual eligibility is not used in risk adjustment for this measure because it was concluded that it wouldn't have a major impact, but the proportionate difference of dual eligibility for the Medicare population under 65 versus over 65 is significant. And that might in some way equalize a little bit the population, but just a thought.
Thank you, Alice. Very, very helpful for that. I believe, Doris, you thought about maybe going back to the TEP and kind of exploring this a little bit further based on the committee's discussion. Alice's question, do you have a response to that, Doris?
I think it goes back to which patients are getting procedures done in these types of facilities, and likely that there isn't a large enough proportion of patients under 65 on Medicare who are getting ASC procedures. Much more relevant probably in the inpatient and HOPD settings. So if we were to look anywhere to include them, I would say there first. But I think in terms of having not having unlimited resources and using taxpayer money, which I think about every day, this is all of our taxpayer money that I'm spending when I think about these things, is that Medicare Advantage is a huge group we're missing. So I'd like to start with that, but I think explore the under 65 in the more high acuity settings rather than the ASC setting.
Thank you. Alice, any additional follow-up there?
I definitely agree that Medicare Advantage is that's a more significant volume and continuing to grow. So I do think that would be primary. And then I understand Doris's point about perhaps looking at the under 65 in other settings.
Thank you so much. All right, I do want to go to the use and usability comment just to kind of wrap this up. But Danny, just based on a lot of these conversations, we've heard some committee members, feeling like, including these may be challenging due to some of the risk to accuracy of the population. It sounds like Doris would kind of go back to their TEP, but of course, CMS on the call as well, hearing the importance of this, because it's not just this measure, it applies to other types of claim-based measures as well. But Danny, based on these conversations, or maybe others looking at this less than 65, Doris's remarks sort of sufficient enough to think about, again, questioning your endorsement for the decision. They would kind of explore this with their TEP, but wanted to open it back up to you, Danny.
Well, thank you. I think this, the use and usability is a cornerstone item for me. That, what good is it if we can't use it? And so using it to me means two different things. It means, can I use this to compare my selection, and can we use this to show improvement over time? And I think, and so I am actually doubtful on both of those counts. So does that, I guess I would ask the question about, on what basis to deny to deny acceptance or accept or deny. I'm still, I guess I'll decide before I do the lever, but it's a big one. Like it's a what?
Thank you, Danny. And just based on what Doris mentioned, that they would, explore this and go to their TEP to also consider this as well. Does that help give you some satisfy a little bit? Just because I think there's a lot that's been discussed around this, and you raise a really good point. And there are challenges, as we've heard. But I think just even considering exploring this, would that help satisfy some of this, recognizing that this measure is currently used, some of the other comments around how these facilities do sort of value these types of measures? Oh, no, Danny, sorry.
I'm here, I'm thinking. Okay. I'm not prepared to answer that. I'm thinking.
Okay. All right, no worries. Didn't mean to put you on the spot. A lot of hands raised. So let me first just go to, I want to open it up on use and usability. I know that we've been talking about under 65. We can definitely circle back there, but there were some comments around, this is ever-changing list of procedures, which is we see with some of these other measures. So how do facilities improve over time? And Danny was kind of touching on this too. So are there other comments related to that? Because I wanted to sort of touch on that, and then we can kind of come back to some the under 65 piece, maybe to wrap some of this up. But other comments on the use and usability piece, thinking about that improvement over time. Maybe this was your question. I don't know if you had a follow-up there.
Yeah, I mean, I think one comment I will make, I guess that is my most significant concern, right? But I will say that like I work at an orthopedic hospital and it's my job to review those internal reports we receive, and we find them incredibly useful. We tie it back to our data in our EHR and understand all the drivers of where the patients go. And so we do our own internal work to understand our improvement. But I will say that's like the not public facing part of the measure, right? That's how providers are using it. I'm wondering on the public facing part, how it can be more useful if over time you can't compare, across facilities we can't compare, right? And then even for us internally, how can we benchmark other than just against ourselves, right, in our previous performance?
Thanks, Amy. Also, doubling down on some of what Dr. Mayo was saying about the importance of this information facilities, and as he had his head nodding as you were stating that. Mihil, anything you wanted to add to what Amy was saying about use and usability or importance?
Yeah, it says at the bottom, does the committee agree that measured results can be used by ASCs? The amount of data and the granularity I think is great. The question is, are ASCs using this for quality improvement? So I think there's value to measure just to direct consumers to high quality ASCs or high performing ASCs, but I don't know anything about the infrastructure within ASCs to actually respond to this information, or whether there are programs built around this measure. I know some measures are kind of considered QI worthy and others not. And I don't know if Dr. May has any insight in this, but are there actually programs, QI programs, going on that use this measure as a basis?
Thank you, Mihil. And Dr. May, I may come to you to see if you have any comments on Mihil, but I'll first go to Sunny and then Alice. Sunny.
This portion of this portion is what I struggle with the most, and I have two sets of questions regarding this. One is the question from a provider aspect or the administration aspect of things, and the other is from a perspective of a patient. You see, the ASC front is pretty much the wild, wild west in healthcare today. You have ASCs owned by private groups, you have ASCs owned by private equity, you have ASCs owned by hospital groups, and the incentives to do procedures in ASCs are so variable. And yes, these patients are low acuity. You would assume that they are low complex patients, but that has some challenges and assumptions. So this measure, so the first question surrounding from a provider level and a hospital level or administration level is, has this done anything for the outcomes or the care of our patients over the decade or the years that has been used? And I'm not sure I see any data on that. Yes, it's a valid construct, it's a reliable construct, its scientific acceptability passes, importance passes, but has it made any difference for some people? Yes, there are programs which are pretty good, like Amy mentioned, which do some internal reviews and try to improve on these constructs. But I can tell you there are many programs out there which don't do any of that. And pretty much these are reported on a website, which half of the people don't even know how to understand or look at these, and they're out there, and take what you want. That's the question from the provider aspect. The question from a patient aspect is much more nuanced. I mean, I'm in a very busy clinical practice. We have ASCs and predominantly in the cardiology space. And when patient comes in, I can tell you almost none of them goes to the CMS website or any public reporting website to look at the outcome of any ASC. They predominantly trust their providers, that is me as their physician, and say, okay, we'll go to this place and I think this is where our outcomes will be best. And there is some faith and assumption in the system on that. But this is where I'd like to challenge this issue, because that faith and assumption may be all in good sense and good conscious, but there are providers who don't have good outcomes, and there are providers who have great outcomes. And I don't think the patients are really using this data over all these years that have been there to improve their care. And that's where I challenge my questioning on this measure, and all of these measures pretty much will be the same question. Is this has been in use for years, and it has pretty probably, I don't think, has affected to as much a degree as I expected when I was initially reviewing these measures.
Great, thank you, Sunny. So again, just thinking about extending this even further, sort of the value with this over time, how has it really been impactful on outcomes, and both from a consumer perspective and others. Alice, let's go to you. Alice, are you there? Looks like Alice. Alice, if you can hear us, you may have frozen there. We'll see if we can get Alice back on. Dr. May, any thoughts on this, especially some of Michiel's comments about the infrastructure responding to these types of reports, or even some of Sunny's comments before maybe I go back to the developer?
Yeah, I completely agree with Sunny that, I think it's very variable with ASCs on whether they have a, quality department to, act on this kind of data. I think obviously most hospitals do, and I think these surgeons typically overlap to other, institutions and may be getting some scrutiny there, but I think it's definitely variable. So that was, I kind of just agree there. Well said. I do think the only other aspect that I was going to bring up is that, I'm not sure whether with these kinds of outpatient procedures, it's really facility volume that is important. I think it's more likely that this is surgeon volume that is the more likely indicator of quality, because, the patient doesn't have a long stay in the facility, like a pancreatic surgery where they would stay for 10 days or 2 weeks. So the only other clarifying point there. Thanks.
Thank you, Dr. May. Alice, looks like you're back on. Not sure if you wanted to add into the use and usability piece before maybe going to the developer.
Sure, and sorry about that. Just one thing I would add, and it goes back to the under 65 population when we talk about the use and usability. And I just thinking about this in terms of there's 2 areas of potential improvement with the ASCs, and one is in appropriate patient selection, and then in the other is in appropriate management of that patient post the procedure. And perhaps not including under 65 might limit the view of appropriate patient selection. It's kind of an interesting conundrum to say, well, these patients are more complex, so likely they're not going to get these procedures in these facilities, but we don't know because we're not capturing it to find out. And so I guess there's 2 things. If it's true, in fact, that these patients are not likely to get these procedures in an ASC, then including them really will have very little impact because they're not there. Or it will have impact in telling us that perhaps there's a problem in patient selection in these ASCs. So just a thought.
Thank you, Alice. Great thoughts there. And I know that, Doris also mentioned about, exploring some of the data here, because I think Paul raised some of the questions around, what does this population look like, specifically if they've looked at any of this. So Doris may have to kind of consider that and explore it. That's why maybe even confirming with the TEP that they work with on these measures, but also really good points, Alice. Anyone else on the committee have thoughts on this based on what Sunny had mentioned, based on sort of this infrastructure for ASCs and how they sort of can actually improve over time, to Amy's point, before I go to Alice. Michiel, you say you agree with Alice. Question is whether plans are using the measure to create tiered preferred networks, which could speak to the value of the measure for commercial population. Chris, and then Dimitri.
Yeah, I don't mean to come off too hard here, or maybe I do, but perhaps feedback to CMS. This is a CMS measure, correct? I mean, it's the plan for that.
Yes.
frankly, condition of participation should be that this metric and the results should be fed back into a formalized quality improvement activity. Okay? If you don't have one, then I don't want to come to your place anyway. Okay? So I'm sorry, I've been in QI for 50 years, and I too am frustrated with the lack of movement. At any rate, I would mandate that these metric results and measures get fed, get fed into a formalized QI activity that frankly, I thought they were required to do anyway. That's it. I'm done.
Thank you. Thanks, Chris. Good comments for CMS to consider there. Thank you for sharing. And Dimitri.
Yeah, real quick, just to recap what the others said, I think I have very similar concerns about the usability and actionability of the measure. So as we discussed, it's very hard for consumers to navigate because it's not public facing, right? So it's not extremely actionable from that standpoint, I would imagine. And with the vast majority of the providers being not significantly different from the national mean, I'm also wondering how actionable it is from the QI perspective, and whether it's meaningful to compare a given facility to the mean at all. I guess what Amy said does make sense. You can benchmark against your own performance, but if your rates are smooth to the mean, I feel like that's also not as actionable as it could be. I realize these are all the limitations of the small sample size, etc. But I'm just wondering if there's any meaningful reason, if we think about this critically, to maintain the measure that is not ultimately, and I don't want to use the term useful to the public and to providers. So, please replace that with the synonym that you think is more appropriate here.
Yeah, thanks, Dimitri. And Pamela Roberts disagreeing with Alice. Wonder how the plans, as well as institutions, are using their networks to determine of where patients should be seen. Okay, and then Michiel, the lack of performance differentiation due to small sample size does make the measure less useful for tiering and preferred facility identification. So before maybe going to the developer, anyone maybe not find this as a concern? What are your thoughts here for those that are raising some of these questions, especially if you've got experience in these areas about the usability of this information, both to consumers and all these facilities as well. Any comments from other committee members who you don't find this as a major concern or question? Daniel, yes. Daniel Halvey, sorry.
Hi, yes, hi. Yeah, so I mean, I don't see it as a major concern. I view this, so from a health plan perspective, I view this as a measure that really should be used, and I think Chris mentioned this, it should be used internally by the facilities to gauge their performance. Assuming that you get to the point where there's enough data out there that they can actually measure their performance against the benchmark. I would hope one day in the future, although I'm very skeptical that this will be used by consumers until the point that it can be incorporated in the public CMS measures. So, I really put this upon CMS to really build the public view of this, but still recognizing how much information we put in front of the public. We really, I think I'm kind of jaded now. I don't think the public is really interested in looking at quality and looking at price. We really want that to be the case, but it really hasn't been the case. So hopefully one day it will be.
Okay, yeah, thank you, Daniel. Any others, especially agreeing maybe with Daniel here, or finding this not to be a major concern? Yeah. Okay, Doris, I'll let you maybe try to tackle this one, and maybe we kind of wrap up here so we can go to a vote and maybe give folks a little bit of a break. Go ahead, Doris.
Okay, so first I just wanted to emphasize that as we submitted in our submission that the public reporting of this measure didn't start until January 2024. So while this measure was developed a while back, it didn't actually get implemented until just now. So in thinking about how long it takes for you to start to see improvement after the measure's been out in the public, we don't actually expect anything right now. And what I'll point to as what I consider the poster child for where I think this will pan out is the colonoscopy measure. That is probably the fourth one that we're going to talk about. And I can't share my screen, but in there, I guess I'm going to pull this up. There's a graph on figure 5B of the colonoscopy measure submission of our supplementary materials that shows improvement year over year at ASCs and HOPDs on that measure. And it's a similar situation where the measure was implemented a long time ago, and it took maybe, I don't know, 4 or 5 reporting cycles, but you can see it starting to shift to the left. But it has the same limitations in that the ASC data is not really visible to the public, et cetera. But facilities know that that CMS is measuring this and focusing on it. And so as soon as they're aware of that, then people start to focus on the issues that are underlying these particular measures. And it could be that there's a suite of measures out there and they're all addressing these care coordination issues. And so facilities start to put in place procedures that get at patient communication before the procedure, after the procedure, offering follow-up visits, offering telehealth. There's so many things that facilities can put in place these days to address those concerns. So I think for this particular measure, more time is needed as then this information will get out more to facilities for them to be able to use it. So I just wanted to correct that, because while it may have been reviewed 10 years ago, it wasn't released until just now. We also actually don't know if there was improvement because we have the strength. Oh, thank you. That's the colonoscopy measure graph I was talking about. So that's what I hope to see over time. We just hadn't had enough time with this measure, but colonoscopy was a little easier. And I was just going to get to this point now. So for the ASC measure and the urology and orthopedic measure, there's a strength that is associated with the measure's construction, which is also a weakness. So the strength is that it's based on the ASC covered procedure list. So those are procedures that CMS has decided can be done in ASCs. That changes year over year in a transparent process that involves public comment, et cetera. So it's not an instantaneous change, but it does shift, which makes comparisons year over year difficult for us. So far, we have not compared performance for this measure for 2 reasons. One, because it was just released now, and so we don't expect to see improvement yet. And because we've got this issue with shifting procedures. There may be a few, we've been talking about this with our experts who are on the phone, our analysts, about ways of trying to do this. Some of the ways that committee members have suggested was, maybe having cohorts that are the same across year over year. It requires more resources on our part to do analyses like that. And so we haven't been able to do them yet, but that is something we could do, compare performance on procedures, even though the measure actually has changed. So what is publicly reported won't be the same as what we're comparing for you, but that's an approach we can use. For colonoscopy, that cohort stayed the same over those periods, so it was easier for us to do. So I think there are things that we can do to try to track performance. They just aren't as simple because of the way the measure is constructed. So I just wanted to get at sort of the underlying reasons why we're not so much focusing on improvement yet and why it's difficult to show for these measures. The other point I wanted to make was sort of what I started out in the beginning about the purpose of these measures, and some of the committee members have alluded to this, that facilities can look at their information and make changes internally. And while it might be somewhat limited for the public at this point, the strength right now is that performance at the facility and using that claims detail report to dig into the information. That said, though, there are other groups that are using this data. So Leapfrog, I mentioned before, they are taking the ASC data that CMS uses, and they are using it in their own assessment of ASCs, which includes other data reported by ASCs. So it really gives them additional information to make transparent to consumers. So I think all of that is important to consider, and that there are no other measures available. And the less measurement happens, the less focus on improvement will happen. So it's kind of a bigger picture push to improve quality. There was a question about comparing difference to the national mean, maybe not being as meaningful. I do agree with that. And maybe there's a potential to make some other kind of benchmarks, though those that in themselves are often difficult to get agreement on is what should be benchmarked and how they should be benchmarked. But that is something that could be considered. Maybe CMS would want to consider that. But we recognize that as an issue, and it's something to think about. So we appreciate the committee's feedback, but I think that, I had one other thing to say. Someone asked about employer groups or maybe payers working with this data. I actually was aware that there are employer groups, sort of like Leapfrog groups that consult with employers to think about networks that actually are using this data. One of them actually contacted asked us a question about the measures in order to help them develop a way to use this data for that purpose. So I do know that that's happening. I hope I answered your question.
Thank you, Doris. Yes, I believe so. And it's a really good point in the argument here being that, this measure is just being used and starting to be reported. January 2024 is what Doris had mentioned. Whereas referring to this colonoscopy measure, even though this is not what we're talking about here, but just seeing how this measure started out that way, as you can see, being reported here or at some of these rates back in 2016-18 with these dashed and dot lines. As we get more to the solid line, all the way to the left, lower rates being seen over time. So the argument that this measure would also likely potentially cause this type of shift. So coming back to this actionability, as well as funding, is this really actually moving the needle? Is it actually impacting some of these rates? So that was the argument there. Okay, so we talked about use and usability. I want to see from those responses, from some of the committee discussion, are there still things the committee is questioning here around the use and usability of the measure for your endorsement decision? Because I really do want to start to move to a vote, but I do want to make sure we identify that. And Chris, yes.
Oh, I'm sorry, did you call me?
Yes, you had your hand raised.
I'm sorry, and my eyes might not be great, but is the best line on this graph the most recent and the prior year the worst? I mean, is it bouncing all over the place?
Yeah, I know. So there's different colors and dashes here, but 2016-18 is really the far right dashed line, and then it goes, and then it progresses to the solid line, which is 2020 to 2022. Again, calling attention, this is the colonoscopy measure we're looking at, but as Doris mentioned, the idea is that this measure, now recently being reported as of January 2024, would also have the similar shift of these types of hospital visits. Whereas this colonoscopy has been out for a little bit longer, as you can see, reporting starting back in 2016. So progression over to reducing those hospital visits over time.
Yeah, that's cool. I couldn't see it. I thought there was more movement internally there. Okay, cool. Go ahead.
Yeah, thanks, Chris. All right. Again, coming back to that question, is it for this use and usability piece, actionability, anything still concern you with your endorsement? So I want to make sure we can start to move to a vote and maybe go to a break. Mahil, yes.
Yeah, I just wanted to clarify, I strongly support the measure. So all of my comments are, let's improve the use and usability, get it used. The Leapfrog is using it is awesome. And I know employers, we work with employers and they're looking to tier networks. And, there's ways to kind of address the statistical kind of problems. So just wanted to make sure that was clear.
Yeah, thank you, Mahil, for stating that. Others? Okay. We heard a lot of really good discussion, and I know that we spent a lot of time here, but again, a lot of these similar types of situations occurred with the other three measures we'll go through. So we will take a lunch break, but I did want to at least mention that through some of these discussions we heard around the reliability, some of the questions related to also exploring ways to evaluate over time. So I heard some conditions here that we would like to consider for the measure. So when this measure comes back for maintenance, we would like the developer to explore methods to enable the evaluation of improvement over time and consider additional approaches to reliability assessment that informs the reliability validity, or that shrinkage, and reliability usability, that stability trade-off. So I think it touches on a lot of what we heard around some of the reliability discussions, maybe some of the validity discussions. I know that we also talked about under 65. Doris has mentioned that they will, CMS will need to consider that, but also looking at with their TEP, et cetera. So that's not something we put on as a condition, but the conditions, as I just stated, were to explore the methods to enable the evaluation of improvement over time and consider additional approaches to reliability assessment that informs the reliability, validity, and reliability usability trade-offs. So that includes that shrinkage situation and stability item as well. I'm going to ask Amy and Danny, just wanted to draw your attention to that. Anything we missed from your perspective?
No, I am grateful to see those. Thank you.
Thank you, Danny.
Yeah, I think those both make sense based on the conversation.
Great. Thank you. And now I'm going to move it to a vote here. So Doris, feasibility of those conditions, any real challenges here? Again, we're exploring this, not really, and considering this, not really requiring that it be done as far as like all of it be done within the measure, but really just exploring and considering this with your, by the time in maintenance, which would be 5 years.
Yeah, these are things that we're already thinking about. So I think we'll talk about it within our team and with CMS. Of course, we can't commit to any one particular thing that we'll do, but given resources. But I mean, everything sounds reasonable, and we'll make sure we talk about it internally and with CMS.
Thanks, Doris. And before we go to a vote, any final comments for the committee on this measure? All right. We're going to go to a vote. So again, we won't be displaying those because I believe it was checking with the team earlier that we were not able to get the quorum number, but maybe after lunch we can see where we are. So at least please pull up your voting link. You can still submit your vote. You're on here on the call. Please do this so you don't have to do it afterwards. And I'll turn it over to Isaac to conduct voting.
Voting is now open for measure 3357. Facility level 7-day hospital visits after general surgery procedures performed at ambulatory surgical centers. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. And as stated, we're expecting 16 votes. We're waiting for 2 more votes. We have all 16 votes. We can move on.
All right, thank you. Thank you all for that great discussion this morning. We're going to take a break. We'll definitely give you that time for that. So let's try to reconvene here. What do we got? 12:27. If we can let's reconvene at 1 o'clock. We'll give you a little bit longer. Keeping in mind these conversations and topics will be very similar to what we've discussed. So if there's anything new, we want to raise that for these other measures so that maybe we can streamline those discussions and keep moving. So we'll resume 1 p.m. Eastern. And Dr. May, thank you. And hopefully you'll come back as well for some of these other discussions, but it's been very helpful for your presence here.
Thanks very much.
Thanks. So you will come back, Dr. May, after lunch? Just want to confirm.
I'll be able to come back at 1, yes.
Thank you. Thank you. All right. Let's break for lunch. Thanks, everyone. Okay. I do want to kind of keep us moving along here. Again, if you're back, it's helpful for us to see the video just to make sure that you are back with us. I do want to kind of pick us up because we are a little behind schedule, but again, these discussions were very similar here. So let's see. Okay. And I do, we still, if you are a committee member that's joined after lunch and you weren't here during roll call or any of the previous discussions, please go ahead and state your name or so we can just recognize that you're here. But I don't think anyone new has joined, unfortunately. Okay. All right. So let's kick this off. So we have our next measure up for discussion, which is CVE number 3366, hospital visits after urology ambulatory surgical center procedures. Again, the developer here is Yale Core. You can see the description there. It's a risk standardized rate of those acute and unplanned visits 7 days after that urology procedure. Again, performed in ASCs among Medicare fee-for-service patients 65 and older. And you can see the unplanned hospital visits very similar. ED visits, observational stays, or unplanned inpatient admission. Very similar type of reporting, public reporting. It's also used for quality improvement and benchmarking. It is an outcome. You saw the target population in the description, ASCs at the care setting, as well as the facility. The same process as thanks Tara, same process as we did previously. I'll let the developer do their opening remarks. And Doris, I don't know if maybe you want to touch on how we just sort of evaluated a broader type of surgical type of procedure measure And, I don't know if there's any value in talking about why these are now getting more specific. You did kind of allude to that during our advisory group meeting, which I thought was very helpful. Well, after that, we'll go into the key discussion points. I'll sort of touch on what we talked about previously as a reminder to the group, and then we'll go to David May to see if he has any thoughts, and then our patient partners and proceed with the discussion. Okay, Doris, I'll turn it over to you.
Great, thank you so much. So we're moving on to these other measures, one for urology and one for orthopedic surgery. And I think what Matt was referring to is a discussion we had at one of our advisory committee meetings. We were talking about why are there these three separate measures for these conditions. And someone I think already alluded to this, that ASCs tend to subspecialize. So I think about 70%, according to the last MedPAC report that I read, about 70% of ASCs subspecialize. So rather than an HOPD, which may do every kind of surgery imaginable, the ASCs will be focusing, let's say, just on orthopedic procedures or just on GI procedures or something like that. So we have separate measures across the separate cohorts. The last one was we called general surgery performed by general surgeons. So there were a lot of things like breast biopsies and wound care and things like that in that measure. And this one, as the name would suggest, urology, focus on urology procedures. So that's how this measure differs. And the HOPD setting, you might remember that HOPD surgery measure, that was a much broader measure that was basically covering everything. So down to urology, I guess what I was just going to mention, I'm not going to go over the whole measure construction because it's all the same except the cohort is different, but everything else about the measure is the same. Although since there was a major point about improvement, which I realize now I was probably being too much of a purist while developing the response to writing up the submission and responding to committee questions. I was very hesitant to compare performance when the cohort changes year over year. But I spoke to our statistician during the break, actually through Teams chat, and got permission to compare results, even though we know the cohorts are different. So actually during the break went back to the code list and identified the procedures that have been added to the measure since the last time and looked up their relative value units, which is a measure of their complexity. And they're very low complexity procedures. So what I'll share with you, I think is okay, even though I probably should have done this in the submission, but I was too much of a purist. So when we look at the distribution of now risk-adjusted measure scores for the urology measure, comparing distribution the last submission, which is 2014-2015 with the current, you actually see improvement across the entire distribution. So I'll just give you 3 data points because I can't show you my screen. For example, the 25th percentile for the prior data was 5.6%. Now it's 5.3%. Okay, it's not a big difference, but it's somewhat of a difference. The 50th percent was 5.8%. Now it's 5.1%. The 75th percentile was 6.1%, and now is 5.3%. So there's a small improvement over time, with the caveat that the procedures are different, slightly different, that 2 procedures or 4 procedures were added. I think it was 4, don't quote me on that, but there were some procedures added of low RVU. I would say that we are seeing improvement. This measure started public reporting in 2022, so it's 2 years ahead of the last one, so we kind of expect there to be more. So I feel okay with sharing that information with you, and in future submissions, we'll either provide that with a note of what changed, or we'll try to account in our actual calculation for the change in measure in cohort. So those are the things I wanted to add to our discussion. Thank you very much.
Thank you, Doris. And could you, apologies, some may have missed the year that you were basing that off of?
The older data? Is that what you mean?
Yes, the improvement results you were just quoting, yeah.
Sure, the prior data was our prior submission, which was 2014-2015 data.
Okay. There we go, thank you. Great, thank you so much. And something for the committee to consider based on our conversation we had about that usability and progress over time with the last measure. So let's go to the discussion slide. I won't go into reading all of this off and developer responses to all of this. It's very similar. I'll just revisit what we chatted about on the last measure. So we talked a lot about the reliability and sample size. A lot of discussion here, thinking about the Medicaid Advantage population, also thinking about the less than 65 plus population. The developer commented it'd be great to have the Medicare Advantage population, but maybe down the road that may be a possibility. Also thinking about exploring that less than 65 populations. There's a lot of comments that were shared by those on the committee to see what that might look like. So going back to their TEP. Reliability and validity trade-offs. So thinking about that shrinkage to the mean concern and questions that some committee members had. So the developer, we put that as a condition for endorsement, as the developer would explore that and consider what the trade-offs there are. Reliability and usability as well, thinking about stability and those trade-offs, as well as thinking about how classification of these providers and how stable that is over time. So that is also something the developer will explore as a condition for the last measure. That volume outcome relationship, we had a lot of discussion on that, recognizing that this volume indicator, it may be the best that we have at this moment, but if they're always looking to dig down further and thinking about that volume, what that volume really, signal really means for quality. And volume was not included in the risk adjustment model because of the wanting to have those types of comparisons for those facilities. Actionability and usability was also discussed. Actionability within the facilities themselves, how they can actually use those reports, and there's claims-based reports that they can use. We heard a lot from the committee around, this is important, and that these centers do use this. And also, Doris had showed, or we did screen share that colonoscopy figure, which did show some of the improvements over time, and Doris sort of quoted some of these results for this measure in her opening remarks. And then usability to consumer. So thinking about how this could be usable to the consumer, obviously an important area of measurement. Patient partners drew attention to that. But I think there's some discussion beyond the capability of the measure here to think about how patients can engage with measured data through Medicare.gov, et cetera. It really isn't out of the realm of this measure itself, but something that I think CMS would value here. So again, repeating those conditions we had on the previous measure was that the developer would explore the methods to evaluate improvement over time, and also consider those additional approaches to the reliability assessment that informs reliability to validity and reliability and usability trade-offs. So keeping the conditions in mind here, keeping those discussion points in mind. I want to turn it over to Dr. May. Just anything you have to say about this measure, Dr. May, and even if you have think it's important and things of that nature, that's also good for the committee to hear.
Yeah, not too much new to add. I guess I was just going to expand on Doris's point, and I think other people have referenced that as more different procedures are added to the list that CMS allows in ASCs, although they tend to be of lower complexity than inpatient procedures, they're not new procedures that are still low complexity. They're actually adding cases that are typically done in the hospital and pushing them to an ASC type environment. So I would say relative to simple things like a skin biopsy, we're adding now things that are arguably more complex, like hip and knee replacements or cardiac catheterization. So the fact that a lot of these complication rates are staying relatively the same, I know we all want to see improvement, I think is actually a good thing, because we're adding more complex procedures and that complication rate is staying stable in some of these metrics. I know the colonoscopy one is improving. So I do think there is more complexity that is being allowed in ASCs over time.
Great, thank you, Dr. May. So just noting that there are more of these procedures being added, and Doris has mentioned this too, and some of these are even a little bit more complex. And it's good to see that maybe there's some stability in some of the rates, even with these added procedures being added. So thank you, Dr. May. I will also mention with this measure specifically, there was advisory group commentary as well that this does have a little bit higher outcome rates. So the low outcome concern that was brought up by the advisory group members was at least less so for a few of those advisory group members during the meeting. I'll turn it to Danny Van Leeuwen or Kimberly Jeffrey, patient partner feedback on this. Anything new you'd like to add specifically to this urology measure, and even hearing if it's important to patients or challenging for patients. I welcome those thoughts.
Thank you. I would say that, yes, this is important. I would say my concerns for the previous remain here, but I would like to give some personal experience. This is an area where I have had urologic procedures over the years with 2 different clinicians in 2 different practices. The first one was notably not available by portal or telehealth and very slow in responding by phone. And when I had pain and bleeding and ended up in the ED, I fired him. And the second urologist I engaged after interviewing several uses the portal extensively, and within a business day, she was clear with complications, like which complications were emergent and which were urgent, and so how to respond with the different levels of complications. And they let me know when they were away and somebody else would be responding. So the customer service was so much better. And I would say my anxiety was less, which may have contributed to better outcomes. But I also think, that I told my story. Anyway, so that's my experience. So that's all.
Well, Danny, thank you very much for sharing that experience. I definitely think it speaks to some of the variability that we see with some of these facilities. And obviously, one of the reasons why we have these measures is to try to improve the overall quality of care. And there are these different interventions that these facilities can do, and you experience it firsthand, how certain facilities maybe use the portal feature a lot more actively versus not. So thank you for sharing that story. I think that's helpful for the community to keep in mind. Let me open it up to the committee. I summarized some of the talking points and things we discussed previously related to the last measure. Are there anything new related to this measure, or any of those topics in the scope of this measure that is new that you'd like to raise, or even to any of Dr. May or Danny's comments? Paul, yes, go ahead.
This is pretty trivial, actually, but I'm just curious. The general surgery measure is reported, I'm reading like some of the documentation, it's the predicted number over the expected number. And then these other measures are standardized against the national average. And then the colonoscopy is, standardized, but multiplied by 1,000 instead of 100. So just kind of curious about the logic behind that, and, any concerns that it might cause some confusion among people that are looking at this at the end, that, that you're just looking at it like, well, these colonoscopy rates are really, it's much more dangerous than general surgery, or, whatever, just not knowing that it's been changed.
Thank you, Paul. So maybe get some clarification from you, Doris, on that.
Sure, definitely. Yeah, we understand the confusion, and internally it gets confusing also. So it's totally accurate. So this measure and the orthopedic measure are reported as a rate. So they're times the national rate. The general surgery measure that we talked about is expressed as a ratio. And my understanding is that because facilities are performing such a different mix of procedures, that we can't multiply it by a national rate, because there are different national rates for each one. And so that ASC general surgery measure just has a different, this patient mix issue that makes it hard to multiply by a national rate. Whereas with these other measures, we're able to do that. So it's easier to interpret a national rate. So we have gotten feedback that they wish that ratio measure was expressed in a different way to make it easier to interpret. We definitely hear you there. And there are different ways we can express a ratio to make it more interpretable. Like you might be familiar with the infection ratios that are expressed, and there are different ways of expressing them as worse or better than national average or something like that. And then the colonoscopy measure was expressed as the number times 1,000, because the outcome rate is so low, it's difficult to interpret a measure at the, humans are just better at interpreting whole numbers rather than decimals. So that's an ease of interpretation move on our part. Does that answer your question?
Thanks, Doris. Yeah, does that answer your question, Paul?
Yeah, that makes sense. I'm just wondering, I'm just thinking about if we put it all in front of consumers and they're trying to read it, would that you know, cause, not that people particularly like to read numbers anyway, but
Yeah, I think the ratio one's probably the most difficult one. When I worked before on the standardized infection ratio, we always had to express it as the percent greater than or percent over the national average or whatever the comparison was, and that made it more interpretable. So that might be something to think about.
makes sense. Thanks.
Thanks, Doris. Thanks, Paul. Chris, your hand, and then Amy.
Yeah, hi. Basic question, I guess, here. Do these urological ortho and colonoscopy procedures feed into the general surgery metric?
No, they're mutually exclusive, so there's no overlap.
Perfect. Thank you.
Thanks, Chris. And Amy? Nope.
Wait, yeah, I just had to, no, I had to find my unmute button. So, okay, so they're mutually exclusive, so there's no orthopedic or urologic procedures in the general measure at all. Okay, got it. Great.
Yeah, this also came up during our advisory group discussions, and was a good question, good response. All right, any others? Any new topics? Anything, again, questioning your endorsement of this measure, your continued endorsement of the measure? We'd really like to get that out there and kind of consider it here. The last call here on this one. I believe if I'm not hearing any other concerns here or questions, I would like to propose that we move forward with the same conditions as we had on the first measure, which again was to explore those methods to enable the evaluation of improvement over time. Doris was alluding to some of those results with this one. And then also consider that additional approaches to reliability assessment, improving informs the reliability validity and the reliability usability trade-offs. The same conditions placed on the measure, but still want to open it up for any additional new topics, questioning your concern, your ability to vote to continue endorsement. So thanks, Chris. Full agreement. Going once. Going twice. Okay. Amy, Danny, anything from you? Does that sound okay?
Sounds okay.
Sounds good.
Okay. All right. So Doris, any comments, remarks on this one? No? All right. Let's move to a vote. Isaac, I'll turn it over to you.
All right, the vote should show up in just a second. Voting is now open for measure 3366, hospital visits after urology ambulatory surgical center procedures. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, or remove endorsement. We're expecting 15 votes. Waiting for 3 more votes. Waiting for 1 more. Pamela, are you able to send in your vote?
I'm having trouble. I'll just email it. Sorry.
You can send it to me directly in the chat and we can move forward.
Great.
Pamela's vote will be a 15.
Thank you so much. And thanks, Pamela, for sending that to Isaac. All right, I'm going to take a little bit of a breather. And sorry, Doris, I know you're still up. I'm going to turn it over to my colleague, Meredith Eastman. Similar type of situation here, so keeping that in mind, everyone, with this and those conditions as well. So Meredith, I'll turn it over to you.
Thanks, Matt, and hi, everybody. Been listening intently throughout the day, throughout the morning, and looking forward to continuing the conversation on these next 2 measures. So this one is 3470, which is hospital visits after orthopedic ambulatory surgical center procedures. So this is the facility level risk standardized rate of acute unplanned hospital visits within 7 days of an orthopedic procedure performed at an ASC among Medicare fee-for-service patients aged 65 years and older. An unplanned hospital visit is defined as an emergency department visit, observation stay, or unplanned inpatient admission. This is again a Yale core and CMS measure. It is in maintenance. It was last reviewed in fall 2018, and the current planned use is the same as the previous ones we've been discussing: public reporting and quality improvement with benchmarking. Similar to the other measures, this is an outcome measure. The target population is Medicare fee-for-service patients aged 65 years and older. This time who have undergone an orthopedic procedure at an ambulatory surgical center. The care setting is the ASC, and the level of analysis is the facility. So I'll actually check with you, Doris, to see if you have any remarks that are unique to this particular measure that you wanted the committee to keep in mind.
Thank you. Yes, so sorry you're still hearing from me for the most of the day. So for this measure, I think the real notable thing and the big change from the last time is that hip and knee replacement. It was moved to the ASC covered procedure list. So that set of procedures is in this measure. And so that is, again, the reason why we hesitated to compare performance from the last measure, the last cycle of endorsement, because of that big change. That said, during the break, I did go back and look at it anyway, with the caveat that this has been a big change to the measure. And despite that, there's been a tiny change, a tiny improvement in the distribution of measure scores. And it's quite small, but maybe because a higher acuity measure or higher acuity procedure was added to the cohort, this might give you confidence, but I don't know. So for example, I'll just quote the 25th and the 75th. The old data, which is 2014, 2015, the 25th percentile was 2.4. And in the current submission, which is 2021, 2022 data, the 25th percentile is 2.12. So that's 2.4 to 2.12. And then the 75th is 2.6 to 2.26. So a small change, and that's again across the distribution, where from min to max across both years comparison, there's been a slight decline despite the addition of highly more complex procedure in the outpatient setting. So, or the ASC setting. And I think that was all I had with respect to this measure. It's otherwise constructed the same way as the other measures in terms of the outcome, and it had the risk adjustment model obviously is different because it's a different set of different cohort.
Great, thank you so much for that. So I think we can advance to the discussion points slide. These are, I think, identical to the previous discussion points. So I think these are pretty fresh in everyone's mind. So I did want to just turn it over to Dr. May to see if you had any reflections or thoughts about this particular measure that you wanted to make sure the committee keeps in mind.
Nothing additional. Thanks, Meredith. I think everybody has put out as much as they can over the last two.
Great, thank you. So turning over to our patient partners, Danny and Kim, if you are on, this particular measure, anything unique about this measure that you wanted to call attention to for everyone?
Nope. Thank you.
Okay. So let's open it up for committee discussion. I think with this measure, we would have the same conditions as the previous ones, but looking for anything unique, uniquely concerning, unique questions about this measure that might affect your vote. So Christopher, I see you have your hand raised.
Thank you. Doris, thanks for your overview and the addition of the new conditions. Can you tell me what the top three conditions were prior to this hip and knee addition?
Prior to adding this or after adding it?
Prior. I'm trying to think of what procedures are done.
Sure, sure. You know, I'm gonna have to look back at our methodology report. Believe it or not, I don't have the
Huh.
frequencies of all the procedures, but while other questions come in, I'm gonna look at the last methodology report, and this would be back from when the measure was first developed.
All right, I'm just curious about that.
Yeah,
Thank
yeah, no, I understand. I get it. I was doing the same thing for urology just last night. So.
Okay, thanks.
Great. Any other questions or considerations that are unique to this measure, focusing on the orthopedic surgeries that we may want to raise? Amy, yes.
I think this like kind of goes back to Oliver questions about like comparisons, right, across these facilities. So I think it's just true of all the measures that there's going to be a wide range of procedures varying in a complexity. Do you look at the blend of procedures that a ASC does? Like, are they only doing the simplest procedures versus doing the whole range of procedures? Like I know in another ASC ranking system, they had included back injections, like essentially like ultrasound guided back injections as a procedure. And then there were essentially pain clinics that were like ASCs that were included in that ranking. So, like what are the efforts to kind of get equivalent ASCs or identify whether ASCs are equivalent?
It's a great question considering we've heard that ASCs tend to specialize. So yeah, I don't know if others on the committee have thoughts in response to that, or if not, Doris, if you have a response.
Sure. So we include procedures that are more complex. So we don't include, and this measure, it's probably less relevant, but for the general surgery measure, it's more relevant, where you might have very minor procedures, like just a minor skin procedure that wouldn't actually count as a surgery. And so we use an indicator called the GSI, which is a measure of basically of procedure complexity, to look at only the more complex procedures. So we're at least narrowing the field that way. That said, there's still going to be a mix of different procedures at different facilities. That's just the way it's going to be. But that's why we have them grouped by, rather than have one giant like HOPD surgery measure where we're looking at all procedures, we at least have them grouped by specialty type. And within those specialties, there are going to be different, which is why we then look at risk adjustment and see, how well the measure is risk adjusting across the entire cohort of patients. So if you look at our calibration plot that we submitted in our attachment, let me just see what figure number that is. That is figure 4. You can see that the predicted and observed outcome rates are correlated very tightly. They line up with each other. So it lets us know that the risk adjustment model is working in order to balance that difference in patient mix between the facilities. So that's what happens with the orthopedic measures. With some of the other measures, and I believe it was true for general surgery, let me just pull up that for a second. We actually had in the risk model procedure types. So there are times at which we have to actually risk adjust for the procedure type in order to account for that, I won't call it service mix, but I'll call it patient mix. So for the general surgery measure, we had 5 different procedure types like breast, skin, wound, and vascular. For the orthopedic measure, we didn't need to do that. And for that one, the risk variables are really more comorbidities, as well as procedure complexity. So the RVU. So the RVU is another way to correct for sort of the more complex procedures versus less, but we didn't have to break it out into subsets of orthopedic procedures for this particular measure. So we take a different approach depending on the needs, of that particular procedure. But yes, thank you for showing figure 4. And so we're pretty sure there that the risk model is able to adjust for that. If it weren't, we might see, like, for example, that the observed the observed outcomes might be much higher than predicted, or the other way around, and then we would know that our risk model wasn't performing well, and that may be due to differences in wide differences in risk among those patients, which would reflect their different procedures that were being done. So we feel pretty confident in this measure that the way we approached it is accounting for risk. A list was just put in chat, I believe, of the types of procedures in the measure. I'm not sure those are by frequency, but we'll continue to look for a frequency table. I know in one of the reports we had one, but we'll have our team looking for it for orthopedics. Sorry, did that answer the question that was asked?
Amy, did you have any follow-up on that?
No, I think that was great. Thank you.
Super. And Chris, I think you have your hand up.
Yes, thank you. I think it's a variation of another question, but I'll ask it. It's my understanding that hands and feet are run out of specific shops, like it's clinics for hands and clinics for feet. Am I wrong?
I believe that is true. I have seen because, okay, so it depends on how the ASC is organized. So there's a lot of different types of ASCs. There are individually provider-owned ASCs. There are ASCs that are owned by hospitals and providers, and then there are ones that are hospital-based. They're hospital-owned. So I think you probably see a wide range there of the types of procedures that are being done across those different types. And I once actually asked someone, in the case somebody brought up pain, I noticed through a MedPAC report that the number of pain ASCs had increased dramatically. And I was asking someone on one of our TEPs, what's going on? Why is that? And the person said, and this is kind of cynical, but probably true, that the providers were organizing as ASCs so that they could get the facility fee. Yeah. So what they were seeing were basically groups of providers that were organizing as ASCs. And so I guess what I'm trying to say there is that sometimes you'll see people who are focusing on particular subspecialties that are then organizing as an ASC. So you might get like a group that focuses on a foot or that focuses on hand, although there are other places that do a wide variety of procedures. So I think it reflects, as maybe we're not surprised, the physicians that belong to that ASC.
So then the measure, I mean, if I'm a foot specialist, this measure does nothing for me if my facility is organized for feet.
No, it does, because those procedures are going to be in there as well. So I think that it applies across the board, whether you're doing broad procedures or narrow. In the realm of orthopedics, the whole thing is a little bit more narrow, which is why we don't have these subsets of adjustments. Whereas for the general surgery one, we had to, like I mentioned before, we have in the risk model, variables for subsets of general procedures, because general is so broad. We had to do it that way. But we didn't need to do that for this procedure. Again, if you looked at that risk decile plot, you could see that there isn't, we're predicting well depending on the outcome rate for that type of procedure. So we're not finding that it's not adjusting for things like that as a problem.
Yeah, I mean, it's a facility comparison, right? And it's not.
Yeah, it is, but we have to also look at whether, so let's say a patient is receiving, I'm thinking more in terms of the risks of the procedures rather than the types of procedures. Because if you think about how payment is done in these facilities is by Medicare, is that they're grouped by the sort of similarity in outcome risk for different procedures, and because they pay based on sort of how hard a procedure is. And so as long as we have similar outcome groupings together, then our risk model is going to work well. But if we have a facility that's doing only high risk things, let's say, and we might see this going forward, and we'll have to watch out for it. If there's only a group that's doing hip and knee replacement, and they have, and you would predict that the outcome rates for those patients would be much higher, that might be an issue. So far, we're actually not seeing that being a problem. But I think we have to look at it as rates of hip and knee replacement increase if the risk model is adjusting appropriately for that group of patients. And for some measures, we've actually looked at the risk model for those patients to see how well it's adjusting.
And you're not seeing that in hands and feet.
We have not broken out the risk model for that right now. I'm just saying the risk model overall looks well. I don't think that that the outcome rates for that are going to be predicted to be very high. So I would say it wouldn't be a problem. I'd be more concerned about in the future hip and knee as that becomes more common.
All right, thank you.
Great. Thanks for that discussion. Does anyone else have any questions or thoughts they wanted to raise that might affect their vote as we sort of move towards efficiency with this group of measures?
Sure, and if it's okay, this is Amy at Yale Corps. I can jump in with what the top procedures were, at least in the, I think I'm looking at the original methodology report. So this is 2014 to 2015 data. The top 5 listed are incised finger tendon sheath, arthroscopic rotator cuff repair, knee arthroscopy surgery, another knee arthroscopy surgery. I'm using the short description and not the CPT code, and repair of hammer toe. So those were the top procedures at that point in time.
Thank you for that, Amy. So I'm seeing some folks mention no issues. Let me check with our chairs to see if there are any lingering concerns or if you feel like we're ready to vote with those same 2 conditions.
I see Dimitri's hand is raised.
Oh, thank you. I
Yeah.
missed it. I apologize,
Thank
Dimitri.
you. No, I just raised it a second ago. I keep thinking, so it's the third measure that we're reviewing, and the validity is also, for all the 3 of them, the validity is tested by correlating the outcome with the volume. I'm just, as a measure developer, I probably want to see maybe a wider variety of metrics to be correlated with the outcome. I'm just curious if why volume has been identified as a suitable or the only suitable metric, perhaps, for establishing empiric validity.
Ken, is it okay if I answer?
I'll just preface by saying I think there was some discussion about a lack of measures for ASCs
Yes.
available to correlate with. But go ahead, Doris, if you had something to add.
Yeah, that's definitely the main issue, but stepping back to the evidence that we supported for validity. So we started with face validity, which is, admittedly weak, but that's what, we all start with. And then we moved on to looking at the reasons for the return to the hospital. So that in itself adds to the validity of the measure. We're actually measuring quality because we're seeing patients come back to the hospital. Even the time course of the outcomes that we're measuring, they're very frequent at the beginning and taper off at 7 days. So they suggest they're related to the procedure itself. And then you have to look at the codes. So that was the second piece of validity. The third is actually the performance of the risk model itself as a supportive validity. And then the final was volume, because we didn't have any other measures. And we had a brief discussion about, what is the volume outcome construct? What does that really mean? And there are a lot of underpinning complexities to it. Does it mean surgeon volume? Does it mean lifetime volume? All the things that volume could mean. Although it's been well described, not the actual construct, but the relationship between volume and outcome is well described in the literature. And we felt like it was the information we had at hand that we could provide. We're just pretty limited in that this is, a claims-based measure, and there's no other public data for ASCs at all, which underscores the importance of the measure.
Yeah, fair enough. Again, I was hoping to maybe see the relationship with some kind of patient characteristics, perhaps, if that's appropriate. I understand your argument that risk adjustment model per se can be used as an indicator of validity. I'm not sure I fully kind of buy that argument. These are 2 different things, and I come from the psychometric training, so I'm inclined to think of validity in terms of maybe construct validity primarily. So I do see how those 2 are related, but I also see the disconnect. So yeah, again, I brought up this question because all these measures seem to be using the same outcome, which to me almost sounds like a cookie cutter approach. And I know that, you guys can do better than that.
Yeah, no, it's not a cookie cutter approach, actually. It's because we actually had to divide what we may have made a bigger measure into smaller cohorts because of the way ASCs are organized. So for the hospital outpatient surgery world, we have one measure called the hospital outpatient, what is it called? Sorry. Hospital outpatient surgery, 7-day visits after hospital outpatient surgery. And it has all the procedures in it. And actually we're criticized for that, for lumping procedures. So take it as you will. You've got lumpers and splitters, but that one is all together. But ASCs are organized differently. ASCs subspecialize. So for this, we had to actually break it up. So I wouldn't call it cookie cutter. I'd call it like a
Right, makes
suite of
sense.
measures. Yeah.
Yeah, I see what you're saying. No, that makes more sense. Thank you. And I wanted to add, I don't disagree with that approach. It just is interesting to see more or better support for validity instead of just looking at one singular metric,
Oh,
which
I
in this
agree.
case happens to be volume.
Yeah, I agree. I mean, another way, so known groups validity has always, I've always struggled with it because for the most part, if it's a known group difference, it would be in the risk model. So it would be fine to look at that. Like we could say, well, patients who have trauma should have higher outcome rates than patients who don't. And they do, and that's why it's in the risk model.
Right.
So
yeah. It's permissible to, I guess, check for the association using the non-risk adjusted scores, the observed scores, I suppose. But I get your argument.
Yeah, no, we know they have higher rates, which is why they're risk adjusted for. So it's like that's in a way why the risk model, the variables in the risk model themselves speak to that known groups difference. So if you look at the variables, you can say, yes, you expect patients that have those diagnoses to have higher outcome rates. And then you can see their odds ratios in the table.
Right.
Yeah.
Thanks for raising that, Dimitri. I think it's an important point that we should, think critically about how we're examining validity, not just for this measure, but for all measures, and avoid sort of cookie cutter approaches. I see a few other folks signaling no issues to raise. So let me check back with our co-chairs, Amy and Danny. Do you feel like we're ready to vote on this?
Yes.
Yes.
Yeah, I think we're ready.
Okay, so let's move to the vote. As Isaac is pulling that up, I'll just reiterate the conditions for everyone. The condition is the conditions are when this measure comes back for maintenance, we would like the developer to explore methods to enable the evaluation of improvement over time, and to consider additional approaches to reliability assessment that informs the reliability, validity, so the shrinkage, and reliability, usability, the stability trade-offs. So those are the two conditions there. Over to you, Isaac.
Voting is now open for measure 3470, hospital visits after orthopedic ambulatory surgical center procedures. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. We are expecting 15 votes. While we wait for a few more votes, I want to remind everyone on the call that we are not displaying the results today because we don't have voting quorum, which is 80% of the active non-recused recommendation group members. And that number would be 17, but we currently only have 15 of that on the call. We're waiting for one more vote.
I put mine in the chat because my voting thing just went down. I'm trying to get it in my email up.
Thank you, David. As we move forward, would you mind sending your vote directly to me in the chat rather than sharing it with everyone else?
I'm going to try to keep it. If you keep it loaded up a little longer, I'm going to try to reload that voting mechanism.
That's okay. We have your vote, so we can move forward.
Chris, did you have a voting concern?
Yeah, well, sort of. Meredith, when you summarized, you laid out what the conditions were, and I agreed with that. And on the prior measure, I just put endorsed because I endorsed what you said. But am I supposed to put endorsed with conditions if you lay the conditions out?
So Chris, I'll chime in here. So Chris, if you feel that the measure doesn't need conditions,
then you endorse.
You would vote endorse. If you feel that the measure should have the conditions that were outlined, then you should vote to endorse. If there were still, after all of those discussions, and even with the conditions placed, you think the measure should have its endorsement removed, you can vote that way. If that helps provide clarification.
That's good. Thanks.
Okay.
Thanks for that, Matt. So we are moving forward to the next measure, which is number 2539, facility 7-day risk standardized hospital visit rate after outpatient colonoscopy. So this one is the facility level risk standardized rate of acute unplanned hospital visits within 7 days of a colonoscopy procedure performed at a hospital outpatient department or ambulatory surgical center among Medicare fee-for-service patients aged 55 years and older. An unplanned hospital visit is defined as an emergency department visit, observation stay, or unplanned inpatient admission. The measure is calculated separately for ASCs and hospital outpatient departments. This is a Yale Core and CMS measure. It is in maintenance, last reviewed in spring 2020. And it is used for public reporting and quality improvement with benchmarking as the previous measures. This measure is an outcome. The target population is fee-for-service patients aged 65 years and older, and the care settings are ambulatory surgical centers and hospital outpatient departments. The level of analysis is the facility. So let me check. Doris, did you have some opening remarks you'd like to make for this measure?
Sure. Thank you very much. So this measure has been out there much longer than the others. I think it was first implemented in 2017. So it's had a much longer time out there in the field. It does focus on colonoscopy related procedures. So the cohort is much narrower. It also has a larger cohort because there are so many procedures that are done. I think if you add up ASCs and HOPDs, it's something like 4 million procedures. However, that's over a 3-year period. So the other 3 measures were 2 years. This one's a 3-year. And that was done actually to improve reliability because the outcome rates are super low, but and they're expressed per 1,000 procedures. That said, though, because the cohort is much more narrow and the measure's been out there a long time, we were able to robustly show improvement over time in both the HOPD and ASC setting. So I think it's really a real good example of how the whole cycle of measure development with a lot of public input followed by implementation and public reporting will result, can result in improvement over time. So it's really the example I hold and where I see the other 3 measures following if we, continue to report the measures and to engage with facilities and with consumers to let them know about this information. So I think that was all I had about colonoscopy. Just reiterating that it's for both HOPDs and ASCs, so that's different than the other 3. And they're calculated separately and reported separately. And I'd love to answer any questions you have.
Great, thank you for that, Doris. And I wanted to let everybody know we have another subject matter expert joining us for the discussion of this measure. Tariq Yus is on. So Tariq, I know that you have taken a look at the measure information for this measure. Wondering if you had any thoughts you wanted to share with the committee about importance or any clinical items to discuss.
No, thanks for the introduction. Yeah, I think it's a good measure. I think there are some concerns that I'm guessing the committee is probably going to review here in terms of reliability and understanding its overall impact. It sounds like it's been around for a little bit since 2017, and so there's been there's been an improvement that's been measured. but just curious to hear what the committee has to say on that, because perhaps I've understood this incorrectly when I reviewed it, but when I looked at it, it seems as though there's a very small group of outliers currently. And so I'm just wondering if that means that from 2017 to now, we've done an amazing job, and do we just continue this measure, or is it more to do with how the measure is currently set up? Happy to chat more.
Great, thank you. So before we go back to you, Doris, for your thoughts on that, I did want to get the perspectives from our patient partners. Danny, I think you are still with us here today. Did you have any reflections or thoughts you wanted to share on this particular measure?
Well, thank you. You know, being an old white man, I have certainly had my share of colonoscopies. And I would say that I think over the years it has changed, especially the preventative activities associated with it. I received verbal instructions before and after and written, but I have never received post-procedure follow-up. And I have never had my wife included in any of the discussions, even though she's present as the person who takes me home for each one, which I would think would, if I was running the shop, I would improve how that was done. That's all I got.
Thank you for sharing that. It's nice to acknowledge that there has been change and improvement, but there's always more to do. So I appreciate that perspective. Opening it up to the full committee, does anyone have any questions, concerns, things they'd like to discuss that would affect their endorsement vote for this? Sunny, I see you have your hand raised.
Thank you. I think, as the developer mentioned, this is probably one of those measures which is the measure that we're all aiming that the other measures would get to at some point, although this measure still has work. My question relates to a factor which I believe the answer should be no, but I do want to ask the question. Over the years that this measure has been developed and in use, have you seen any unintended consequences or harm to patients with the measure? For example, this is colonoscopy. Have you seen patients not getting required colonoscopies, or increase in their cancer diagnosis, or missed biopsies, or something like that, you know, where unintended consequences have occurred?
Great question, and something I think we should always be thinking about when we're evaluating, you know, measures. What are the unintended consequences associated? Before I turn it back to you, Doris, just want to check to see if there are any other questions to add to the list here as folks are considering this particular measure. Okay, so I think, Doris, if you'd like to respond to, I think Dr. Yuse's question or notice of outliers, and then Sunny's unintended consequences question.
Sure, thanks very much. So the outliers question, so the method that CMS uses to identify outliers, statistical outliers, is extremely conservative and stringent. So it looks at 95% credible intervals, which is akin to a confidence interval, to determine whether there's statistically significant differences between the provider's score and the average. But that doesn't look at the whole distribution. So that improvement that I was mentioning, and you saw the distribution curves perhaps that were brought up earlier, which are figures 5A for HOPDs and 5B for ASCs, you can still see there's a quite wide range of performance that's clinically meaningful within even with the current measure in terms of performance. So the outliers are one thing and one way. It's just one way to express the information. Another thing we submitted as part of our submission was the median odds ratio, which is another way of looking at variation. So I think there are just different ways you can make your look at variation very stringent. You can look at something like the median's odd ratio, which is like an odds ratio, which is about 1.25 for this measure. or you can look at clinical relevance of the range of performance. So I think it's worth it to look at all, all of those things. So that was the outlier question. The other one for unintended consequences, we have not specifically looked at that. I think for what I understand from the literature, the biggest barrier for people obtaining a colonoscopy is the concerns about discomfort, about pain. So I think those kind of things are a concern, and also potential payment issues. And now that they're more widely available as far as payment goes, I think it's less of an issue. But we don't specifically look at unintended consequences. CMS does, however, and occasionally releases a report about unintended consequences. I've not seen this measure show up on that report, the last one I read, but that's the limit of my understanding of that. I didn't expect there to be for this because I don't think that there are reasons for providers to avoid a colonoscopy. If anything, people are recommending them and patients aren't getting them done. It's more the opposite way, that there's more being promoted than being adopted by patients.
Neat. So just want to check back, Sunny or Dr. Hughes, if you had any follow-up based on that response, or if you feel content
That
there.
is what I would imagine, too, Doris. But I was more concerned about at the lower spectrum in the rural areas where the volume size are low and access to care is limited.
No other comments. I appreciate. Oh, I'm sorry, Doris. I didn't mean
Oh, no,
to
you go ahead. Go ahead.
I was going to say, I appreciate Doris talking about the outliers, and I think a great deal of work has been put into this this measure, and so I don't have any other strong feelings.
Great, thank you.
I was just going to make a comment about access. I think one thing we haven't been thinking about is also these procedures can be done in the clinic office. So there's quite a wide variety of places that one could receive this procedure. So hopefully access is less of an issue. It's not like it's just ASCs saying, oh, we're only going to take low risk patients. You've got ASCs performing in them, HOPDs, and in the office practice. So it's quite a wide variety. So, and then also it's an A recommendation, I believe, from the U.S. Preventive Services Task Force, at least colonoscopy screening. So that makes easier from a payer perspective. Although I know this is Medicare fee-for-service, which pays for the whole thing.
Doris, sorry, I apologize if you said this earlier and I missed it. Because this measure includes HOPs and ASCs, in your evaluation, do you adjust for where the procedure is being done between the two, or in a clinic setting? Or one
That's a
can
good
imagine
question.
that. Oh, I'm sorry. I was going to say, one can imagine that if I were referring a patient for a colonoscopy and they had 15 comorbidities, I probably wouldn't send them to an ASC. I probably would perform it at a tertiary center that has an outpatient facility attached to it. But I'm just curious if that was adjusted for, and I'm sorry if I missed that.
Oh, no problem at all. Actually, instead of adjusting, we run them separately. So we have ASCs in one measure and HOPDs in another.
Perfect. Thank you so much.
Thank you.
So, Mahil, yes.
Yeah, no, I was going to ask a follow-up. So is the risk adjustment model, variables and model, the same for HOPDs and ASCs? And do you need to recalibrate? And do you, as volume shifts?
Well, the risk models are the same, but they're not, the odds ratios for the variables are not. So so they differ. So if you look at, I was just actually going to look at that before we started talking. There's two different tables that show the odds ratios. Table 9A is for the HOPD setting, and table 9B is for the, oh, sorry, no, I got them wrong. Sorry, that seems to be labeled incorrectly. Hold on. Yeah, 9A. I'm on the wrong page. That's frequencies. Hold on a second. Oh, I see how we did it. All right, so it's 9B, which is the HOPD risk model variables, and 10B for ASCs. So you can see the odds ratios are, so basically what you do is you take the risk model and then you let the odds ratios vary depending on the patient population. So they'll be, so that's there, and you can look and see whether there are higher odds ratios for different patients in the different settings. And you would
how
expect.
often do you recalibrate the model?
Sorry?
How often do you recalibrate the model, or?
Do you mean reselect variables or
Or run the model and reestablish odds ratios?
We
I'm
every
just thinking,
time,
what would be the impact, if any, of sort of more complex colonoscopies moving to ASCs?
Okay, so very complex things wouldn't end up in the cohort. So that's what's different about this one, is that the cohort doesn't vary as much as the others. So there could be small code changes, and maybe minor things that change, but there wouldn't be like a group of high-risk procedures that end up in here, because we actually exclude high-risk procedures and also colonoscopies that occur at the same time as a high-risk procedure. So it's a little more contained than those other measures. So that's the first thing. And then the second is for every year, not just when we submit for CBE, but every year we assess the risk model. And so we start out doing one thing is we look at the frequency of risk variables and we compare them to the prior time. So we look to see, is there anything weird going on? Do we see a much higher frequency of variable X one year over the other? If that happens, we dig into it. That's the first thing we look at. Then we look at odds ratios. So we're just basically testing the model. We do look at C-statistics and we look at calibration. So the calibration plot is really the one that I always look at because we want to make sure that with new data, the existing model is still performing as well as it did when it was first developed, because that's one of the concerns, right? That with the new data, it's going to be changing and then the risk model may not work anymore. With other measures that are older, like measures that were developed, maybe 15, 20 years ago, those measures in the hospital setting are actually undergoing new variable selection. So in huge time intervals, that will happen where we decide, okay, it's time to reselect variables for one reason or another. And then that's a 3-year to 5-year process itself. But right now, this model is performing well. These procedures are more narrowly confined. So I think there's less concern about a change.
Makes a lot of sense. So you're saying that the complex procedures done in ASCs aren't included.
Well,
or complex
HOPDs.
procedures excluded.
Right. So very high risk procedures or high risk procedures done together with a colonoscopy would not be in here. And that cohort is, so this cohort's not the same as the, let's say, orthopedic surgery, where all of a sudden now hip knee replacements are in there where they weren't before. So that's a big change. That's not happening to this particular measure based on the way it's constructed.
Okay, got it. Thanks.
Great, thank you for that. I wanted to get the committee's thoughts on, whereas this is a measure where we've seen some demonstration of improvement over time, if that's a condition you'd like to remove during this vote. So that would leave the condition of considering additional approaches to reliability assessment to inform the shrinkage and reliability, usability, or the stability trade-offs. So just interested to hear if folks feel like we have confidence in the improvement over time piece with this particular measure. So we have Amy, our co-chair, saying to remove the condition over time, improvement over time condition, and Chris agreeing to that in the chat. Let me just ask for any dissenting voices there. Okay. So before we move to a vote, let me just check with our co-chairs to see if you feel like you have what you need to place a vote.
All set.
Yep.
Well, great. And Doris, let me check with you to see if you had anything you wanted to add.
No, thanks. Thank you very much, though.
Great. Okay, so Isaac, I'm going to turn it over to you. Again, just as a reminder, we have the one remaining condition to consider additional approaches to reliability assessment related to the shrinkage and stability issues that have been discussed. Over to you, Isaac.
Voting is now open for measure 2539, facility 7-day risk standardized hospital visit rate after outpatient colonoscopy. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and remove endorsement. And again, we are expecting 15 votes. If you're having issues with the voting platform, please send your vote directly to me in the chat. We're waiting for 3 more votes. Waiting for 2 more. We have 1 vote via chat. Is anyone having difficulties with casting their vote via the voting link? Kimberly, David, are you able to send in your vote? We're waiting for 1 additional vote.
This might be a good reminder if the voting platform is having difficulty, please do send your vote directly to Isaac in the chat.
Refreshing your page usually does the trick. Waiting for 1 last vote. David, are you able to send your vote to me in the chat?
I wonder, is it possible he may have stepped away?
We can move forward. We can leave the voting open for him to cast his vote.
Great, thank you. Okay, well, it was lovely visiting with you all today. I'm going to turn things back over to Matt.
Thank you so much, Meredith. And also to Tariq, thank you very much for your time as well. You may have hopped off. I know David also had hopped off, but both of them being our subject matter experts for the first 4 measures, and very helpful for their perspectives as we got into those discussions. We're going to take a break. Maybe we can, does anyone have any concerns to come back about 10 minutes early? So 2:20 p.m. Is that okay? All right. Sounds good. So let's take a brief break and we'll come back at 2:20 and we'll close out with our last 2 measures. Okay. And just for the committee's awareness, if you lose me on the screen, we're having some bad thunderstorms here in Florida right now. So if I lose power, I'm dialed in. So I'll still be able to listen and facilitate that way, but I'll have someone else from the team recognize whose hands are raised for me. So hopefully we won't lose power where I am, but I'll still be on the call. So thank you for bearing with us if that is the case. All right, so let's pick back up. The CBE number 3495. This is the hospital-wide 30-day all-cause unplanned readmission rate, or HWR, for the merit-based incentive payment system, or MIPS, eligible clinician groups. And I think here it's just focusing on this as eligible clinician groups as opposed to individual clinicians. So we'll refer to that when we get to the discussion slide as well. You can see the description here. This is a respecified version of the hospital level measure, which is the hospital-wide all-cause unplanned readmission measure, which was NQF or now CBE 1789, which was developed for patients who are 65 years and older, are enrolled in the fee-for-service Medicare, and hospitalized in non-federal hospitals. It's a respecified measure which attributes hospital-wide index admissions to up to 3 participating MIPS eligible clinician groups, again, not individual clinicians, rather than the hospitals. It assesses each provider's rate of 30-day readmission, which is defined as unplanned all-cause readmission within 30 days of hospital discharge for any eligible condition. The measure reports a single summary risk-adjusted readmission rate. It's derived from the volume-weighted results of 5 different models, one of which of the following specialty cohorts based on groups of discharge condition categories and procedure categories. So surgery, gynecology, and then we have general medicine, cardiorespiratory, cardiovascular, and neurology. Again, the developer is Yale Core, steward is CMS. Maintenance measure last reviewed in fall 2019, and current and planned use is public reporting, a payment program, and the quality improvement and benchmarking, specifically external across other organizations. It's an outcome measure. You see the patient population in the description there, care setting, clinician, office or clinic, or hospital inpatient, and again, clinician group practice level of analysis. Doris, I'll turn it over to you for your overview, and then we can dive into the discussion.
Great, thanks so much. So hold on one second, just want to make sure I've got everything here. So this measure, I'm going to refer to it as MIPS HWR, just to make it a little shorter. So this measure is now, think about, shift your mind from the outpatient setting, because this is what I have to do to myself too. We've been talking all about outpatient facilities. Now we're talking about the hospital setting, inpatient setting. But we're talking about attributing a hospital readmission to a clinician group. So these are clinicians that are accountable for the care of the patient that's in the hospital. And we'll talk a little bit about the attribution approach. But this includes the physician who discharges the patient at the end of the hospital stay. So that's one attributable person or MIPS eligible provider. And then you have the inpatient provider, the person who is mostly caring for the patient while they were an inpatient, which can sometimes be the same as the discharging clinician, but that's the other attributable clinician eligible group. And then the third one is the outpatient provider. So the one that's sort of responsible for that care coordination for following up after the hospital visit. So those are the three provider types or groups that this outcome could be attributed to. As Matt mentioned, it's a claims-based risk-adjusted outcome measure, and we're looking at 30 days after the hospitalization is over and looking only at unplanned readmissions. Just like the other measures, we're looking at unplanned hospital visits. So this is an unplanned readmission. And it's only calculated for clinician groups with at least 200 patients. So it's really only for those larger groups. It's a claims-based measure, so it doesn't require any burden for the clinicians to do anything. CMS just calculates it. There's a wide range of performance, as you can see by the information that we submitted. Overall, CMS has developed a large suite of readmission measures. So there are ones that for hospitals, there are one for skilled nursing facilities, there are one for inpatient rehab facilities. So there's a whole group of these measures, and CMS is trying to be consistent across care settings so that there are measures that hold providers accountable across the board so they can more likely see improvement over time. Because if you're only looking at improvement or quality in one area, then you might not see it improve in the other. So that's why CMS has really taken an approach where they're applying measures across different settings. And this is one of them where it's applied across the setting. Similarly to the other measures, why are we measure all-cause readmission? In this one, it's a little bit different because we're talking about 30-day all-cause, and we're looking at a much broader sort of set of care that's happening with patients, many of them who have chronic conditions. So the all-cause approach results in quality improvement efforts across the larger aspects of care coordination and post-discharge care. And we know that there are evidence-based interventions that are targeted at reducing readmissions, and they result in declines in readmission rates. And this wide range of best practices related to high quality post-discharge care, things like educating patients and reconciling medications, means that lapses in those best practices can cause this cascade of events that result in a rehospitalization. So for example, if you don't have post-discharge medication management, you could get hypoglycemia, the patient could faint, fall, and go back to the hospital. So in this general all-cause approach, you'll see across many CMS measures and all of the readmission measures overall, including this one. Also, we know that there are interventions that clinician groups can implement that we know reduce all-cause readmission rates. For example, again, these transitions of care. So communicating with patients, reconciling medications, ensuring follow-up visits. And there was actually a study that looked like the number of interventions that provider groups did was associated with their reductions in readmission rates. So you can see that it requires really multiple of these things to make some movement, but it's something that providers can do. In addition, the attribution approach that was developed for this measure is aligned with where these interventions are targeted. So like, for example, the discharging clinician who's responsible for ensuring proper discharge instructions for self-care The inpatient provider, as I mentioned before, who might be a surgeon, is responsible for the patient during the hospital stay, and the outpatient provider is responsible for timely follow-up after the hospitalization. So those interventions are all responsibilities of those different attributable entities for this measure. Importantly, the measure is risk adjusted using claims data from the prior year of the hospitalization, as well as from the original index hospitalization. We adjust for the principal discharge diagnosis from the index hospitalization also. And as Matt mentioned, there are 5 different risk models. So remember before we were talking about having 4 different ASC measures. Well, right now we have the sort of the equivalent of that, 5 different models that group patients by how they're cared for in the hospital. And then those resulting, the results for each of those models is combined into this HWR measure score. Those subgroups, as I mentioned, reflect how care is delivered in the hospital. And having separate models allows us to risk adjust differently, because you can imagine that outcomes for a surgery patient might be much different from a neurology patient, for example. I think we can talk about social risk factors a bit, maybe in our discussion. I don't want to take up too much time, but we did look at the impact of social risk factors. And while we do see that there are differences in unadjusted rates for the different cohorts of the measure, once we look at the relationship between how the proportion of patients that providers treat who have social risk factors and their measure scores, we don't see a correlation, a meaningful correlation. And so we're not seeing really an impact of those social risk factors on measure scores. So that is why there is no adjustment of the measure itself, but CMS adjusts at the level of payment through MIPS by allowing clinicians to earn bonus points for caring for patients with complex conditions and dual eligibility also. So we'll look forward to discussing this measure in more detail and answering all of your questions.
Great. Thank you so much, Doris. Appreciate that. So let's dive into our discussion points here. There's 3 of them that came through. Again, these are not limited here. If you have others, we definitely will open this up. But for our attribution piece, this really came from our advisor group feedback. There was also some recommendation group members that drew attention to this as well in their reviews. So, does the measure really accurately categorize the clinicians into performance deciles? The concern here is about that attribution methodology. It links those physicians responsible for the greatest costs, like the surgeon, with a hospital admission, which may be beyond their control. And also some comments like this really does make sense for hospital measure, but thinking and questioning whether or not for physicians, specifically physician groups. Now, in response to that, the developer did clarify that the measure applies to clinician groups, not individual clinicians. And as Doris mentioned, to qualify for this or to be included in this, they must have at least 200 of these admissions in a year for the outcomes to be attributed. Now, in their response as well, which is not listed on this slide, the developer, about the 6 attribution approaches, and they actually worked with their TEP to identify that 3 provider attribution approach, which was the most relevant way, according to that TEP, for them to provide fairness to the providers captured. Not included on the slide, but also in the response in the discussion guide, was that the developer also notes that higher reliability increases the likelihood, or reduces the likelihood of misclassification. So thinking about how these providers are classified in the high reliability here, according to the developer, and they cited a literature as well to support this. The higher reliability reduces that likelihood of misclassification. And for the committee's awareness, the minimum reliability values that were found here were above 0.6 for all clinician groups with at least those 200 patients. Except for the surgical cohort, there was a range that was provided, sort of a minimum and max. The minimum there for the surgical cohort was 0.49. So maybe we can see if there's a way to speak to either interquartile range on that surgical cohort, just to see where that 0.6 lies. But for all the other cohorts, the reliability was above that minimum of 0.6 that we've discussed and heard about previously. So again, that argument that reliability reduces the likelihood of misclassification. The second there was mortality. So there was concern that there was an absence of mortality in the mortality assessments in the measure, noting that a hospital could have a lower readmission rate simply because it has a higher mortality rate. The developer did note that they explored ways to address these competing risks, including coding adjustments related to end-of-life care, such as do not resuscitate and palliative care, and they confirmed that competing risks do not have to majorly compromise the measure's effectiveness. Lastly, use and usability. Again, when we're looking at use and usability for a maintenance measure, is it in use? Is there a feedback mechanism, which there is for these here, but there wasn't any, at least from the developer, they stated that they didn't have access to data to look at a span over time to sufficiently compare performance for this measure specifically. They did provide results from that 1789, the hospital-wide readmission measure, and they, seeing improvement on that measure. Just for some comparison here, but again, not seeing the results provided for this clinician group measure. So I'm going to turn it over to patient partners. I think Danny, you might be the only one on here. I'm not sure if Kim's come back, but please go ahead if you have any perspectives on the importance or any questions, concerns you might have from the patient perspective, please.
Thanks, Matt. Yeah, so this was the only measure that when I shared with peeps that I was, involved in this. And this is the only measure that drew any interest and conversation. And the kind of comments that people made were about systemic issues rather than individual issues. And I would say, here's my list. Primary care access, GYN deserts, and rural access, and then urban, closing the New York Beth Israel closing and Steward Health going bankrupt in Massachusetts, that these are all factors that impact readmission rates because follow-up is much less available. Now, I don't really know where this fits in this category that we have. And, maybe you all can help me categorize this, but this raised interest of people.
Thank you, Danny. So drawing attention to, that potential readmissions are impacted by access issues, and especially for primary care in rural and even urban settings. And I know that we have David on the call. He's a rural healthcare provider. Could definitely speak to some of those concerns or similar issues, and also a GYN desert. So again, access being a common thread here when we're thinking about admissions and how patients can actually prevent those by seeking care elsewhere. Thank you, Danny. Other committee members, we don't have a subject matter expert for this measure, but any other committee members, thoughts on Danny's comments from you, or something new, something that is on this slide that you want to draw attention to? Chris.
Yeah, Danny, when you say there's interest or impact on readmissions in desert areas, let's say, are you saying that readmissions are higher, or they would be lower because people just don't follow, they don't follow up because they can't, or both?
I'm not saying either. What I'm saying is that one of the things that I try to do in my role as a patient caregiver activist is to help people care about this work that we're doing, because basically nobody cares. But this particular item, when I shared this readmission rate measure, there were definitely people who had questions and had expressed concerns. And what I listed were the things that they brought up that made it difficult for them to get care after they were discharged, which might lead them to then be readmitted because they couldn't get the interim care that they wanted. Now, whether those numbers went up or down, I have no idea.
Yeah. Chris, any follow-up on that one?
No, that's good. That answered my question.
Great. I do see David and Mahil. And Danny, I appreciate you saying that comment. I feel that you and where you are and where you sit with your health hats, reaching out, there is some care here, bringing these comments back that you're sharing with us. I think there's some care here. I think it's just how people are are translating that. And I think you have always tried to be that translator to some degree through your health hats, and I applaud you for that. David, you had your hand raised, so please go right ahead.
Yes, I've always struggled with this this quality measure for a while, and I think the real reason, I practice privately. I have a group of 4 nurse practitioners, another physician. I do all the hospital medicine for our group. We typically keep 10 to 12 patients in. We have a lot of high acuity in our practice, and so forth. But we also live in an area where the ER admits literally 42 to 43% of all patients that come through the door. So this is a factor where it's outside of our hands. And when you look at it across the whole country, so it's really dependent on the ER doctor a lot of times, where they're unnecessarily admitting people to the hospital system. And so from a physician such as myself, this leads to a strong sense of frustration and so forth. It's something that's not going to necessarily be attainable, especially when you're comparing our numbers to other areas. We have access in our office to get patients in literally the next day or even the day of. We have walk-ins allowed. But we also live in an area that's a climate of a lot of ER admissions, and that's frustrating. I guess the other thing to look at is with this measure is the tendency to discourage groups that are admitting to have people with high acuity in it. I mean, if you're going to get dinged every time you admit somebody to the hospital with a lot of problems, you get them out, you follow up with them, then you're finding them getting readmitted to the hospital. I think I think it tends to shy people away from that. And I have seen evidence of that in our area, at least. So those are just a couple of things I see from an observational standpoint as a clinician. I get the need for this. I think we should do a better job with the post hospital follow-up. And I think that's the more important issue, is how good of a job do we do the post discharge follow-up. I think that's what we should be looking at and focusing most, which I hope I haven't sidestepped or gone into the weeds on this too much, but that's just how I feel.
No, David, I appreciate that. And if I may, you mentioned sort of out of your hands or not attainable, with these ER numbers that you were quoting, and you're coming from a rural perspective, do you think that might be an access issue? And that's why these ER visits are at the rates they are where you are, or something else? And I also asked, you say out of your hands, and then you mentioned the post-discharge follow-up. Are there other things that are in your control or in the hands that maybe could be attainable?
So our area,
two pieces of this.
Our area, we're in Southwest Indiana, and we've got 2 hospital systems here. We're not a university setting. Our community is not a university setting. And I think that's part of the thing here in our area. We have a large draw. We have a lot of rural people who come into our area. We have 750,000 patients who come into our town, our community. So when you look at what's happened is we're not a very attractive area. We're not Salt Lake City. We're not Las Vegas. We're not upstate New York. We are literally Southwest Indiana. And so you don't have the number of specialists coming in here. You don't have the number of cardiologists coming in our area. And so we're a semi-small urban area, but basically functioning in a rural-like setting because of lack of availability and lack of access. And what I've seen even outside of our area is the lack of access to some of the specialists that are necessary with these people of higher acuity. So, is it feasible if you have someone admitted with CHF, you're admitting them, you're discharging them, can you get them a 1-week follow-up with cardiology? Probably not. Can you get them a 1-month follow-up with cardiology? Probably not. And if you do, it's going to be with one of the nurse practitioners there. They may have the expertise, the background, they may not. And so I don't think that's just unique to Southwest Indiana. I think there's several areas around the country with that problem. And I think, to your point you said earlier, even some of the larger cities where some of the hospitals have shut down, remember, if a hospital shuts down, so do the specialists. So do access to that higher level of care. So I think the real problem that we have is, we haven't expanded graduate medical education like we should, which everyone on this panel probably knows that and understands that. And by doing so, we restrict access to only those, university settings where this is a goal that can be appropriately achieved.
Yeah, thank you, David. I'll definitely move on and see Michiel here, but striking this fine balance with the importance of this measure, plus some of the issues that Danny was mentioning, and David, you kind of following up with as well with some other examples with access. So let me go to Michiel. Let me see if you have any comments on any of that, or if you have a comment on a different topic.
No, I want to appreciate what Danny was saying, sort of keep me out of the hospital. I think is something that people can resonate with, and I appreciate David's sort of, the dynamics are different in a rural area. But want to say, about maybe 12 years ago, maybe more, we actually developed a risk-adjusted hospitalization readmissions measure for a value-based payment program in California that was at 200 physician organizations. And it was a very compelling, actionable measure. So I talked about some measures are worthy of a QI program. The physician organizations really thought this one was. And the fact that it now will complement the incentives on the hospital side to reduce readmissions, provides an incentive for both hospitals and physician organizations to work together. And there's lots of programs addressing this now. So I think it's a good measure, and strongly support it.
Thank you, Michiel. And I appreciate my question back to you. If you didn't say it's like, do you think there are hospitals and these outpatient providers actually starting to do those connections and working together to really try to prevent those readmissions because of the two measures that are existing? And you said there are these programs now. I don't know if you have anything else to add to that, but I'll definitely go to Amy if you don't have anything else to add.
Yeah, no, I mean, there's a sort of body of knowledge, and the organization was the Integrated Healthcare Association in California that we worked with. And so it's been literally 12 years, but just even communication about when my patient is admitted, right, and getting that data flow going. And there's been efforts by CMS to stop information blocking, which was happening. So the ACO programs, worked on the pioneering ACO programs, they really kind of pioneered some of that. And just, what's the right structure for complex care management? Who should be doing follow-up? There's various models that are like RN versus just more social models. So I think this measure is a really great complement, and hospitals have been working on this for a long time. So
yeah.
I think it's a really great measure, and I like the statistical properties of it as well.
Thank you. Thank you for expressing those thoughts as well. Definitely welcome others if you feel the same with Michiel. Important measure. Especially not hearing too many concerns, a good measure. That's also helpful for us to know. Amy, I'll go to you. Any comments on what's been discussed or something new? Go right ahead.
Yeah, I mean, I think attribution is very complicated, and we've seen this in a lot of different measures. I mean, I noticed that we have these specialty cohort groups that are based on on the hospital discharge, right? That is like the index admission. And then that readmission would be attributed to 3 different physicians, and one of them is this outpatient primary care physician group. I guess where do specialists fit in that? Like if you have a discharge that's for a specific surgery or gynecology, cardiorespiratory, cardiovascular, would you still attribute that to their primary care physician, or would you attribute to a specialist that they saw after that index admission? It's just a question, I guess.
Yeah, thanks, Amy. I'll definitely go to Doris for some clarification on the attribution methodology, especially thinking about, these specialty groups. But before I go there, any thoughts from others, either what Amy has said or previous discussions? Daniel, Halvey, and then Paul.
And David.
Yeah, so.
Oh, yeah, David, you still have your hand raised. Sorry, I don't know if that's a leftover. Go ahead, Daniel.
Okay, so my comment, so first of all, I agree with Amy's concerns about attribution, and I would like to hear the answer to that. Also, I do worry about and this is, I think, related to what David was saying before about how some EDs can just have high admission rates, whether admission or readmission, but they just admit everybody. And that really limits the control of the attributed physicians. So what do we really expect them to do? And I mean, I get that there are some successful models with health systems where you have provider groups collaborating with hospital systems to reduce readmissions. But unless you have everyone kind of in the same value-based model, I question what the provider groups can do outside of those models. That they become essentially the victims of this scoring method because they don't have control over what happens in the ED.
Yeah, thank you, Daniel. And that's kind of also what David was mentioning too with the ER rates that he was talking about. Others on the call too, like in this area, Nahil mentioned there are those types of programs that are starting and have been implemented. There's still maybe some that are not. And what can those provider groups do work in those hospitals? Another good point. I don't know. We can also maybe flag that for the developer potentially, but I will open it up to see if others also have thoughts on what Daniel said. And Paul, I'll go to you.
Yeah, also on the attribution, I share some of the same concerns, but also just kind of a operational question on the attribution. It seems like there's the 3 different types of doctor that are all getting kind of the credit for this. And I'm just curious what happens if a doctor plays multiple roles. Do they get, like if they're both the discharge clinician and the primary inpatient care provider, if we're willing to say that they all play kind of an equal role the way that it's shaking out, should that person, or that group then get 2/3 of, kind of an extra weighted experience. So if everything goes well and they were both the discharge and the primary inpatient care provider, should they get extra credit for that?
Great question. Definitely extending some of the attribution questions we heard. And David, you still have your hand raised. Not sure if you have a follow-up question. David Schultz? No? Okay. How about others? Other comments could be something new. We've heard a lot about asking more clarification and attribution, which probably a lot of people are wanting to hear. So that was related to specifically about how the specialists are, how that would work with the specialist attribution, because attribution is definitely complicated, and Daniel wanted to hear that as well. And also what Paul was mentioning about if there's providers are playing multiple roles here, is there penalties, but also extra credit. Chris, go right ahead.
Yeah, where does, I guess this is for Doris, or maybe not. Where does oncology and end-stage renal disease, things like that, fall in the risk adjustment model, if at all? Does it come under general medicine?
Oncology, I'm sorry, it was oncology and renal, you said?
I'm talking about these underlying conditions that really add a lot of weight to a patient's experience, like cancer. Not necessarily cancer is the primary diagnosis, but just having it, and end-stage renal disease also.
Okay, so asking about some patient comorbidities here, how is that accounted for in the risk adjustment model? So thank you. Anyone else? Anyone else? Any thoughts on this? And we heard some positivity from Nahil on this. Are others sharing in that sentiment right now? Okay. I'll circle back on that. So Doris, let me go to you. Maybe you can kind of touch on the attribution approach and methodology. Again, keeping in mind, they did explore 6 different attribution approaches with a technical expert panel. It was very consistent of accountable entities that would be held accountable to this measure to inform. So Doris, please go ahead.
Sorry, I had to get off mute. So I just wanted to say that I was not part of the team that developed the attribution approach, although I did watch them. And what I mean by that is I did attend one of their TEP meetings where they went through these different approaches. And I have to say that it was done extremely carefully and deliberately. So first of all, the team at CORE that developed this, as you can read if you did in the methodology report, or maybe in some of our submission, we explained sort of the approach. By first, we basically gathered up all the possible attribution approaches that we thought would apply based on the data that we're using, and also developed principles for attribution, which actually NQF had developed a report with principles around attributing, attribution approaches. So it was a real focus from a methodology point of view in terms of making sure it was a fair approach. We started out with 6 different approaches. Actually, we started out with fewer than that. And the TEP actually was the one that preferred the multiple attribution model and suggested adding one of the 3 approaches, which is the inpatient provider attribution. So in listening to the TEP is why we came up with something that sounds complex. It's actually pretty elegant when you think about it, but the complexity was added because we wanted to listen to the TEP. So that's the important, I think, a very important point. As far as multiple attribution, you don't have to have, every patient doesn't have to have 3 providers attributed to them. So if there isn't, for example, an outpatient PCP provider, or if there isn't one of the other providers, that doesn't matter. And you wouldn't be attributed twice or dinged twice for the same patient. So that's something to realize. And also that the attribution is rolled up to the TIN level, which is the group level. So again, it's always the group that's the issue, not individual providers in the end, in the end of the day. So let me think, what other questions were the attribution, just like
there was one from Paul and also Amy. So Paul was asking about if providers are playing multiple roles, how does that sort of work? Do they share the credit? Is there weighting going on?
So you mean if someone is both the discharge clinician and the inpatient clinician, for example?
Yes, Paul, is that, I'm not going to.
Yeah, that's right.
Yeah, it would be that, and if that provider if it was for the same patient, it would just be one attribution. So it wouldn't be that they were to be attributed twice or anything like that. And they wouldn't get like extra credit. It's not about credit. It's about attributing a patient to somebody's care. And so if you look at our inclusion exclusion criteria, we actually can't include patients for whom we can't attribute anybody to. So it's really an attribution step in the beginning that then goes to the TIN, and then you've got the measure score. So I'm not sure if I answered your question, but.
Yeah, it makes sense. I'm just trying to kind of figure out if they had more stake in it than the other doctors, and they should get more.
Honestly, some other folks on my team who are way more familiar with this from a methodologic point of view could comment, but I don't think that's how it works. It's just attributing, you want to attribute a patient, and if the discharge clinician and the inpatient clinician happen to be the same, then it's just one attribution. But if they're different, then you would get that patient's outcome would be attributed to 2 different individuals who may be part of 2 different groups, or maybe they're part of the same group, right? So it all depends on where that individual clinician ends up rolling up to. But if you think about it, it made the most sense to me when I was thinking about the care of the patient and where the interventions are happening. And those all line up with those 3 provider types. The inpatient physician. So for example, that could be a surgeon. The surgeon may be the inpatient provider. And that's the reason why we use charges instead of using the number of claims, because we wanted to identify the inpatient provider. That way, when you used the number of claims, you ended up getting primary care doctors being assigned to surgical patients, right? And that didn't make sense. We didn't want to attribute a readmission for a surgical patient to a PCP inpatient provider, right? That didn't make sense. So the attribution approaches are really derived from a face validity point of view. Similarly, the outpatient primary care provider, or we'll call them the outpatient provider. PCP is a little bit of a misnomer. That provider is identified by the number of charges, because that's the way you're more likely to get the primary care, the provider, rather than a surgeon, for example. So we're trying to make sure the right type of provider gets attributed based on the setting of care. I hope that makes sense.
Yeah, it does. I think, I'm just thinking a little bit like if there are three things that have to go right to have a success, right? And someone does 2 of them right, shouldn't they get a little more credit for it, I guess is the way I'm potentially thinking about it.
Yeah, I see what you mean. Yeah. Well, I suppose if they're doing it right, then the other patients will also fall in there, in that way for them. They'll do well on the measure.
Right. All right.
Thanks, Doris. Paul, did you have a follow-up? I wanted to kind of get to Amy to make sure that was addressed. But do you have a follow-up on that one? Okay.
Yeah, so sorry.
Go ahead, Amy.
So like the example you gave, Doris, was that you don't want like a primary care doctor to have a readmission related to a surgery admission attributed to the primary care physician. But it does say that 3 clinician groups account for the readmission, right? And it's a discharge clinician group, the primary inpatient care provider group, and then the outpatient primary care physician group. So
right.
it is not all.
I'm sorry, go ahead.
Go ahead, Amy.
So like, are not all three attributed for every admission? Do you only do some of them in certain circumstances?
No, what I was referring to was what we called the inpatient, and we use the word primary, but that's not the right word. So think about the inpatient clinician, the person taking care of the patient in the hospital. That was the one I was referring to, where we used the total charges, the amount of charges rather than the number of claims, because we wanted to make sure that the correct physician from the inpatient point of view was being attributed. There still may be also an outpatient person in that case, but there I was talking about the inpatient provider, because what we found was when we used the number of claims, you ended up with potentially a non-surgeon being attributed to a surgery patient when it really should have been the surgeon. And by switching to the amount billed, we ended up picking up the surgeon for surgery cases. It's just an example of how we used face validity to adjust the attribution rules to make it make more sense overall. But with in the case, there doesn't have to be, like, for example, like I was saying, you could have the same person could be a discharge clinician and the outpatient clinician. That's fine to have two of the same individuals.
So I guess, okay, so in the example you gave, so like the primary inpatient care provider would be the surgeon, but then their outpatient primary care physician could be any of their primary care physicians that they see after the admission.
It would be the individual, and it doesn't have to be a primary care provider. It's just any individual who's patient facing, like we wouldn't include a radiologist or something like that, but patient facing specialties that have the most claims in that period. So you'll end up with people who are seeing the patient more repeatedly instead of, so let's say you had a surgery, you went home, and then you were seeing your surgeon maybe 3 or 4 times, but then you also went for an eye procedure, or you went to the ophthalmologist or something. We don't want to pick up the ophthalmologist. We want to pick up the people who are sending the most claims in, the one you're repeatedly going to. So that's the person, and it could also be the same as the surgeon.
And then could it be like a physical therapist, or is it only MDs are included in MIPS?
No, it's not just MDs, it's eligible clinicians. And I'm going to have to ask Shusha, do you know if physical therapists are also included? I will ask, she may not be able to chime in right away, but I'll ask her. I'm not sure about physical therapists, but it's not just MDs.
Okay, thank you.
Thanks, Doris. I'll circle back.
The physical therapist in or not, but we can give you the list. It's based on the CMS 2-letter specialty code. So you can say radiology is not there for sure.
Right.
Yeah. But the registered nursing is there. Registered nurse should be there. Just whoever sees the patient.
So it sounds like physical therapist isn't in there. It's sort of based on how CMS defines who could be in here. Is that what I heard? Shusha, you're kind of coming in a little echoey a little bit. I'm not sure if the committee heard that fully.
We will get back on you on that exact list. That's a long list.
Yeah, she just said we're going to look it up to see specifically if physical therapists are on the list of providers, because there's a whole list of codes that are eligible clinicians for this measure. And so she's just going to look it up. That's all.
Okay. Thank you. Thank you, Shusha. Okay, so answering questions from Paul and Amy and others about the attribution approach, are there other questions, concerns, especially if you're thinking about if this is going to question your or impact your decision for endorsement related to the attribution? Chris, I haven't forgot about your question, so I'll come back to that. But thoughts from the committee, questioning your endorsement or impacting your endorsement decision based on this attribution discussion? And I see Lisa Suter, I know she's from Yale course. She has her hand raised. I'm not sure I can go to her here in a little bit, but anyone else on the attribution approach, especially if it's going to impact your decision for endorsement based on the discussions, based on responses from Doris? I want to hear those. Okay, not hearing any. Assuming no concerns. Okay, let me switch to Chris. Chris, you had asked about some of the risk adjustment approach. Can you please go ahead, Doris, if you wanted to, you had asked about certain comorbidities as oncology, renal, these underlying conditions, if they're sort of included or adjusted for or counted for? in your risk adjustment model?
Yeah, so I believe I was just trying to see which table it was that we submitted. We might have submitted the whole data dictionary to you all so that you can take a look at it. I don't see it here, but I'm sure it was one of our attachments. So I'm not sure if you can bring it up or not, but I will let you know in the risk model itself, we have metastatic cancer, severe cancer, and other cancers. So there's a lot of cancer that's in the risk model. I think this was the question, right?
That's fine. Good.
Right, exactly. We have end-stage liver disease. I think someone asked about mental health. It wasn't clear if they were talking about cohort or about the comorbidities, but psychiatric comorbidity is in the risk model as well, which is a bunch of CCs related to psychiatric disorders. I can read you the list there.
Fine. How about end-stage renal disease? A lot of that going around.
Yeah, I'm just looking. Yeah, renal failure is here.
Okay. All right. That's it. Thank you.
Any others?
No.
Okay.
Thanks, Doris. Thanks, Chris. Okay, and so circling back here on any of these other topics listed here or concerns that committee may have, especially about the mortality topic. We talked about the attribution piece here, but others, either on mortality, I know we have use and usability here. I definitely want to see what the developer has to say there, but opening it up. Okay. Yes, Mihil.
Yeah, there's more question, but do you know how well, Doris, or the measure specifications and the risk adjustment approach align with the ACO readmissions measure?
I think they are the same. To be honest, that measure is another developer, but my recollection is that they are the same risk model. Does I don't know if anyone else on the line knows. It is not a measure under us. It often gets confused with our measure. Which is
so are you saying, Doris, the starting point was the approach for the ACO measure and you adapted it?
It's a good question whether ACO measure came first. I don't know. I was thinking the hospital measure did, but I'm not sure. So we used the hospital level measure to create a respecified measure for clinicians. So we used the risk model from the hospital level measure and then adjusted the attribution approach. And also the risk model itself was changed a little bit, but I'm not sure whether the ACO measure came first, which is how the hospital measure was developed, but we were just used the hospital measure.
Yeah, I think it's true that the ACO measure was adapted from the hospital measure, but you may want to check on the alignment. Is that right, Chris?
Yeah, we try to align where
nodding his
possible. Yeah, and there's, as you know, and NQF used to do this as well, make sure that developers are trying to align as much as possible. So we definitely try to do that as much as we can. And I bet they're using the same risk model as ours. And if I can get one of our staff to find out, if you like.
Yeah, that'd be great.
Thank you. Thanks, Mihil. Was there any major concerns you had here or just sort of curiosity? Mihil?
No, I mean, if they're misaligned, there may be just consideration about alignment in the future. I don't think it necessarily causes a lot of cognitive dissonance, but might, depending on how the performance of the measure might be different. So, but no, it wouldn't affect my vote today.
Okay, thank you, Mihil. I'm going to circle back. David, you still have your hand raised, just calling attention. I'm not sure if that was a leftover, if you actually have a question. Okay. Oh, thank you, David. All right. All right, so others, not hearing anything about the mortality concern or the response here. I did want to touch on the use and usability piece. Again, this is just one element of that domain of our rubric. We've heard some discussions before around the improvement results over time. Anyone have any thoughts on this? And Alice, just recognizing your chat here, there are 3 eligible clinician groups of primary care, inpatient care provider, right? The discharge clinician and outpatient primary care physician. This should not include physical therapists. So I think we're going to circle back on that to see if that's the case. Thank you, Alice. Others on the use and usability piece, any thoughts, questions, concerns? Okay. Again, questioning your ability to continue on with endorsement of this measure. Okay. No, all right. Not hearing any. Okay. Let me circle back just briefly. Doris, I don't know if you found the physical therapist piece yet for your team, if physical therapists were included or not.
I think they are looking still.
Still? Okay.
So we have an answer about the risk model that the ACO measure was based on the hospital measure. So I know there's a lot of confusion about this, but and so the risk model is the same.
Okay.
For the
Great,
ACO
thank
measure.
you.
Yeah, great, thanks. There's also, I dropped this in the chat, there's also an NCQA readmissions measure, so I thought maybe the ACO came from that. As long as there's alignment.
Great.
Thanks.
Thanks, Michiel. All right. Alice, while they're looking for the physical therapist piece, did you want to just elaborate on some of those concerns? Is this something that really is going to be concerning enough for you to question your endorsement? Don't mean to call you out, but just wanted to make sure that's heard. I don't know if you're there, Alice. Okay, not hearing Alice. All right, let me open it up to see if there's any other comments, again, thinking about whether this is going to impact your endorsement decision today.
I'm sorry, I was having trouble getting off my mute. I'm back.
Okay.
So I want to clarify, when I said should not, my point was based on how it's described, I didn't expect physical therapists would be included. But if they are, and I'm looking to see here now what's in the post. Yeah, so it looks like they are included.
Yeah, so these are just all MIPS eligible clinician types.
Yeah,
though. So I don't know if
no.
there is explicit exclusions in the measure that would prevent some of these clinicians from being in it.
And I think based on the way the measure is described and the codes that are assigned to it, it doesn't look like physical therapists would be included, but it's not impacting my vote.
Yeah, because the types of codes that we use for the billing itself wouldn't be one that a physical therapist would use. So yeah, even though they're potentially on the list.
Yeah, and that was my point. When I looked at the codes, it's not codes that are billed by physical therapists.
Right.
Okay, that's helpful.
Thank you, Alice.
Yep.
Thank you, Amy. Thank you, Alice. Appreciate that. Okay. Not hearing anything else. I just wanted to circle back just lastly, Danny and David, others, the access issue, I think that's definitely prevalent with a lot of these types of readmission measures. So, I think what we're looking at is also just thinking about this measure itself. Does this logic model make sense? Does this attribution methodology seem to be appropriate, which I'm not hearing a lot of more concerns here. The testing analysis and how this measure can be used as well. So not hearing a lot of concerns based on that, and that's considering how it aligns with our rubric. The access issue, very, very important. And I don't want to lose sight of that, but Danny, you kind of started this, and I want to sort of maybe see if we can kind of close here. And I did want to maybe potentially propose a condition that we may have heard. But Danny, I want to circle back on you around the access issue. I'm not sure there's much we could do with the measure itself here based on that, but I wanted to see if you had any additional comments on that because you raised it, didn't want to lose sight of it.
Thank you. No, I don't have additional comments. I agree. It's what to do about it. I have no idea.
Yeah.
Yeah.
Well, I greatly appreciate that, Danny. Will CMS communicate this as well? I know there's things that Michiel had mentioned that are going on today, and there's still more work to do with this. Let me at least unpack a potential condition here. It's based on some of the discussions kind of proposing this. So when this measure comes back for maintenance, we would like the developer to explore systemic differences in ED admission versus readmission rates and the potential impact on clinician groups' ability to improve. Amy and Danny, what are your thoughts on that? Is that something based on the discussions today we want to propose as a condition? Thoughts?
Amy, could you comment on that? I don't know.
Okay. Others on the committee? Doesn't have to be.
This is Dave Schultz. I think that's reasonable as a condition to attach that.
Okay.
Again,
Okay.
I think that the importance is how do you identify an area that has adequate clinicians to follow up versus an area that doesn't, because it's not just the rural areas, as we've already pointed out.
Okay. Thank you, David. And seeing an agreement from Daniel in the chat on that condition. Again, just because it's placed on the measure doesn't mean you have to actually vote for it. If you feel like the measure is fine without the condition, you can vote to endorse it. Okay. But it's there for if folks wanted it. I saw Daniel and David thought it was fine. So Amy, Danny. Okay. Amy, what do you think?
Yeah,
I
I think
I think it is descriptive of the conversation that we had. Yes. So I think it's
Okay.
accurate.
Okay.
Yeah.
Okay. Thanks, Danny. Thanks, Amy. All right. Doris, I'm going to turn it back to you. The feasibility of that condition, final remarks on this, and then we'll go to a vote.
Yeah, I think it's reasonable. We can look into these issues. And again, we have to, speak with CMS about it. We are contractors. I can't agree to stuff directly, but certainly sounds reasonable.
Thank you. Again, for the committee, if you don't feel it's needed, you can just endorse without actually having the condition. But thank you all very much for that. All right, let's go to a vote and we'll get into our last measure.
Voting is now open for measure 3495. Hospital-wide 30-day all-cause unplanned readmission rate for the merit-based incentive payment system, eligible clinician groups. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, or remove endorsement. And we are expecting 15 votes. We have 13 in. Waiting for one more. We have all 15 votes. We can move forward.
Excellent, thank you. And thank you to Yale Core, Doris and the team for all the morning and into the afternoon. Thank you very much. Have a great weekend. We'll see you next time.
Thank you
Okay,
so much. I want to thank the committee and Battelle for all your help. Really appreciate it.
Of course, of course. All right, and let's see if we have the developer for our last measure. Do we have a representative from the Lewin Group? Oh, hey, Colleen. Good to see you. Colleen, do you know if we have everybody needed on the panelist side? Okay, great. So let's kick this off. Well, first of all, I do want to check in. Margarita, you're with us? And more.
Yeah, I'm with you, and much like yourself, we're experiencing some thunderstorms. It's that time of the year. So, but so far everything's holding.
Thank you.
I'm here as well, Matt.
Great, thank you. First, for the committee's attention, I know you all have been here on this call throughout the majority of the day, so thank you. I will also mention that Morris and Margarita also serve on our Advanced Illness and Post-Acute Care Committee. That meeting was yesterday, which was an all-day meeting. So them being on here today, I can't thank you enough for your participation. That was definitely a long meeting, as well as with Colleen. Colleen was on that call with her team, and that was also a very long meeting as well. So thank you, Colleen, for being on the call. All right, so let's kick this off. CDE number 4490, hospitalizations for ambulatory care sensitive conditions among home and community-based services or HCBS participants. For the Medicaid HCBS participants age 18 years and older, this measure calculates the state level observed and risk adjusted rates for hospital admissions for ambulatory care sensitive conditions, including select behavioral health care conditions per 1,000 participants for chronic and acute ambulatory care sensitive conditions. So this measure has three rates reported for potentially avoidable acute inpatient hospital admissions, chronic conditions composite, acute conditions composite, and chronic and acute conditions composite. So the Lewin Group is the developer and the steward being CMS. It is a new measure being brought to the committee today. Its intended use here is a public reporting with quality improvement with benchmarking external to other organizations. It's an outcome measure. We talked about the description of those target population in the description. Care setting is hospital inpatient or other, specifically this home and community-based services, and population or geographic area being at the state level. Let's go to Colleen to do her 3 to 5 minute overview, and then we'll go into the discussion topics before we go to Margarita and Morris for their thoughts.
Fabulous. Thank you so much, Matt. So thank you all for the opportunity to speak today about CBE 4490, hospitalizations for ambulatory care sensitive conditions among home and community-based services participants. My name is Colleen McKernan. I'm a managing director at the Lewin Group, and I'm joined by colleagues from Lewin and staff from the Centers for Medicare and Medicaid Services, or CMS. Medicaid HCBS provides participants with disabilities the opportunity to remain in their communities. The type of disabilities covered include physical, intellectual and developmental, cognitive, brain injuries, and those resulting from diagnoses of mental health or substance use disorders. Examples of the services provided include personal care, so assistance with activities of daily living like eating, bathing, or dressing, skilled nursing, therapy, case management, supported employment, transportation, habilitation, which is defined as assistance to participants in acquiring, retaining, and improving self-help, socialization, and adaptation skills, and also respite for participants' unpaid caregivers. The need for services can range from intermittent to around the clock. States have many opportunities for the implementation of HCBS, the populations to include, the services to offer, and the Medicaid authorities to use. So, for example, delivery via managed care versus fee-for-service, the ability to limit the number of participants and or the geographic coverage, and the allowance of self-direction where the participants can hire their own workers and manage to a budget. Earlier this year, CMS finalized the Ensuring Access to Medicaid Services Rule, also known as the Access Rule, which includes important new provisions to promote transparency related to the administration of Medicaid-covered HCBS through public reporting of quality, performance, and compliance measures. CMS developed CBE 4490 for use in state Medicaid programs with an aim of monitoring opportunities for improvement in care for conditions treatable in the urgent care, primary care, or secondary care setting. A measure documenting treatment of ambulatory care sensitive conditions within the inpatient setting will help to highlight social inequalities in access to health across the United States' delivery systems. Participants from lower socioeconomic classes, those who identify with minority, racial, or ethnic groups, and those with inconsistent access to insurance coverage are the most likely to experience barriers to timely and appropriate care. These groups are represented disproportionately within the initial population for our measure. This lack of timely care can lead to exacerbation of disease burden and increase the risk for admission to an inpatient facility. Substantial evidence within the literature demonstrates that hospitalizations for ambulatory care sensitive conditions can serve as a proxy for poor quality care. The communities in which this care is provided generally have a higher prevalence of ambulatory care sensitive diagnoses, further highlighting opportunities for improvement. Participants from middle and lower socioeconomic strata are less likely to access preventative care, more likely to encounter delays in access to appropriate care, and less likely to have a primary care provider or an alternative clinician who is managing their overall health. Studies of data from these populations demonstrate that better, more available ambulatory care can lead to lower hospitalizations over time. Monitoring access to care and, consequently, admissions to inpatient facilities is critical to identify opportunities for improvement, manage costs, and implement public health interventions at the state or managed care plan level. CBE 4490 builds upon measures of ambulatory care sensitive conditions within the general population. All individuals aged 18 years and older who receive home and community-based services through Medicaid are eligible for inclusion in the initial population. Acute hospital transfers, placement onto hospice, and hospitalization for a peri-pregnancy diagnosis remove participants from the denominator. In addition, there are condition-specific reasons for removal from the denominator, for which I can provide more detail. There's a long list. Within the numerator, CBE 4490 reports 3 rates: hospitalizations for chronic ambulatory care sensitive conditions, hospitalizations for acute ambulatory care sensitive conditions, and total hospitalizations for ambulatory care sensitive conditions. For the purposes of today's discussion, our chronic admission rate includes diagnoses of chronic obstructive pulmonary disease, COPD, long-term complications associated with diabetes, short-term complications associated with diabetes, heart failure, hypertension, lower extremity amputation, Parkinson's disease, persistent asthma, renal disease, and seizure disorder. Admissions for acute diagnoses include acute bronchitis, acute heart failure, cellulitis, complicated urinary tract infection or UTI, constipation, dehydration, falls, ketoacidosis with or without coma, malnutrition, pneumonia, pressure ulcers, and sepsis. On behalf of CMS, Lewin performed a series of quantitative and qualitative efforts to assess the CBE 4490 evidence-based distribution of performance, scientific acceptability, feasibility, and usability. And we're excited to speak with you this afternoon about this measure and answer any questions you might have. Thank you so much.
Thank you, Colleen. Great summary. Let's go on to our discussion slide. I'll summarize that briefly and turn it over to Morris and Margarita. So there's three topics that we have listed here. Again, like the other measures, if there's something that's not listed, we definitely have the opportunity to dive into that. Through our advisory group meetings and discussion, there was advisory group members that brought up the question around feasibility. Mainly, they had questions about the feasibility due to the data that were used from 2018 and 19 in the measure specification and testing, and ongoing problems with Medicaid data, raising doubts about the measure's feasibility or consistent type of reporting. And the developer did respond, stating that administrative claims from 2018 and 19 represent the best picture of the hospitalizations as for ambulatory care sensitive conditions when accounting for COVID-19 and capturing a full year of data. So as 12 months of the 2022 claims for Medicare and Medicaid populations are not yet available. And newer data will be used to calculate the state level performance later this year as well. So reliability and validity. So from the staff assessment and also our recommendation group, there was some, the topic of reliability came up as this measure is really reported in the form of observed rates over expected rates. So the risk adjustment accounts for those differences between entities. So the reliability of this measure, as it will be used is likely less the reliability of those observed rates. Again, what we're seeing in the reliability of the observed rates, not with that rate observed over the predicted. So one method that was mentioned in the staff assessment was just to do a split half reliability testing, which should use to estimate that reliability of those observed over expected values. Also with validity, from the staff assessment and the recommendation group. So the face validity results were done on the denominator population. So the developer did conduct face validity using a technical expert panel, but only did on the structure of the denominator and the eligible population. So this accountable entity level is really the state. And so the claim here is that are there some variations in that the score itself is meaningful to assess quality due to some of these variations that are going on in the states. So that was something that we drew out because the face validity didn't seem to get to that meaningfulness of that score. Overall, the developer, what was stated in the staff assessment is could potentially explore a further robust logic model and some additional literature review to support some of the face validity analysis. And the last piece here, maybe I'll definitely turn to our SMEs here to maybe speak to some of the variation in these HCBS services. This came from our advisory group. There was some question and concern about the definition of HCBS services that is used in the measure, noting that it's not clearly specified and there's variation in those types of services across states. And so there could be some discrepancies there. So let me open it up to Margarita first and then Morris. And thinking about for the this committee's input and information, what about these variations in HCBS services? Is this somewhat like a concern with these types of measures based on the advisory group input or not so much, and anything else you'd like to add? So Margarita, I'll start with you and then go to Morris.
Sure, and I want to be sure and give Morris sufficient time. So just very briefly, this is an extraordinarily vulnerable population of older adults that we're dealing with. And if you are experienced in the Medicare home health benefit or the Medicare hospice benefit, let me assure you that this is nothing like either one of those. This is an entirely different situation. and so you are not dealing with regularly visiting RNs and social workers. They have an entirely different staffing system. It is really behavioral health in the home. So this is really the nexus of this work in occupational training and vocational. And so it's a very different component. They have medication assistance. They have aides, that personal care aides, but they may not necessarily be CNAs. And there is variation state to state to state, because every state has the ability to set up their particular program. So, the amount of hours devoted to a particular program or a particular service may differ state to state to state. And I'm going to stop there because, Morris, I think you were much more involved with the reliability and validity discussion.
I think I might have been, Margarita, but honestly, I wouldn't mind hearing more about the details about the clinical differences of the HCBS population.
Sure.
So go ahead.
So in an IDDD, let's just take the IDDD program, for example, that we would have chronic problems. These are individuals that often live either in a group home or they're like a bed and board almost. So there may be issues where if they don't follow the rules of the home, they're going to be shifted to another home. Well, there's equipment transfers, there are medication issues. Then you're also dependent on getting the medication into the hands of that particular individual. If they are discharged from an ambulatory setting or from a program and they move back into their home, but they don't have their medication with them, there's nothing that says that they're going to show up at the pharmacy, if there is a pharmacy within 10 miles and the bus route goes that way, that to pick up their meds, because there's only so many pharmacies that will fill the Medicaid prescriptions. So there's some issues there. There's also issues around trust. And since this is a paper and this is a phone interview, they're not necessarily going to open their mail, nor are they going to stay on the phone. There's not a lot of trust there. It takes time to build that trust. And so it's challenging, but we know, those of us that are privileged to take care of older adults in their home for a variety of reasons, that this population is growing exponentially in numbers every day, because these are the people that in the 60s and in the 60s and the 70s, were heavy smokers, and they continued. And when they hurt their back, that was a time when we medicated to the pain level. And so many of them are dependent on opioids. And now it's evolved into a whole other issue. And I'll stop there because really you don't want me going on.
Thank you. No, it's okay, Margaret. Thank you for sharing that. And let me pose this to you. There's other HCBS measures that we've evaluated, especially in the Advanced Illness Committee. I mean, these variations that you've described, I mean, is it causing you any concern with respect to a measure like this, or if you like to share anything about that?
I would just tell you, I think the consideration that we put in is a good first step. I truly do. Okay. We need to at least make a step forward and let that step teach us.
Thank you, Margarita. That's helpful. Morris.
Yes. Yeah, part of the reason I wanted to give more floor to Margarita is because I think the clinical context around this discussion really ties into some of the validity comments that Matt had made when opening up the discussion, because what we're really trying to do here, kind of at a big picture level, is assign some sort of quality attribution to HCBS plans for outcomes, for readmissions, either chronic or acute, and you can definitely attribute it to them because these are HCBS beneficiaries in those plans at those states, so it's definitely attributable. But what you really want to know is can we or can the HCBS administrators for those state plans actually implement initiatives to make the quality better, to improve performance? And so that's really a clinical question. I think it really depends on having a more robust logic model. This is a request I'd made yesterday as well, so Colleen's probably familiar with it, but I think really digging into the logic model, explaining how the state administrators can implement programs to improve a very specific and very complex, needy population is going to be really important for maybe not this round of endorsement and review, but certainly for future rounds. We need to be seeing that this measure, that the gap is closing, that it's usable, that administrators are doing something that seems to be working. I mean, that's the point of this whole process. So that's a critical component. As far as the reliability goes, Matt, you kind of took the wind out of my sails. I was going to recommend split half as well. In general, I've found when I do the Adams reliability testing, I think it's the parametric assumptions around the beta and binomial distributions. It tends to give me better numbers. And always in this type of world, I like to sandbag my numbers. The split half tends to do that a little bit better than some of the others. That's not a universal truth, so I can't, I don't want to say it, but at a minimum, I would like to see both if you're going to show me the Adams beta binomial test. One thing, and I think this is going to be related to data availability, is the risk adjustment period. You're losing 20% of your sample by looking back 18 months for this population. This is a Medicaid population. I don't know if churn is an issue here. It's certainly an issue pre-COVID, and so I'm a little bit worried that you're losing people just because they're bumping in and out of the system. And I would appreciate it, possibly even as a condition for endorsement, if you would explore shrinking that look-back window to see if you can improve your sample size. And then lastly, I think Matt said this, I couldn't find it when I was reading it, and this is really a subtle point, but I never saw the measures specifically outlined to say that the risk-adjusted value is equal to observed over expected. I looked for it. I could have easily missed it. I miss things all the time, but I'd appreciate it in the next submission if that's made abundantly clear. And you feel free to confirm on the call. Those are the things that caught my eye. So yeah, at this point, I think take the floor away.
Thank you, Morris. Thank you. Good point. I definitely want to. We also recognize that Colleen has also a subject matter expert on the call too. And Colleen, there'll be time for us to go to some questions here and refer to you and others on your team. Definitely. I want to open it up to our patient partner here. I think Dana, you're still the one that on. This concept, this measure, this area, home and community-based services, hospital admissions as well. Thoughts from you, Dana?
Well, thank you. Well, it so happens that I have quite a bit of experience here. I spent about 5 years as VP of Quality for an organization in Massachusetts that supported 23,000 such people. And it was a very interesting challenge. So I have nothing to say about statewide comparison. What I know is what we did in Massachusetts. I know that there was, yes, this is a lot of work. And and we are in a state, Massachusetts is in a state that's very supportive of this. And that we found a considerable neighborhood variation because, where the group's homes were, or if there were people that were living at home where we were supporting caregivers. And I would say I like that this is Medicaid 18 and older, because this is so not just a elderly issue. This is like every age. And we found that the neighborhood support of people, the relief that, caregivers could get, from their families and from their neighborhoods, their neighborhood neighbors, was an impact, had an impact on well-being. The public transportation that was available locally, was, and those were mostly like not the subway and the tube, but the ride, that the van, a van would come, you call a number, a van would come. And it was also and
Danny, I don't mean to cut you off. I'm curious though. You're wearing many hats, as you say, many hats. I'm curious, and when you're working in this area, and to Norris's question, are there things that these services can do to prevent these hospitalizations? From your prior work, and I know it was years ago, but was it, in your opinion, are there things that these services and these providers can do to prevent these hospitalizations of these patients?
Absolutely.
Coming back to
absolutely. Yeah. I totally support this measure, whether it's perfect or not. I'm just sort of delighted that we're looking at this, and then we can get some data and criticize. But yes, there's a lot that can be done. So I think this is useful information. I don't know anything about comparing between states. Like, that's where I have no idea, but it would be useful in the state locally.
Yeah. Thank you, Danny. And no, thank you. And also drawing attention that there are some social determinants here that obviously impact ability with this patient population as well, both positive and negative, like you had mentioned, Danny. It's great to call that out. Let me open it up to the committee here for questions here on any of the topics, but maybe what Danny was mentioning, or Morris or Margarita, and then we'll sort of triage from there. So Chris, see your hand raised, and then Alice.
Yes, this is very interesting. I wanted to briefly chat with Margarita, and I sensed from your delivery that this is a necessary first step in addressing what is a terrible wide chasm of need here. Can you just say yes or no to that?
A qualified yes.
Okay, that's cool. And Danny sort of addressed it. I'm really less concerned about, well, gee, how are we going to solve it? But I happen to think that this will shine a light on an issue. And I think it was Harry Truman who said, how do you solve an insoluble problem? You make it bigger. Okay, this can really help. This is going to be an iterative process, I think. So I just wanted to get a sense, because I'm involved, and my family's engaged in delivering services to patients, and I keep hearing about how terrible things are, and able to and the ability to deliver them and carry through. It's just this is a good start. That's all I wanted to address. Thanks.
Thank you, Chris. Appreciate those comments. Alice, I'll go to you, and then Dimitri and Paul, I see your hands raised, and we'll get some of the discussion before maybe going back to the developer or our SMEs. So go ahead, Alice.
Thank you. And I agree. I think this is a really important step and a movement in the right direction. The question I have is, given that there's a high degree of variability on both, on a couple of different, in a couple of different areas. One is what these programs actually include in terms of the types of services that are delivered, not just state to state, but even program to program within some states. And then there is a high degree of variability in terms of the conditions that fall under those acute and chronic conditions, and what services might most likely impact reducing the risk of hospitalization for those different factors. So my question is, as you parse the data when you're looking at this measure, will there be a way to start to kind of deconstruct the services that are offered in these programs against the conditions that are being effectively or ineffectively managed, and better understand how you create a model that you kind of how you create the recommended model that links to the prevention of different risk mitigation or different risk factors. I hope that makes sense.
Yeah, I think it does, Alice, and sort of drawing attention again about, you know, what can these states do, but also like if they're given this information, reporting this information, can they sort of drill down and identify, you know, where there's the conditions that we can create programs around to reduce the risk, where there's others that may not be. Is that a sense of what you're getting at, Alice, or did I?
Yeah, it's kind of like I mean, this could be a tremendous opportunity, right, to learn, for states to learn from one another, and also for us to better target where the true gaps lie, because we might be managing some things really well based on the service offerings and other things not well at all. And so when we lump all those acute and chronic conditions together, I worry that we might not have a pure picture of where we're being successful and where we're still failing.
Great, great comments as well. And this is a new measure. So, you know, one question I'll go to you, Colleen, in a minute. Is, you know, when do you expect this to actually start to be used, to start to see some of these types of results and reporting these types of reports maybe to states? I'll circle back on that because of Alice's point. But let's see, Chris, I think your hand might be still raised, or I'm not sure if that's new, but I'll go to Dimitri and then Paul.
Thank you, Matt. I have a clarifying question, I suppose. When Morris was introducing the reliability of the measure, he mentioned that the reliability was calculated, the approach that is described in Adams, I believe it's 2009. I am wondering if, Colleen, you may clarify whether you used the beta binomial approach for this measure, or if it was just a broader signal to noise approach. And depending on your answer, I may or may not have a follow-up question.
Okay, I'll go to Colleen on that one. Dimitri here in a bit. So thank you, and then Paul.
Thanks. So, you know, as I think about this, I think that, you know, the fact that it's a comparison between states, you know, I have less concern about the differences in services provided, because I think part of what you want to see is, I think like Alice was kind of saying, is that, you know, this allows you to compare states, and you can go in and say, who are the best practice states, and let's try to see what they're doing and what's working well, right? My bigger concern is the state, how the variability, the ability for people to qualify for both Medicaid and the HCBS vary by state, right? So if one state is doing really well, is it because they have easier patients, you know, or just patients that are less likely to be admitted to the hospital? And how can that be, you know, the variance, not in the services provided, but in the ability to qualify for these programs, how that can be, you know, potentially adjusted for or dealt with.
Great, thanks, Paul. All right, so we got some questions here. Any others from the committee on these questions? Anyone else want to add anything to this before I go to the developer on a few things? Okay, maybe we can start with that clarification question with Dimitri. Colleen, to see if we can get that one addressed, and then I'll go to one of the others here. If you want to answer about the reliability, he was asking about the signal to noise approach you used from Adams. Was it a beta binomial or something else?
Yes, it is the beta binomial model.
Okay, and Dimitri, did you have a follow-up?
I do. I believe that this measure is risk adjusted, right?
Yes.
So
yes, it is.
So for each patient, presumably the score is not going to be a binary 0-1 score, will it?
We're going to get into a point where I cannot answer the question. So I'm going to defer this to my colleague Vivian to answer from here.
And Dimitri, do you maybe elaborate where you are thinking about this concern or question?
Yeah, the question that I have is the beta binomial method is appropriate for the measures that are binary at the patient level. For example, did or did not a patient have a follow-up? The measures that are risk adjusted typically end up calculating a continuous score at the patient level. It's the ratio of the observed over expected score. So I'm just wondering if beta binomial is an applicable framework for this type of measure.
So
When I
the
go
note
back
that
to
I
the developer.
Yep.
Oh, sorry,
Thanks,
Colleen.
Matt.
Other methodologists on the committee share similar thoughts or questions as Dimitri around the beta binomial model and the risk adjusted measure. Okay, let's go ahead, Colleen.
So it does account for the variability between the providers. And so if we say the entity that we're measuring is the state, so it looks at the variability between the states. Again, I'm going to need Vivian to jump in to provide additional detail on this. She's our methodologist for this measure.
Hi, Dimitri. Thank you, Colleen. Hi, everyone. My name is Vivian Bazad, and I'm on the Lewin team for measure testing. Thanks so much for your question, Dimitri. Yes, it is an appropriate approach for us to do for the beta binomial versus signal to noise. The binomial model is usually used for accounting in the variability between providers. So it does make it very suitable for assessing the provider level reliability. When using signal to noise, in contrast, that usually measures the proportion of observed variance attributable to true differences between various providers. Though that is sometimes a more straightforward interpretation for reliability. For this environment and this population of providers for HCBS ACSC, it is definitely much more appropriate for us to be using the beta binomial. And to answer your question earlier too, it is not a binary result provided.
Right, and this is
sorry, Dimitri, I was going to mention too. When we called out our reliability for the staff assessment, it looked like the developer did reliability on the observed rate only, and not the observed over the expected. Yep, and so we had recommended doing a split. We had recommended doing a split half on that. If that helps answer that question.
Yes, it does. Thank you, and thank you, Vivian. Yeah, that level of detail does help a lot.
Okay, and Dimitri, thoughts on the split half approach?
There's a very recent paper, I believe, in the Health Services Research on split half as opposed to other methods. I mean, it's a fine method. There's better methods, but it's a perfectly appropriate reliability, methodology for calculating reliability. So, I'm not going to argue with the classics, I suppose.
Yeah, that's great. Yeah, and I believe that was an SMT member that wrote that paper, Alex Sox-Harris. So thank you. So got that question out of the way. Maybe I can go to Paul. Paul's question as well. There, Colleen. You had less of concern about differences in services provided, but just wanting to see what the ability for, I guess, to qualify by a state. I'm not sure if I got that correct, Paul, but could you mind restating that? Your question?
Yeah, just the different rules states have for who qualifies both for Medicaid and for HCBS, and how that complicates things.
Sure, Paul,
Colleen?
for that, we have a subject matter expert on our team on HCBS on the phone. So Lisa, I'm going to have you jump in here.
Hi, Lisa Alexi. Yes, it's an issue, and it's inherent in Medicaid, and there's not a lot we can do about it. But by using a risk adjustment approach, I think we are accounting for some of the variability that you might, have at a managed at a plan level or a state level related to this particular measure. All of the for individuals with physical disabilities and older adults, they all have to meet a nursing facility level of care, and states can define those differently, but it is, kind of at least all in the same ballpark. And on intellectual and developmental disabilities, again, there's probably varying levels of ways that states determine that form of disability and the way they define it. But again, they're, within a reasonable ballpark of each other.
Thank you.
And and then the like income thresholds for qualifying for Medicaid too, which can, I guess, is that something that you would have data on to be able to make adjustments for that, the different
the income variability, that if you're talking 100% poverty level versus 120% poverty level, you're not, I don't consider that substantial in terms of who you, it affects, if you had the universe of people who might be potentially eligible and those who actually qualify, something along those lines. But this is among people who have engaged and qualified for services. And so all vulnerable, all low income, slight variations amongst the states in terms of the amount of income, but generally, it's somebody who's on either Social Security disability insurance or supplemental security income, which again can vary by state, but we're not talking about huge variations from state to state. It's, $100 a month or, in that range.
Okay.
The other note I'd make there, Paul, is when we do see variability in eligibility for the ceiling for income, states that have higher cost of living generally have higher ceilings. And so it actually helps us to get us closer to what the population looks like across states, because if Massachusetts has 400% of the COLA versus, Alabama having 100%, the cost of living in those states are different. And so it does, while there could be variation, there's also cost of living variation that's accounted for.
Right.
Thanks.
And generally
Thanks,
it's not
Colleen.
100 versus 400. It's like 100% versus 120 or something. Yeah.
Yeah. Thank you. Paul, did you have a follow-up on any of that or anything that was sort of concerning you wanted to touch on?
Just saying thanks. Yep.
Okay, great. Dimitri, I see your hand raised. Was it about what Paul was mentioning, or maybe reliability or something new?
No, it's actually that I forgot to lower it. Sorry about that.
Oh, okay. No, it's okay. It's okay. I may come back to you, Dimitri, about the reliability piece, but at least for now, I'd like to move on to what we've been hearing about some of the other discussions that we have had about. Read my own notes here. Sort of how these states can really. It's Alice's comment, was others sort of touching on too. How can states really deconstruct these services and these conditions? And I tacked onto that, Colleen. When this measure might be used to start these states maybe start seeing this information to maybe dig into that.
Yes, thank you for the question. Yeah, so this measure is new, and so the buckets of acute versus chronic have been created to keep in alignment with other measures that exist. If there were a need to parse the data to provide more granular information about specific conditions, certainly that's something that we could consider. For related to use, I think we're super close. It should be going on Medicaid.gov this month or next month. And so this would be a measure that, similar to discussions we've had earlier this week, made available for optional use with potential additional requirements being considered for the future.
Okay, thank you. Alice, coming back to you or others related to that, any follow-up?
No real follow-up, just to say that, I would just strongly encourage that as we continue to look at the data, that we be able to do some level of that deconstruction.
Great. Thank you so much, Alice. Okay, and others on any of those topics? Again, is there something that's starting to question your endorsement decision? I think we heard a lot from our patient partner, Danny, thank you, our SMEs, even some members of this group who have some experiences in this area. This is an important area. There's a lot that may be needed here on quality. So recognizing the importance of this area, but there are a few additional points here that were discussed that our team is kind of considering potentially as conditions. But Amy, and then Michiel.
Yeah, I think someone had talked about this earlier, just like a little bit more on the logic model. So like essentially this will be like a publicly reported measure at the state level. But I guess like a lot of our measures are like provider driven, where providers guide their own quality improvement projects, things like that. So I guess like from the perspective of the developers, like who do you see driving the change and the improvement?
Great. Thank you, Amy. Great question. Who do you see driving that change and the improvement? Again, drawing attention to the logic model. I think we kind of heard that as also from Morris. Michiel, and then I'll see if there's others, and we go back to Colleen.
Yeah, it might be related, but so who is the intended audience for this data? Is it consumers? Is it Congress? Is it others? Yeah, what is the logic model? But also, is the intention that this gets down to like MCO level or within state regional level at some point and used as an accountability measure? And then related to that, what is the data source for this? Is this TMSIS? And any concerns about variation in quality across states actually driving the variation in performance?
Okay,
I had the
thanks,
misfortune
Michiel.
of working with TMSIS a while ago, and I know it's been a slow process to get it better.
Thank you so much. So asking about the data source, asking about the variation across states, and is that challenging for comparing performance? Talked about who's the intended audience, as well as Amy's question as well around the logic model element also. Any other questions? Okay, Colleen, maybe we can start with the logic model, both Amy and Michiel.
Yeah, so Morris, with whom I spoke yesterday, encouraged us to have a stronger logic model for future submissions of measures that we discussed. And I think that the same point has been made today. Certainly when we present our, should this measure obtain endorsement, the granularity we provide in the logic model will be enhanced so that we meet the standard that he has set. And so related to several questions about attribution and quality improvement, we see this as a public health measure. This is state level, not provider level. Attribution for a measure like this is complicated because there's a number of providers who feed into the experiences provided to participants. And so the benefit of having a measure at the state level is it allows the audience that we were currently targeting, Medicaid offices, administrators, staff working specifically on HCBS, but just more broadly on the Medicaid side, giving them the information necessary to see that this population, for which all of the groups that qualify for HCBS are disproportionately vulnerable compared to other individuals who receive Medicaid. So giving this vulnerable population data specific to the care that they're receiving in the community, and giving them opportunities to provide additional resources to access urgent care, primary care, secondary care. There's a lot of data out there on care coordination and support that's provided for wraparound services for varying populations. And so building in quality improvement initiatives regionally, statewide, really making sure that the HCBS population is receiving a level of support to encourage shifting the acuity at which their care is provided down so that they're accessing treatment from a primary care provider, from a cardiologist, from a pulmonologist, rather than letting their condition get sufficiently bad that they end up being admitted to the emergency department. The suggestion about regional evaluation is interesting. Thank you. We do have information on rurality versus urbanicity, but we don't drill down to state regions at the way the data are currently structured. And other measures on which we have worked do provide information about the managed care plan in states for which there is either hybrid delivery of fee-for-service and managed care or managed care exclusively. We don't have that level of detail currently, but again, another great suggestion for us to consider as we parse out these data when the measure starts to be used.
Great,
Can I
thanks, Colleen.
jump in real quick here? Just
Sure,
on the thought of closing the gap and what can states do. So the people who are who are providing these services are in people's homes on a regular basis. Training them to be able to pick up on signals and signs of something that might be problematic. They don't need to be clinician. They don't need to, they just need to know, okay, if their ankles are swollen, or if, some sign that things are going downhill, they can be the eyes and ears to get to the primary care physician in time rather than having to go to the hospital. So that's kind of the thought, I think, behind, trying to get to these things that ambulatory care sensitive, eyes and ears in the home could potentially. And so states that undertake either requirements that, direct care workers have certain training in order to be able to do that, or encourage their providers to make that happen, I think is where there's great potential for having these measures, knowing what states then do, and then seeing if they have an impact.
Great, thank you. Thank you for that. Mahil, you have your hand raised. I think circling back,
yeah, no, just any comments about, hey, maybe it's the quality and completeness of the TMSIS data that's actually driving the performance variation. And, there used to be, like, I think CMS published like scorecards of TMSIS data quality, and maybe that's a good thing to circulate with the results.
Matt may answer
Colleen,
that question. Thank
yeah,
you.
Please go ahead.
Yes. So TMSIS is an evolving source of data. And we know that as time goes on, the data quality has improved. So we use the Data Quality Atlas as a tool to drive whether the variables used in our measure were of sufficient quality for inclusion in our analysis. There was one state for which the data quality was not sufficiently high for us to be able to feel confident in reporting those numbers. Also, two territories for which there weren't enough data. But the other states, for the variables necessary to calculate the measure, the Data Quality Atlas gave us sufficient confidence that the data were accurate enough for use. But we agree that, TMSIS gets better every year, and the quality of the data hopefully is going up over time.
Thank you, Colleen. All right, I do want to try to wrap this a little bit up, but I do see Alice, your hand raised, so I'm going to again call attention to any of these other topics that haven't been addressed for you, that questions your endorsement, or you're still not sure where to go. Please go ahead and raise those. The team is sort of drafting up potential conditions related to some of the discussion we've had, considering some things around face validity, logic model, reliability testing. So we'll propose those. So if you feel like that's not resolved for you, we'll lay out the conditions and see if that makes sense. But any other new topics? Alice, I'll go to you.
Thanks, and I'll make this real quick. And is there a way through this measure, I'm thinking this kind of a concept of network adequacy, for lack of a better term, to get a sense of, under these models, how quickly are individuals able to access what is purportedly being provided under the model, and where might there be kind of an inability to meet the need, even though it's described within the model?
Colleen, I'll go to you to answer that.
Yes, thank you. Alice, that might be too far out of scope for what we're hoping to accomplish with this measure, but our CMS core and others are on the phone, and so it's an interesting idea. And so I don't know what could be accomplished, but they're hearing it. And I think that network adequacy is a great opportunity to identify if the individuals receiving HCBS in our measure are in a location where they can access pulmonology, or they can access nephrology, or whatever the ACSC that they're qualifying for this measure, if they can get a primary or secondary care provider there. So thank you for that.
Thank you.
Great. Okay. Lastly, I did forget one item, and Morris, you brought this up, and Colleen, I'd like to see your thoughts on this. It's just that his comment around reducing that window of time for 18 months helps maybe improve. I think, Morris, you mentioned the sample size, but also with this risk adjustment, you raised a risk adjustment flag there, and maybe think about that 18 months and reducing that. Colleen, thoughts on that?
Yes, so we tested that. We tested 10, 12, and 18 months. Unfortunately, when we used the shorter period, our model was less stable. We could work on some additional sensitivity analyses, various imputation techniques, but really the only way we could get the accurate data about the history of admissions and ensure that we had clean enough data was to use 18 months. And that was supported by our technical expert panel. We acknowledge that having 20% of our population fall out is not ideal. And so improvements in the future, I think refinements are a great suggestion. About at 10 months, it was about 12%. So we're still losing a lot of people, but it is something at which we could continue to look to see if there is a value between 10 and 18 that would be usable.
Thank you, Colleen. And others on the committee, and I'll go to you, Morris, to see if you have follow-up. Others on the committee have any follow-up on that? Okay, Morris, do you want to chime in?
Yeah, just quickly. I'm glad you looked into it. I think it would be helpful to just kind of keep that on your rolling technical expert panel docket and keep on looking into it as you get new data. But yeah, very glad you looked into it.
Thank you.
Great, excellent. Thank you, Morris. All right, I will see if there's any final topics on here, any final comments, questions, any concerns you need to have answered to vote here. Okay. All right. Okay. So we heard quite a bit here today, just thinking about the logic model piece, as well as some of the face validity testing. Remind the group, the face validity was really just done on the eligible population, so that denominator. So the questions that were asked of their TEP was really focusing on that eligible population itself and not really looking at that logic model, but we've been hearing a lot of really good discussion and suggestions related to the logic model. We also been hearing some things about the reliability testing as well. So just thinking about how to recalculate the reliability here and considering the age of the data that have been provided here. Some of the developers' responses, it looks like they might have the 2022 claims at some point in time. But again, the 2019 is also a time frame that we may want to revisit as well. So proposing to the committee that when this measure comes back for endorsement, and in this case, thinking that endorsement would be 3 years, or maintenance, excuse me, would be 3 years, the developer would recalculate the reliability and observed over the expected rates using the appropriate methods, one of which we stated, which was the split half, and evaluate face validity, specifically addressing whether the measure distinguishes quality. That's getting to that logic model piece. What are those activities? What are those things that the states can do to actually improve that score and that variation, and then provide that robust logic model at the HCBS plan level to illustrate areas of improvement. So again, recalculating the reliability on the observed over expected rates, evaluating the face validity, and then providing that robust logic model. Those are sort of three there. Kind of the face validity kind of maybe can fold into the logic model piece. Amy and Daniel, any thoughts on that? Did that capture it pretty well, or did we miss something?
I think it captures those conditions well.
Good.
Thank you. Danny, you're good? Okay.
All right. Yeah, I thought that those conditions seem reasonable.
Thanks, Amy. And thanks, Daniel, as well. Okay, Colleen, I'm going to turn to you. Given some of the face validity pieces that we've been talking about, and the data being 2019, putting it at a 3-year as opposed to a 5. Feasibility on that is, I know you have to connect with CMS, but that would be a proposed condition on this measure.
Yes, so all the 2 conditions you described, 2.5, that you described are reasonable, and they would fall under the umbrella of comprehensive reevaluation for the measure anyway, including newer data as well. And so I don't see a concern with it. Obviously, CMS, our contract is ending. CMS will have to fund this under a new contract, and then a new contractor will have to execute the work, but I don't think it will be a problem.
Okay, all right, thank you. Okay. Any final comments, Colleen, before we go to vote?
So this is the only new measure that we've presented this week. We've had some other maintenance measures that where we've had them in the field for longer. And so the suggestions that have been made today have been tremendously helpful for us to think through prospectively. How can we use these data? If there's any ways as we get through comprehensive reevaluation that the measure could be refined to make it more usable. And so I just want to thank the committee for the feedback that you all have provided. We really appreciate your perspective on this measure. Thank you.
Thank you so much, Colleen. All right, so going to a vote again. If you agree with the conditions, you can vote for those conditions. If you do not think the conditions are needed, you can vote to endorse. Or if you think that the measure, even with the at this current state, even with these conditions in place at this time, you don't think it should move forward, you can vote not endorse. Isaac, I'll turn it over to you. And I don't think we were able to get quorum, so apologies, Colleen. I know you've been on the call witnessing that as well. But Isaac, I'll turn to you to confirm.
Voting is now open for measure 4490, hospitalizations for ambulatory care sensitive conditions among HCBS participants. Based on the evaluation of this measure, please indicate your endorsement decision. The options are endorse, endorse with conditions, and not endorse. And again, we're expecting 15 votes. We have 13 in. Waiting for the last vote. David, are you able to send in your vote? David, we're still waiting on your vote. If you're having difficulties, you can send it to me directly in the chat. All right, we'll work on the back end to get David's vote in, so we will leave the vote open. In the meantime, we can move on. Matt, I believe you're on mute.
Thanks, Isaac. Colleen, thank you so much for your time today. Thank you for your team as well. That'll complete that. We'll follow up, obviously, with the voting results once we collect those offline votes. So thank you. Also, thank you to Morris and to Margarita as well. Long day for you yesterday and being on the call today. Greatly appreciate your input. Thank you so much for your time as well. I'll just pause here. This was an agenda item. We do have a little time, but we can definitely move past it if the committee doesn't have any additional things they'd like to state about the measures that we reviewed today. Recommendations, suggestions. I'll just pause. If anyone has any, raise your hand. Okay. Oh, go ahead, Mihail.
Yeah, super quick. There's the sort of discussion of whether SDOH should be incorporated into risk adjustment models. I think it'd be great if PQM kind of thought about, should there be a standard methodology by which that's assessed and a decision is made? I know in previous years we talked about, oh, the variables don't improve the model fit, so that's a rationale for not including them. But to my mind, it's like really, would a model developed by SDOH putting the variables in first amongst providers? So I know it's optional, so it's not really a voting consideration, but I think clarity on what the right approach is across measures would be good. Because it's sort of like saying, okay, the clinical variables really take care of the risk and the SDOH variables don't add to that. And that's really saying, SDOH doesn't carry increased risk beyond clinical risk. And that's sort of counter to policy and direction here.
Thank you, Mihail. Appreciate that comment. Looks like Sunny agree with Mihail. Thank you for that. So thinking about how we can pick that up and give some more guidance or standardization. Thank you. Any other thoughts or comments in the proceedings today? And once, twice, 3 times. Been a long day. Okay. So let's go to the next slide. Isaac, we can summarize our next steps.
We will be publishing a meeting summary on August 30th containing endorsement decisions and rationales, and that will start the 3-week appeals period during which any interested party may request an appeal regarding any endorsement decision. The appeals committee will be meeting on September 30th, and this meeting is open to the public. Around October, November, we will also publish the final technical report. I'll pause here to see if there are any additional questions. Hearing none, I will turn it over to you. Christopher, I see your hand raised.
Yeah, well, just a general question. Once you get all the votes, you'll let us know by email what the result was?
Yes, once we collect all the votes, we'll be sharing the results to the committee.
Cool, thank you.
Are there any other questions? Matt, I don't see any other hands raised, so I'll turn it over to you for closing remarks.
Okay, thank you. Appreciate that. So let's go to the next slide. I'll just draw attention. You see a list of names here. These individuals, some of you on this call today, obviously are, your term was this 1 year as we launched this and randomized you into 1 year, 2 year, 3 year terms. So this cycle concludes that first term for you. So you'll be rolling off unless you reapplied and be nominated to serve on this committee or another. I just wanted to thank you. The whole team wanted to thank you, especially for your engagement today. As you saw, attendance is very, very important for us to think about quorum. So thank you for those that were on the call today, and thank you for your participation both from fall into spring and the changes we've made. We do welcome feedback. There'll be a feedback survey we'll send out to committee members. We want to hear from you to see what else we can do to try to improve and change, but thank you very much. And I'll also draw attention to our 2 co-chairs today. We have Danny, who stepped in really last minute to be our patient co-chair, and Danny did a fantastic job. Thank you, as well as Amy. Amy, also great job. Very much appreciate you sticking on with us from fall into spring. Thank you both very much. They are also going to be stepping down at the end of this year. Danny, obviously, on this list of his term actually ending, just because we're going to be getting some new co-chairs every year. But I just wanted to thank them for all of their help, support, and guidance as well. And with that, Danny, Amy, would you like to send any remarks before we adjourn?
Thank you. This was a hoot.
Thanks, Danny.
Thanks to everyone for your active discussion and participation. When Doris said, she's a nerd who reads MedPAC, I've never felt more seen. So same. I think we're all here for these thoughtful discussions and really getting in the weeds with the measures. And also just huge thanks for measure developers for all the work they do to prep for the calls.
Thank you, Amy. All right, we'll go to the last slide. Just a reminder, if you have any questions, pcmsupport@battelle.org. Again, big shout out and thank you to everyone, including our developers and the Battelle staff for all the work that they did leading up to these meetings this week and last week. This is the 5th and final one for us. So thank you all. We will see you all next cycle. Have a great weekend.
Thanks, you too.
Thank you all.
Well done, everybody. Take care.